So a very good morning to one and all. It is my honor and privilege to extend a warm and heartfelt welcome to the third edition of the ART Fertility Clinics Annual Conference 2025 in the financial capital of India. This year, our key theme is Lab to Life, reflecting our commitment to bridging cutting-edge research with real-world fertility treatments. This conference will showcase the latest clinical advancements and research in assisted reproductive technologies while highlighting unique approaches and treatments in reproductive medicine. We are also thrilled to bring together top international and national faculties addressing women's health. Experts from across the globe are here to join us today to share their insights and expertise. Together, we will address the most important facets of fertility treatments, that is, embryo as the seed, uterus or endometrium as the soil, and the lab as the surroundings. We will also explore personalized approaches and evidence-based practices that offer new learning to us all. Most importantly, this conference provides a platform to exchange knowledge and ideas in this continuously evolving field of reproductive medicine. We hope this gathering offers all delegates and participants a stimulating, insightful, and enriching experience. So thank you again for being a part of this incredible event. To start off, I request Dr. Geeta Balsarkar, ma'am. She is the secretary of Mumbai Ops Gynae Society, and she will be representing the Mumbai Ops Gynae Society today. She is here with us to share a few words. Over to you, ma'am.
I should thank the ART Clinics today for having this particular conference in association with Mumbai Obs and Gynae Society. We are very, very privileged to do this particular conference because our theme is from adolescence to senescence, and this particular theme exactly fits into the middle. And I'm so happy that the topics that are chosen for this particular conference are all very futuristic, and they have a great, great practical approach in life. I'm happy to invite all the faculty from far and near, and there are a lot of Mumbai Society people here already in the audience. Dr. Amit Patki is there, who is the past president of Mumbai Obstetric Gynec Society. Dr. Rajkumar Shah, Dr. Sachin Dalal, Dr. Ganpat Sawant. We have so many of our members here who are participating, and the program looks really very interesting. And on behalf of Mumbai Obstetric Gynec Society, I extend a warm welcome to all of you here to participate in this particular program. Also, for those of the Mumbai Obstetric Gynec Society here, I would like to say that I am the secretary of Mumbai Obstetric Gynec Society, and I wish to go ahead to contest the vice president elections of FOXY in this year 2025. So please support me for this particular by voting for me. Thank you.
So without further ado, let us begin the first session on ovarian management. As we are all very well aware and accept the age-old Greek dogma, that is, life comes from an egg. And I request Dr. Suman Bijlani ma'am and Dr. Richa Jagtap to chair this session. Dr. Suman Bijlani ma'am is a renowned obstetrician and gynecologist with over 30 years of experience she specializes in adolescent care, family planning, and advanced laparoscopy, and she is very well known for her compassionate and expert care. Dr. Richa Jagtap, Medical Director, ART Fertility Clinics, India. She is committed to providing international standard care and ethical practices in reproductive medicine and has contributed extensively to research and training in the same field. Welcome, ma'am.
Thank you, Harita. I would like to invite on stage our very first speaker, Professor Barbara Lawrence. She's the Scientific Director of ART Clinics, also a guest professor at Reproductive Unit of Ghent. She is renowned in reproductive medicine with specialization in gynecology and fertility preservation. She holds a PhD in fertility preservation. She is a former head of IVF at Women's University Hospital, Germany. She is an esteemed ISHRE member with a strong research focus, where we know that she hands-holds us through all the research projects and through the new learning. Over to you, Professor Barbara.
Okay. A very good morning at this early time. Thank you very much for your kind introduction and also for the opportunity to present in this forum on personalized ovarian stimulation. So you all know the journey, the IVF journey, starting with a consultation and then in the end, ending up hopefully with a transfer of a good quality, healthy embryo. One of those crucial steps, I mean, there are many, and of course all of them are important, but one of the first and crucial steps is ovarian stimulation. Because in the end, we want to have a good number of eggs because we know number matters. So now, also we know that a patient is not like a patient, so we'll have to personalize. To be able to do this well, we have to know and understand very well the physiology behind ovarian stimulation. Then the next point is, what do we want to achieve? We want to achieve a multifollicular growth, as many oocytes as possible, because as said, numbers matter. However, we still have to avoid ovarian hyperstimulation, because even nowadays, I mean, we can most likely avoid it, but still, if it happens, it's still a life-threatening complication for a patient. And in case of a fresh embryo transfer, also we want to avoid late progesterone elevation, because we know that this will impact endometrial receptivity and will reduce the chance of a pregnancy in a fresh embryo transfer cycle. So what are the challenges? We'll have to do a correct stimulation, and this often starts with choosing the stimulation dosage. Usually, we are choosing it according to ovarian reserve parameters and to the patient's characteristics, because we want to avoid under and overdosing. But the question would be also, do we have another parameter which we can choose? For example, FSH levels. So let's just briefly recapitulate what happens in a natural cycle. So we know that FSH is starting to increase at the late luteal phase already, because this is the time when the sensitive cohort is recruited. And then it slowly subsides during the follicular phase to peak again during ovulation. So we know when we are looking at the follicle cohort, we have like a common growth of the follicular cohort until approximately a size of 10 to 12 millimeter. And then the growth will start to diverge. Only the dominant follicle will continue to grow. The smaller ones will undergo atresia. And why does it happen? Because the dominant follicle is developing a higher sensitivity towards FSH, so which means those declining FSH levels, they do not harm the dominant follicle. But for the smaller ones, it's not enough anymore, they will stop growing. Furthermore, FSH is inducing LH receptors because those are important finally for the ovulation process. And this is when we are looking into the insides, this is what happens at the follicle, at the granulosa cells. We see a distinct shift from the predominance of FSH receptors in the very small follicles to a predominance in LH receptors, which means if you translate it towards your stimulation, a pre-ovulatory follicle has only few FSH receptors, so he might not need that much FSH at all anymore. So we all know just this, the end of the recapitulation, we know that the recruitment of the cohort depends on the time of the FSH level or FSH activity being above a required threshold. And this time is crucial to see how many follicles are recruited. If it's a short time, it's the development of a single dominant follicle. If it's a longer time, we have multifollicular growth. This was published almost 30 years ago by Fauser and colleagues as a so-called FSH threshold, window, or gate concept. So now let's go to the ovarian stimulation. And when we are looking at the cause of ovarian stimulation, the gonadotropins, When we give daily FSH, it takes a few days until the FSH activity is beyond the required threshold. So this happens with daily administrations. Contrary looks a little bit the FSH trajectory when we are giving the depot gonadotropin, which is the corypholetropin alpha. So it increases rapidly and then slowly declines. And when there's need to continue stimulation further on after 8 days, then most likely the patient needs to add daily FSH injections, depending also a little bit on the FSH level in blood. So this, of course, looks much more physiological and much more like what we see in a natural cycle. So now when we are looking into the response of ovarian stimulation, and those are data from our population, so we see we have AMH levels here on the x-axis, we have the response on the y-axis, and we have like the patients, the average, what we expect, like the 50% percentile. However, we see that we have patients who are responding above the average, below the average, and sometimes also unexpectedly very low response. And this is the population, of course, which we would like to identify and which we would like to improve. So now when we are looking into factors which are associated with the number of oocytes what we yield, beyond the ones which we know, which is AMH and AFC, so we have seen, those are the analysis from the same data, that, for example, higher basal FSH levels, the FSH level on the antagonist day, and the BMI of the patient also plays a role. But I'll take you through this now. So which means, as we are knowing that FSH levels might play a role, the question is whether we can use them to improve and personalize our stimulation. So most likely you remember before AMH was very popular and AMH was used as a main parameter to define an ovarian reserve, people were looking at FSH levels because they had been the first marker of an ovarian reserve. However, as we have seen previously, they fluctuate a lot over the cycle, so they are not really reliable. But nowadays, when we are looking at basal FSH levels, we consider that a range of 10 to 12 is normal. But of course, we'll have to ask ourselves, how normal is in the end normal? That's one thing. The second thing is also, can we give FSH a new role? For example, as a potential prognostic parameter when we start stimulation to get an idea maybe this patient is for a risk of an unexpected poor or suboptimal response. And also when we are following FSH levels during ovarian stimulation, maybe we can use it to adjust treatment. Because just to keep in mind, again, so Dr. Richer is now sitting in front of the picture, sorry for this one, we know that in the end, the pre-ovulatory follicle does not need that much FSH anymore. I will show this picture again. I think it's a fantastic picture, so you will see it again. Don't worry. Thank you very much. Okay, let's have a closer look at the FSH levels. Let's start with the basal FSH levels. I want to point to one publication which we had recently, where we were looking into the impact of basal FSH levels on the prediction of a poor or suboptimal response. So this was our patient population, around 900 patients, and when you look here at the known parameters, AMH, AFC, so they had been, not really very good responders, but AFC was still okay, and basal FSH levels were in the range. So now, this analysis, if you are, just let me explain it. So we categorized into different AMH categories, very low, also still low, and then what we would more or less consider at normal and trend to a little bit higher AMH levels. Then we were categorizing according to FSH categories at basal, and we were looking into the number of obtained COCs. And whereas in the low AMH categories, we don't see really a difference in the oocyte yield when we are looking into different basal FSH categories. When we are coming into higher AMH categories, you see that even in those patients, when we would expect them to have a normal response, with higher FSH levels, we have a significantly lower number of COCs which had been obtained. A similar picture is when we correlated with AFC levels. So now there are different classifications for low responder. We all know the Bologna criteria. Here shows the Poseidon criteria, and we were classifying our patients according to those Poseidon criteria. We were dividing them in patients younger than 35, older than 35. So this is again where we have seen that, of course, AMH and AFC correlates with the risk for having a poor or an unexpected ovarian response and a lower number of oocytes yielded. However, for the FSH level, here we did not see a significant impact. However, when we are looking into the older patients, still with a normal ovarian reserve, but of course here again we see that AMH and AFC have a prediction risk for having a low ovarian reserve response, but also here we can see really a clear impact of the basal FSH levels. So which means the higher the basal FSH level, even in this population where we think they should have a normal adequate ovarian reserve, this has an impact on the number of oocytes what we will obtain. So, and this refers to this number group 2 of the Poseidon criteria. So this is about basal FSH levels. Now let's have a look. When we start to stimulate, we give, as you have seen previously, we give daily FSH. So is there any impact of the FSH level, the exogenous FSH level, what we achieve after 5 days, here rising fast or just slower? Also here we analyzed our data. So we were putting together the basal FSH level, which is the endogenous FSH level, together with the FSH level on the antagonist day, which is of course the level what we are achieving when we give daily gonadotropins. And we were splitting according to the basal FSH categories. And you can see when you have a higher FSH level on day 5, which is, as I said, the exogenous FSH, what you measure, you still have a higher number of COCs, what you will obtain. Next point is how are patients' characteristics impacting our outcome. And I think we can keep this very short, and we know all about it, that patients with higher BMI, they usually need more FSH. And this is also when we are looking into the change from basal FSH to the FSH level on antagonist day, when we have a higher BMI, so then usually this increase is not as much pronounced as it is in leaner patients. The last point is how can we use FSH levels during ovarian stimulation? So of course some questions are arising. So the first question is, how much FSH is needed towards the end of the ovarian stimulation? Again, think about this picture, what I have shown, the graph of Jeppesen et al., where we have the distinct shift of receptors from predominantly FSH to predominantly LH receptors. Then the second question is, when we are going down with our FSH dosage, maybe we are afraid that the follicles will not grow that well anymore. Also, we'll have to think, okay, we don't reduce, we'll just keep on pushing and pushing, but do we have to consider any negative side effects of higher FSH levels? And how can we use this information and this knowledge to individualize treatment? Again, so you will dream of this picture. You hopefully will remember it nicely for the rest of your time when you are working. So because this is, I think, very important and very important to remember. And it's a lesson from the nature that most likely we don't need that much FSH towards the end of the stimulation. But we can support it with data. So this is a study what we published some years ago. So this was a study basically where we wanted to avoid progesterone elevation towards the end of the ovarian stimulation. So we had one control group which took the FSH medication unchanged the whole stimulation, and we had a study group which reduced stimulation when the follicle reached a size of 14. At this time, we had still been little bit scared regarding this reduction, so we just took only very small steps of 12.5 units. Now we are more brave, now we are just reducing a lot more. But the important point, and this is what I want to point to, so when we were measuring FSH levels on the day of trigger, so we see that we have in both groups, the ones which reduced and the ones which did not reduce, we have really a very wide range of FSH levels on the day of trigger, telling us that, of course, patients are metabolizing FSH very differently, but also the question is, how important is this? So we then further analyzed this data, and we were splitting the group according to the FSH levels on the day of trigger. And we were looking whether this will have an impact on the outcome, which means on the number of oocytes what we retrieve. And we were splitting the group according to the median, just to have same size groups. And as you can see, of course, because we were splitting according to FSH levels, so we have a significant difference in the FSH levels. But when we are looking at the important outcome, which is the number of COCs obtained, then there was no significant difference. Which means when we translate it, higher FSH levels on the day of trigger does not mean we are having a higher number of oocytes what we will be able to collect. And now just let's have a look at the negative sides of high FSH levels. So those are data from two different studies. One is an in vivo study, so where granulosa cells of a follicle were treated with FSH dosages, with increasing FSH dosages over a different time period. And as you can see here, when granulosa cells were treated with high dosages of FSH over a longer time, we have a significant increase in the progesterone levels. And also clinically, this is a paper which we published a couple of years ago. We have seen when we were comparing the Elonva or corifalitropin alpha, which is a depot preparation which slowly subsides the FSH activity, when we compare it to daily FSH given. So with a daily FSH, we have a higher risk of progesterone elevation. I mean, in a time where we are doing a lot of freeze-all cycles, maybe progesterone elevation is not that important, but in settings where you do a fresh embryo transfers, you still have to be concerned about your endometrial receptivity. And at the last point, I want to point to one study, so which we were doing lately, and hopefully we can submit it soon. So we were comparing volunteers who went for social fertility preservation. They had one cycle with 150 units, one cycle with 300 units, and we were interested whether those higher dosage of gonadotropin will have an impact on the expression of LH receptors on the granulosa cells. And we have seen clearly that with a higher dosage, we have a significantly higher expression of LH receptors, which are like the source of then having higher progesterone levels. So let me summarize. So when we start stimulation, of course, still we will use our gonadotropin dosage according to AMH and AFC. But let's not forget the FSH levels, the basal FSH level. Have a look at it. So if you have higher basal FSH level, you might have to consider that this could be a patient who might have an unexpected poor or suboptimal response. Then further on, during stimulation, we can consider less might be more, so which means if the patient is responding well, if the follicle growth goes well, if the hormones are okay, then maybe towards the end of stimulation, we don't need that much of gonadotropins anymore. Taking this into account, I think we can try to make ART an art. Thank you very much.
We have time for a few questions for Dr. Barbara. Yes, Prof. Mike, please.
Thank you, Professor Lawrence. Can you please explain about you mentioned FSH is creating LH receptors. Now we know that poor responders, they already have elevated FSH levels. Now we have all learned that we have to trigger at a size of 17, 18, 19 or 20. But those poor responders, obviously they have shorter cycles. Could you please explain us why they have shorter cycles and what would be the impact for us IVF specialists for these challenging patients?
Thank you very much for this question, because I think it's an important question, especially as we, at least in our population, we see a lot of poor responders. I think everyone sees this population because now towards to the change of family planning, women usually get older when they start to have a family. So when you are looking at a cycle of a patient with a reduced ovarian reserve, which are often like also advanced maternal age patients, so what we see is that if you are looking at the cycle length, the shorter cycle length is attributed to a shorter follicular phase length. So which means in the end the follicle grows faster, gets faster ripe, and also they ovulate earlier. So which means in this patient population we should not wait until the follicle reaches a size of 17 or 18 because they might experience a premature ovulation, so we are losing the eggs, that's one thing. And the second thing is we were looking into this patient group, and we have seen that even out of follicles smaller sizes, so like 12, 13, 14, where we would previously never have thought that we would trigger them, we can still get competent oocytes which can develop perfectly fine into a healthy blastocyst.
Madam, I have a question for you. I want to know what is the intercycle variability of basal FSH. So if you've done it one cycle, do you need to do it every cycle?
I mean, I think that's also an interesting question because we see, I mean, also my colleague, Dr. Laura Melado, she published a paper a bit ago regarding varying AMH levels, which is also, previously we were always thinking it's constant, and I think for FSH levels it's most likely much more pronounced. This is one of the projects we want to look into, but of course, I mean, I think also what we have seen, even in higher patients with a good ovarian reserve, sometimes we find FSH levels of 12, and we feel like they might not respond as well during the cycle.
Professor, I have a question. You mentioned that in people who have normal AMH levels, who are presumably normal responders, they have a variability in their FSH levels, and they could have much higher FSH. So what exactly is going on physiologically in these patients where despite having normal ovarian reserve, they have a variability in their FSH, and which ultimately is affecting the clinical outcome. So there's something happening which is causing a problem with the oocytes.
Yes, thank you very much for this question. I think it's important, and it's something what we see on a daily basis. I mean, you do 2 cycles, you do exactly the same, and you have a completely different response, right? But I think we are not yet there to really explain what happens, what is behind it. Is it stress? Is it change in BMI? Is it whatever? Physiologically, I don't know. I don't think that anyone was looking into this. I mean, also again, Dr. Laura published lately a paper where we know that in some patients you find an FSH receptor defect, which is a different story, and you have a mismatch between your ovarian reserve and your FSH levels. But maybe you can ask regarding this intercycle variation if we really know what's pathophysiologically behind.
So I think, thank you for this very important question, which is in line with your question. So what we have looked at, and it's a paper we published last year, if we would ask any one of the colleagues here, what is a normal FSH? What would you say? What is a normal FSH? You would say less than 10, right? Okay. Now, less than 10, do you think it would make a difference if it is 9, 8, 7, 6, 5, 4, 3, or 2? Would that make a difference? Because if it is 2 or 9, it's less than 10. Is it the same? No, it's not the same. So the paper we have published last year with Raquel as a first author, we stratified women, young women, with good ovarian reserve and with good antral follicle count, and we looked to the basal FSH values, obviously in correlation with the E2 values. And between 3 and 4, there is no difference. 4 and 5, there is no difference. But the moment you go to 6 or 7 or 8 or 9, every unit that it increases reduces the quality of the egg, reduces the division pattern of that embryo, and creates more aneuploid embryos. So I think the basal FSH, it's something very simple but neglected, because we have started looking to AMH and what have you, but I think we need to go one step back. I think the basal FSH is extremely important. And going back to your question, that was a very important question, the so-called intercycle variation. You know, there is a publication by George Griesinger. I remember in Belgium, women are allowed to donate 6 times in their life. So every donor is assigned to one physician. So I had one donor, and you see them every 3 months. Same body mass index, same protocol. And you know what we observed? That the same donor, young women, healthy women, sometimes she comes up with 25 eggs, sometimes she comes up with 3 eggs, with the same stimulation, same time of triggering. This is called intercycle variation. But that puts a question mark behind most of the treatments which have been proposed for the poor responders. DHEA, testosterone, letrozole, whatever you have there, growth hormone. What about the intercycle variation which is there? And I think this has been neglected. This has been neglected. So what would be the conclusion of all these questions? It would be, actually, for these poor responders, first of all, we need to trigger earlier. I think that's very important. But secondly, we need to put the intercycle variation into cohesion. I think this is important, that not every cycle is the same. And I think this is a very important message.
Thank you, Prof.
At what follicle are you saying? When you say trigger early, what do you exactly mean?
You see what Professor Lawrence just mentioned. When you have a poor responder, the poor responder is having a shorter cycle, right? That's given. They have a shorter cycle. Why do they have shorter cycle? They have a shorter cycle because they have elevated basal FSH levels. Now, you have to be cautious, because sometimes you have women with a decent antral follicle count, let's say 6 or 7, and they have elevated FSH. That's a different story, because this is an FSH receptor issue. But if you have, let's say, 1 or 2 follicles, maybe 3 follicles, both sides, and you have elevated FSH, these women, they tend to have shorter cycles. So if you have an FSH of, let's say, 11, 10, 12, and cycles of 24, 25 days, we agree this is a short cycle. This is a short cycle, as Professor Lawrence mentioned, because FSH, and it's a beautiful study she just presented, and it's not published. What you just have seen, these are beautiful data which are going to be published in the next 6 months. So you receive really firsthand a lot of important information from Professor Lawrence. FSH creates LH receptors. Now imagine your FSH is elevated. What does FSH do? Creates LH receptors. These LH receptors, what do? They prepare the egg for the final maturation, right? So it means this high FSH has led to more LH receptors. These eggs will be ready much earlier. And the size, the paper, you don't have the slides for the paper of the one we published last year for the early triggering. You didn't have the slides there? No. So it's, who is the first, are you the first author for that? So Dr. Lawrence is the first author, so you can look it up. It's Ultrasound of Obstetric Gynecology, very high impact factor journal. So we stratified the patients in different categories. 10, 11, 12, 13, 14, 15, 16, 17, 18, and more. Of course, you would say the bigger, the better. The opposite is the truth. The highest pregnancies we had between 11 and 30 millimeters. 11 and 30 millimeters. Now, please don't go home and start triggering everyone at 11 millimeters. That's not what I said. He said you have to trigger early. No. I'm talking about women with elevated FSH, poor responders, and short cycles. You would be amazed. And you know what was beautiful? And we stratified also according to fertilization rate, maturation rate, embryo division pattern, and euploidy.
The best fertilization we had between 11 and 30 millimeters. The best embryo division pattern we had there, and the only pregnancies we had there. And these are very challenging cases. So I think when we speak about individualization, that's what we're talking about. It's not one size fits all. We were discussing with Dr. Kritika this morning about that issue, early trigger and individualization. I'm sorry? Yeah, usually it is the question. Thank you for that. So day 2, day 3 of the cycle, but obviously you have to make sure that your E2 values are low, because some of these women on day 2, 3, they already have a dominant follicle. The E2 is already 70, 80, so your FSH is not reliable. So you need to have an E2 value which is basal and FSH on day 2, 3 of the cycle. And then usually we stimulate them, and these are very short cycles. These are not long cycles, because those follicles tend to grow rapidly, but important to trigger them not when they are 17, 18. Important to trigger them much, much earlier than that.
Thank you, Prof, and thanks to everyone for very interactive session. We'll keep some more time if we have at the end of the session for question answers, because I know there'll be a lot of questions in your mind. Meanwhile, we'll proceed with the second speaker, and thank you, Professor Barbara, for your excellent talk.
That was a very stimulating session. So it gives me great pleasure to welcome on stage Dr. Laura Milado. She is the Medical Director of ART Clinics, Abu Dhabi. Dr. Laura is a certified reproductive medicine specialist with a PhD cum laude from University Autonoma Madrid. With a focus on reduced ovarian reserve and fertility markers, she has authored 40+ international publications and speaks regularly at global conferences. She currently serves as the Medical Director of ART Fertility Clinics, Abu Dhabi.
Thank you for this kind introduction. I'm really pleased to have been invited to this conference again. And my presentation today is about, I think is a very interesting topic, very, very easy to have many, many questions. So I will try to keep it short, because PRP and stem cells are now in everyone's mind, in every patient request. And I think it's good that we have also like an interactive session and we can debate about this. So I'm sure that all of you have seen in the newspapers, in the news, in social media, there are plenty of people that is now openly talking that they struggle with fertility. And even if they don't say openly that I was really old when I decided, they explain that they struggle for a long time until there was no other issue, no other possibility to go ahead with the treatment. Rachel Green from France was one of them. And even if she got pregnant on the TV show, she couldn't make it during her fertility years. And this is because age and ovarian reserve is the two most important factors to get pregnant. And this is a beautiful graph that you can use with your patients. This is how important is age and the number of eggs to give to our patients the prognosis to get pregnant. And it's very easy maths. If we get more eggs, we will have more euploid embryos. Sorry, I don't know if that was me. More euploid embryos, and then we will have more chances to have a baby. But age will make a difference, because we will not get enough euploid embryos if we are in an older stage. So this is a paper that is a beautiful paper that explains that in a different way. We say that age is the most important thing, but Antonio Lamarca, in this paper, did a complete U-turn to the perspective. He said that AMH is the most important factor. Look at the difference. AMH represents the ovarian reserve, and this is why it's very important, because if we don't have an egg, it doesn't matter the age of the patient. If we don't have an egg, for sure, we will not have an embryo. So we need eggs. We will struggle with the factors of the age and other issues, but we need to have eggs. And here is what we are going to discuss today. We cannot miss a patient that is struggling with her ovarian reserve. These patients that comes to our consultations, they say that, sometimes my periods are shorter, sometimes I miss one period or 1 or 2 months. If they are young, the first thing that we think about is polycystic ovary. So we don't think about that this young lady of 34, 35, 36 might be struggling with a poor ovarian reserve or a premature ovarian failure, which is the next step. And once they are in this situation, a POI, if they Google it, the only option that they have is egg donation. And let's be realistic. Nowadays, the real option that they have is an egg donation. So we cannot miss this situation because maybe still we have some chances when the patient starts having some symptoms. So we need to be aware of that. And this is why today we are going to talk about a little bit different approaches for these patients, that they are in a very, very poor ovarian reserve, very low levels of eggs in the ovaries, and maybe we can consider any other options, not only egg donation. This is why we are going to talk about the rejuvenation, that is a very difficult word, or regenerative therapies. We have explained a little bit the first part. Let's go to the physiology of this. Everything started because in 1999, there was a publication that said that patients with POI, premature ovarian insufficiency, they didn't have periods, they were in menopause, they still have follicles in the cortex. The publication was a publication from histopath doctors, and they presented that 40% of the patients, they still have some eggs there that can be stimulated for moving to the next stage, from the primordial follicles to the preantral follicles. And then Dr. Lee, that this is her profile in LinkedIn, if you look for it, which is very cool, it's just half of the face. Dr. Lee did a beautiful publication in mouse models, okay? What she did is that she took some of the cortex of the ovaries, she stimulated with some mechanical activation, that means several cuts, she put some chemicals there, and she saw that these ovaries that were with POI induced after chemotherapy, these ovaries start moving to preantral follicles. And this picture is beautiful because I'm studying a lot about AMH, and when I saw this picture, these are the receptors of the AMH. So that means that these follicles move from primordial follicles to be preantral follicles that are expressing receptors for AMH. And this is the normal cycle in the ovary of the follicles. We move from primordial follicles, primary follicles, secondary follicle, and the ovulatory follicles. These ones are the ones that are going to respond to our FSH. We are not going to talk about this. From the primary follicles to the secondary follicles, this is regulated by AMH and activins. It is a gatekeeper here in this stage. But we are going to talk about regenerative therapies one step before, in primordial stage. This stage is the one that we are going to talk. And it's controlled by different gatekeepers. So it's not the same like activating the follicles here. So the 4 techniques that are presented and that they are published until now are these ones: PRP, the stem cell therapy, in vitro activation, and mechanical activations. These techniques are the ones that are working at this stage, primordial follicles. We want to move them to this primary stage, and then they can be controlled by the AMH, still not by FSH. So this is a little bit the explanation. We are going to have some dormant follicles in the primary stage. We are going to use some activators, or we are going to try to remove some inhibitors, and then with these therapies, we want to check if these follicles can grow, and maybe they can move for a mature oocyte. Let's start with PRP. PRP is very commonly used in many other medical areas, and cosmetic now is really all around, but is used as well in many other medical areas: spinal surgery, cardiac surgery, in orthopedics for cartilage repair. It's a very simple process. We draw some blood, we centrifuge, and we obtain a preparation that should be with at least 1 million platelets per milliliter. It contains not only platelets, it contains growth factors that they have these effects. Is a pro-inflammatory activity, because with the pro-inflammation, we are going to generate more vascularization, and that can the chain of reaction. This is a very important step. These platelets that are in the supernatant that we will use, they need a kind of activation before being injected. And as you can see, if you go to PubMed, there are plenty of publications, mainly in the last few years. But this has been used for a very, very long time. And now it seems that everyone is talking about this, but the publications actually use very heterogeneous protocols. They use different volumes. They use very different populations. The quality of the studies is not optimal, and it's very difficult to have a standardized protocol. So I'm not going through all the literature here. I'm just going to discuss 2 publications, the only 2 randomized controlled trials that we have for PRP. This is Dr. Nola. I met her in 2023 in ESRE Congress. She presented this paper that she published the next year. This is a randomized controlled trial from the EV group, and they were injecting PRP in some patients, and they were observing the response. They didn't find any benefit at all. But this is the biggest randomized control paper. I'm very proud because this is Dr. Gorka Barrenechea. He's from Spain. I know him very well. And he has published this paper in 2024 in Human Reproduction. I'm going to explain you a little bit the rationale of the study. They checked for the patients. The inclusion criteria was patients with Poseidon, from the groups of Poseidon 3 and 4. And then they randomized to have PRP or not to have PRP. So they did 3 stimulations on the patients. First stimulation for egg vitrification, second stimulation for egg vitrification, and the last stimulation, they did egg collection, they used frozen eggs and fresh eggs, and they did ICSI. And they checked the results with PGTA. The group of PRP was the same, 3 cycles, 2 for egg freezing, 1 for fertilization. And then the first cycle, during the moment of the egg collection, they injected the PRP. So they did an analysis of the patients comparing with the control group, and they did an inter-analysis as well with the first stimulation of the patients that they got PRP. These are the results. Nothing. Everything was the same. And the problem here is that we are really willing to find something for our patients, but this study, nothing. And he got, we can send letters to the editor. He got some letters there in Human Reproduction. They were criticizing, if the PRP preparation, if the timing of injection was not optimal, if the number of injections was not optimal, if the site of injection was not, is during an egg collection, so for sure was in the ovary. There was no option for that. But he got some letters to the editor with criticizing this. And we all are very free to give an opinion and criticize papers, but I want you to think about the inclusion criteria for these patients. Is Poseidon 3 and Poseidon 4. And this is the definition. Less than 5 antral follicles, below 35 years old, less than 5 antral follicles, above 35 years old. But look at the AMH, 1.2. We have been discussing variability, and this is the example of variability. If I include a Poseidon group 3 patient that one cycle has 2 antral follicles and the next cycle has 4 antral follicles, is in the correct group for inclusion? Yes. But for sure, I have 200% increase on the number of antral follicles. This variability is what Dr. Barbara Lawrence and Dr. Fatemi were mentioning. This is the paper that we published. We have seen that we have in the ovarian reserve markers, antral follicle count, AMH, whatever you want to call it, the number of eggs that we are going to have, above 28% per cycle, from one cycle to the next cycle. And this is an average. Those patients from the study, they have huge differences. And a patient with AMH below 1.2 can have a number of eggs of 5 and can have a number of eggs of 11 and still is matching with the AMH below 1.2. So this natural variability is something that we have to put into the equation. And we are doing egg collections. We stimulate the ovaries during the egg collection. We increase the vascularization. We put a needle, if they have 5 follicles, and we puncture, we flash, we stimulate this neoangiogenesis. And then immediately we do another stimulation. We keep on pushing the ovary. We are doing a good workout for the ovary. We are improving this vascularization just with our treatments. So this is why the most of the studies that are randomized, well done, well performed, they don't find differences because we are also doing a stimulation. We have additionally a huge variability of 28%, and this is not possible to find a proper difference. When we move to POI, premature ovarian insufficiency, this is different. Because these patients, they don't have antral follicles visible in the scan. So this is the graph that we saw at the beginning. We are going one step back. Patients that they have a POI, by definition, they don't have antral follicles in the scan. They have super elevated FSH. They are in amenorrhea. By definition, should be like this. There's many, many, many studies on PRP that are using poor ovarian reserve patients. But POI, they are very few, very few. And actually with not very clear inclusion criteria. There is one randomized controlled trial in 2020 that we're saying with a few patients that the results might be promising. We are doing a research protocol under the Department of Health. We are including patients with pure menopause, FSH above 25, no periods, AMH 0.1, no antral follicles visible. And until now, we are not seeing any difference. So actually, these patients are a different step. Let's move for stem cells. Stem cells, everything started because when we create rats with POI with chemotherapy, stem cells used from different tissues can restore the functional activity. Functional activity is related with the hormonal activity. but it's not directly related with collecting proper eggs. There are different ways to collect the stem cells, mesenchymal stem cells. The ones that comes from the bone marrow are the ones that have been used more frequently for the clinical trials, and now very, very famous, the adipose stem cells. So these stem cells, they have a big challenge when they are collected because they are very unstable and they have chromosomal instability and they are sometimes not in a good quality. What they do is, I'm mentioning this here because I think it's really important. They are not differentiating themselves to oocytes. What they do is a paracrine effect. They produce some signals around, some factors that they activate vascularization, they activate cell proliferation. They have a regenerative environment, but they are not differentiating themselves to oocytes. They have been collected from the bone marrow directly, as well from apheresis from blood, and now from adipose tissue as well they can be collected. And before, there is a randomized control study, ASCOT study, that they injected in the arteria ovarica, but now we can inject it as well directly into the stroma of the ovary. So same here. The studies are for stem cells. The most of them that are using bone marrow stem cells are done in a very scientific environment. And one of the main problems that we have is how to translate this to a normal practice, to a clinical practice, because the cells are kind of unstable and the quality can be difficult to obtain. So we need to optimize what could be the dose correct for the stem cells. And we have to really have long-term safety evaluation for these patients. It might be promising, but we need to have studies still to compare bone marrow with adipose stem cells. And how to escalate this is still undergoing. So from these two therapies, these are one very important things that I want to remember. This is a short-term restoration. It doesn't last long. So if we do a treatment like this, we have to keep an eye on our patients and do treatments immediately. This is why when some questions, for example, for the PRP in these letters to the editor, why they don't inject PRP and wait 3 months? Because this activity of the injection, the activation of the environment, maybe it can take a while, but we cannot keep on waiting for these patients because the situation that they have is difficult and because this restoration is very short term. The mechanism of action, the most of them, when we inject something into the ovary, is that we are rescuing preantral follicles, so these small follicles that are still not clearly visible in the scan, but they are there. These are being rescued from atresia because of the neovascularization, because the pro-stimulating environment. So we are not going to a step back. We are not going to the first step that we have been seeing before. And what will be, let me go to the last one. And this is super important. We are creating an environment trying to rescue some follicles from the apoptosis, but we are not changing at all the quality of the eggs. We are not changing the chromosomes. We are still having the same aneuploidy rate for all these patients. So if I have a patient with 44, I'm doing a therapy trying to collect more eggs, those eggs will have the same rate of aneuploidy. I'm not changing that. And these are the future for these techniques. This is what we have to investigate. We have to improve the quality of the eggs. That is the next step, the next level. Is not only trying to collect more eggs, it's trying to collect better eggs. And there are new therapies that have been under research that they are not still yet in clinic. But, for example, improving the energy of the egg, improving the treatments to reduce the inhibitory spots. The telomere length is another way to go. And a very new and very promising is the spindle transfer. So to transfer the spindle into a cytoplasm with better environment to improve the chances. And this is a beautiful paper from Peggy Fair and Sonia Herrainz. They are very active publishing in these restorative therapies. This is the final sentence. Follicle reactivation shows promising experimental outcomes, but clinical evidence in a daily basis is not really clear. The focus should be on increasing not only the number of follicles, but more importantly, the oocyte quality. Because if not, we are in the same situation. Maybe we get 1 egg more, maybe we get 2 eggs more, but they are the same, not good quality. Let's go to the final part. Ethics and regulations. I think that as doctors, we don't need to discuss this part because we have to understand that these are experimental techniques and this cannot be offered like a treatment. Is a research for our patients, so they have to be under a research environment. And this is very important because everybody now is talking about, let's do a PRP or let's do a stem cells. Why don't you put some stem cells in my ovaries and let's see what happens? It's not that easy. We have to do it properly if we want to know really the proper results. And I'm going to discuss a little bit different next steps. This is a new approach that there are some studies ongoing, randomized controlled trials from the group of Antonio Lamarca using LH as a reactivation of the antral follicles to create like an high LH environment on the poor responders, like the PCO patients, like a PCO-like environment, trying to increase this number of antral follicles before starting the stimulation. So they are using LH as a priming. Let's see where it goes. And there is as well some research regarding AMH analogs. AMH is one of the gatekeepers for the antral follicles, so the use of analogs for the AMH is another path to go. But we were talking about these therapies. These LH priming or AMH analogs are working here. So we are talking about different levels. None of these ones, by the moment, has demonstrated that will change the quality of the eggs, but we have to keep in mind which path we want to work. And this is something important because we want to give to our patients better options. We are telling them that very sure we will have regenerative therapies that will improve the things, but we don't know yet when, we don't know how, and we don't know if they are going to work. Until now, it doesn't look like it's very clinically applicable with a big scale. So predicting is very difficult, and mainly for the future. So what we can do for our patients now is to preserve their fertility, even if it's low. Even if it's 2, 3, 4 eggs, we have to catch these patients because what it works is to vitrify the eggs, the embryos. Vitrification is real. It works and it's here. This is what we can do for them nowadays. We can keep on waiting for new therapies, yes. We can try to help doing research and working on that, yes. But we cannot keep these patients waiting. They have to freeze their fertility. And this is very easy, very short takeaways. They are experimental. We cannot tell them that it's a therapy, it's a research. We are not changing the quality of the eggs, and the prevention is the key. Thank you so much.
Thank you, Dr. Laura. That was an excellent, lucid, and very thought-provoking lecture that you took. I have a few points in my mind which came while I was listening to you. One of them, I think Dr. Richa can also share her thoughts on this. I have noticed a significant drop in the ovarian reserve in the patients I'm treating. In our country, I think it's a real problem. I'm also noticing a lot of patients who are complaining of hypomenorrhea. I'm not very sure if that is related to any of it, but it's a real change. It's really a problem which I'm seeing. So, Richa, would you like to say something about the ovarian reserve?
So I think we are seeing more and more of these patients, definitely.
low reserve patients, and more so we see that those patients don't immediately come to a right fertility option because they keep on exploring things, they keep on exploring if they will conceive naturally. But if these eggs are not competent, whatever we give them, all kinds of antioxidants, adjuvants, it's not going to help them if these eggs are not competent. And we'll never see it. Like we see the sperm, we will never be able to see the egg because egg is inside. And as we see in the Greek mythology, it says that life comes from an egg. So somewhere we are really ignoring that part, that low reserve needs to be picked up early and treated early, because really we do not have, as Dr. Laura said, we don't have any options to treat it once we have diagnosed it as primary ovarian insufficiency. Not right now, that is. But your thoughts, Dr. Laura?
Yeah, I completely agree. We have seen many more patients with poor ovarian reserve. We are working in the Middle East, and we publish that approximately 40% of the patients that we see on a daily basis in our consultations are with poor ovarian reserve, which is a lot. Cultural changes, because we postpone our fertility, diet, environment, genetics, whatever reason, it's more frequent. And people is still not aware of that. Not only the patients, I mean, it looks like the doctors, the social environment, you still have time, you are 38, you're still young, go to the gym, take some vitamins, let's keep on waiting. It's a waste of time. At least we can help them to keep some of the eggs or the embryos vitrified. They can keep on trying maybe 1 or 2 years if they want, but to waste the time at that age is really very important. And we have to educate our young girls, because they will like maybe to postpone even further. We look younger, we have a lot of PRP to physically look much better, but still we cannot do anything for the eggs. Yeah. So the way is to prevent that.
Any questions? Yes. So, can we give the mic to sir, please?
Dr. Laura, very nicely presented, and I appreciate the details in which you have explained everything. Now, when we talk of PRP, obviously it's an autologous PRP because we are using the patient's own PRP.
Yes.
Yes. And the platelets, as all of us know, that how it works, once the platelet is injected, the platelet gets lysed inside the body, and they releases the cytokines, and they release the growth factor. So, and along with that, when you are injecting, even some of the neutrophils are also injected, which is an inflammatory conditions. Mm-hmm. So against that, this is autologous, which is there. Now the people have developed an allogenic platelet lysal solutions, where the platelets are already lysed, and only pure cytokines and pure growth factors without any neutrophil or other cells which are available, and it is an over-the-counter, it is available, and the patient does not have to undergo an additional procedure of collecting a PRP. And this has been tried out by a few of my colleagues in 2 conditions. One is a ovarian failure and another is a thin endometrium, and they have found it very, very useful. Thank you.
Thank you for your information. I think that autologous treatments are the ones that are more frequently used. And I think that are, in my opinion, I'm giving here my opinion, the safest ones. When we do PRP under this research protocol in our center, the patient comes in an sterile environment, we collect the blood. In 1.5 hours, we have ready the sample for PRP and is immediately injected. We quantify the platelets, we evaluate the result of the sample. If we need to collect again, we can do it. But we have guarantees of sterility, we have guarantees of the number of platelets, and we want to minimize the side effects that these patients will have. This is an experimental technique. What we cannot do is to put the patients under risk. So in my preparations that are not from the same patient, from my experience, we use autologous PRP, and we do it fresh on the same day.
Thank you, Dr. Laura, for a wonderful discussion and your insight. We'll go on to the next speaker.
Sorry, I just had a quick question, a bit of a tangent. Recently heard a lecture about ovarian tissue cryopreservation and putting it back, and that probably it's going to take over vitrification because, there's a chance of natural conception. There's a chance that, you could delay menopause. So, do you think that it's going to go that way at any point in time?
I'm not sure if that will replace egg vitrification. Because obviously to do cryopreservation means that we are going to do a laparoscopy, collect the cortex of the ovary, and then we need another laparoscopy to put it back. I don't have here the video, but very recently, together with Dr. Lawrence, we had a presentation in one of our congress in UAE regarding this ovarian tissue cryopreservation. Actually, as well, with the tissue, you can do activation of the follicles in the lab and collect the eggs directly from the tissue. To restore the ovarian function is like for 2, 3, 4 months, maximum 6 months. So when we put back the tissue, the small pieces of the tissue inside the body, the hormonal restoration is maximum for 6 months. So we need to keep on doing that, laparoscopy to insert again the tissue every 6 months. And spontaneous pregnancy might happen, but the most of those patients, they need fertility treatment. So I'm not sure if that will be the possibility to substitute the oocyte vitrification. I think it's an option, but I'm not sure if that will be the one that will take our egg freezing away from the picture.
Thank you so much. And with that, we'll like to invite Professor Baris Ata. He is the current president of Turkish Society of Reproductive Medicine and a former ISHRI Executive Committee member. He is globally recognized expert with training from McGill, and he has over 150 publications. He is known for his work in infertility, endometriosis, and always the best talks that we hear. Over to you, Professor.
Hi, good morning. Right, so it is morning, right? Anyways, and it's a pleasure to be here. India keeps amazing me every time I come, and it's difficult to talk after this lively speakers who gave wonderful lectures, and I'll handle the ovarian reserve in a slightly different way. Okay, so Dr. Barbara showed you about stimulation. Dr. Laura discussed, if we could do anything to increase or improve reserve, and how do we, what is the relevance of that information for us? What's the relevance of that information for the patient? Okay, so, well, yes, you see, no disclosures. So why is it relevant? That is the question. So let's see, try to answer these 3 questions in your mind. We're not holding a poll, but the first question is about, is ovarian reserve associated with the chance of a natural pregnancy in a woman who is regularly ovulating? Okay. Say in the question, is a woman, everything else similar, 2 women, one has an AFC of 14, the other has an AFC of 5. What is their chances of conceiving naturally within the next year? That's one. The second implication could be, for if it wasn't AFC, but if it was AMH, everything else equal, young women, regularly ovulating, one has an AMH of 0.6, the other has an AMH of 2 nanograms per milliliter. Are their chances of spontaneous conception within the next year different? So does ovarian reserve relate with chance of natural conception? The other aspect is it related with the risk of pregnancy loss? I mean, once they're pregnant with ART or spontaneously, young women, they have 2 pregnancy losses before, so recurrent pregnancy loss in a sense. Otherwise unexplained, 3 women, and they have different levels of AMH, 0.8, 2.7, and 4. If you would rank them for the risk of pregnancy loss in a subsequent pregnancy, how would that be? Let's see what are the answers in the literature after this final one. 34-year-old, two women, young, again, one has a very low AMH, the other has normal, and they're undergoing IVF. What would you expect? I mean, would they have a similar number of eggs? Would they have a similar number of blastocysts? Or would the chance of each blastocyst being euploid be similar or different? So what is related to ovarian reserve? So I was trying to contrast two things. One is quantity, the other is quality. Now, quantity is easier to understand. It's visible. Quality is a vague term, more difficult to assess, and it has a different meaning under different contexts. In terms of ovarian reserve, quantity refers to the quantitative ovarian reserve, refers to the number of primordial follicles in both ovaries, that the total number a woman has. Quality, now you could say, the potential for each oocyte to reach, to end up in live birth. You can measure quantity relatively easily. You can do a serum AMH, you can do an antral follicle count. In the past, we were looking at FSH and E2 levels. There are other markers as well. Numerous studies shows us, in general, AMH is easy, has less inter and intracycle variation, so that's why it has replaced FSH and E2 for the general assessment. AFC and AMH are usually consistent. Sometimes in about 10-15% of the patients, they may be contradictory. In that sense, the patient would usually respond if she's undergoing ART in between. Okay? But if you're looking at a per cycle basis, like what is the response in the upcoming cycle, AFC measured in that cycle tends to be more predictive than AMH measured a while ago. Because, they are dynamic, they are dependent on the number of growing follicles at the time. Whereas the measures of quality, okay, there's not a single measure, but what you can use as surrogates, you can look at fecundity to see, the chances of conception in a cycle with one oocyte, if it's different between women with different levels of quantitative reserve, it could be a marker of quality, how long it takes to conceive, time to natural pregnancy, or the risk of pregnancy loss, or even if the quality is related, the oocyte quality is related with chromosomal abnormalities in the fetus. You could see an increased risk of fetal chromosome abnormalities in women with decreased ovarian reserve. And in the ART setting, the marker of quantity, assuming the patient is stimulated properly, would be the number of oocytes collected, and the markers of quality would be, the fertilization rate, blastulation rate, euploid rate, and live birth per transferred embryo or per transferred euploid blastocyst. There are studies looking at every single of these markers, and I'll just review a few better quality ones to form our opinion. So how about this one? This is one of the early studies. It's a retrospective study. It's from Denmark. What they did is, it's a case control study, design-wise. They recruited women who presented to the infertility clinic, and they matched them with fertile patients from the gynecology clinic, and they compared their AMH values and adjusted for age, smoking, BMI, and their own gestational age at birth, and chronic diseases, etc. What they observed here, the distribution of AMH was not significantly different between infertile and fertile women as long as they were ovulatory. And also, when they directly compared the proportion of women who had an AMH less than 0.7 nanograms per ml, an AMH level of 0.7 nanograms per ml, it was similar between fertile and infertile patients. So it's a retrospective case control. It can't claim causality, but that's one way of looking at it. This is a better study from US, published 8 years ago. It was a prospective cohort. It was called Time to Conceive study. They recruited through public advertisements women who were trying to conceive for less than 3 months. They excluded women with irregular cycles, any obvious factor for infertility or an obvious male factor. And over 12 months, the cumulative probability of conception did not depend on their AMH levels. You see, like, actually, I mean, the confidence intervals are overlapping, but even the absolute number favored women with lower ovarian reserve as measured by AMH. So it's consistent with the other study. And just last year, I believe, actually, wow, time flies, but yeah, it's almost a year and a half now. They published long-term follow-up of the patients from the original Time to Conceive study. People have been followed up. They've been recruited from between 2008 to 2016, and there were people at the time of publication who have been followed up for more 14 years. And even in the long term, or the probability of receiving a diagnosis of infertility was not dependent on AMH levels, okay? So does it make sense? It makes sense in a way, because regardless of your ovarian reserve, everyone ovulates one oocyte in a given month. So that's how spontaneous pregnancies, that's how natural pregnancies happen. And all these studies have recruited women with regular cycles. That's an important distinction, as Dr. Laura made for POI and decreased ovarian reserve. Because POI, the most severe form of decreased ovarian reserve, you can call it, is associated with some chromosome abnormalities like X chromosome abnormalities, fragile X permutation, among others. So they may be a minority here. Actually, they are excluded from these studies. So we can assume these people are likely to have normal chromosome analysis, etc. And in this case, the chance of spontaneous pregnancy in a short term or even in a relatively longer term is not dependent on ovarian reserve, suggesting against a close association between quantity and quality. There are other studies trying to answer the same question in the literature, and they are usually consistent in their findings. Okay? So now the second context, let's say, the second realm, assisted reproductive technology. The marker of quality could be the chance of fertilization, the chance of blastulation, the chance of euploidy, things that you can observe in the lab. And this is one of the earlier studies that's coming from RMA. In this graph, what you see, they categorized patients based on their pre-treatment AMH levels and took the patients between the 25th and 75th percentiles, the middle 50%, as the reference, and compared the lower 25% with the reference. What they report is obviously the oocyte yield is lower. That's what you would expect. But once you collect the oocyte, the chances that each oocyte would reach blastulation, a blastocyst from those oocytes would be euploid, or if you transfer it, their chance of live birth did not depend on how many you collected or pre-treatment AMH level. They also did a secondary analysis, categorizing patients based on the oocytes collected after stimulation. So like after treatment. Again, here they compare the middle 50% with the lower 10 or 25%. Again, the results are more or less similar, speaking against a strong association between the performance of each egg in the lab with quantitative ovarian reserve. That's another study. This is from Boston IVF. This is also published recently. Retrospectively, they collected patients who were under 40, and their study group was women who had an AMH of less than 1.1 nanograms per ml or who yielded less than 5 oocytes. Okay? And they matched them with 1,149 patients for other characteristics with propensity score matching. What they observed at the end, euploid rates did not depend on quantitative ovarian reserve. Yes, so you obviously get less oocytes. Per stimulation cycle, the patient has lower chances, but each oocyte adjusted for age performed similarly. Now, this is one of the studies suggesting otherwise. This study is from UCSF. They had also published a smaller study, similar to the Danish study, comparing fertile and infertile patients, and they had reported lower ovarian reserve among infertile patients with a smaller sample. And here, they retrospectively reviewed or compared, let's say, 225 patients who were diagnosed with decreased ovarian reserve as per Bologna criteria to 927 women not diagnosed as decreased ovarian reserve, and they report lower euploid rates in women with decreased ovarian reserve in adjusted or unadjusted analysis. So here there's some controversy, but the majority of the studies, the larger samples, show otherwise. This study has been referred by Dr. Laura as well. The only thing with this study is it's by Antonio Lamarca. What they report here is the chances that a patient will have at least one euploid blastocyst, which is proportionate with the number of blastocysts you would have, and that is dependent on ovarian reserve, no question. The number of euploid blastocysts is obviously dependent on how many blastocysts you would have and how many oocytes you would have. That is also dependent on ovarian reserve, but the chances that each blastocyst will be euploid, Antonio Lamarca, he also reports it's independent of ovarian reserve. The title is misleading in this paper. I mean, sometimes happens to the best of us. That's okay. And these are other studies looking at same question. The majority, the ones in green, report that ovarian reserve is not strongly related with the performance of each individual oocyte, whereas some, the minority, reports the other way around, which is normal because each study is a sample. You would expect the samples to have some distribution, but so far, I think it is in favor of, say, the quantity and quality not being strongly related. Now, the final subject, realm, let's say, pregnancy losses. Okay? Here, the picture starts looking different somehow, and it's difficult to reconcile. But anyways, this is a relatively recent systematic review looking at an association between decreased ovarian reserve and otherwise unexplained recurrent pregnancy losses. Okay? There are few studies on it, but actually there's not too few. 16 studies were included. And what they find in any analysis, however they categorize it, AMH, AFC, other markers, younger women, older women, the aggregate data suggests that decreased ovarian reserve is associated with a higher risk of pregnancy loss. Okay? In spontaneous, in natural pregnancies, in ART pregnancies, in younger patients, in older patients. Okay? It is difficult to explain the mechanism. In natural pregnancies, you can suspect maybe it's not the content of the oocyte, but it's the follicle, it's the luteal function, etc. But it even holds in the ART setting, even in artificial cycles. So there is a retrospective study published by the same group who published the systematic review shortly after. They analyzed their own data. They collected data from particularly younger women to decrease the incidence of pregnancy losses due to common aneuploidy, which would cause noise in the data. And they collected data from women without obesity, which is also a risk factor for pregnancy loss. And at the end, when they run their analysis, the conclusion reads, ovarian reserve is not related with the risk of pregnancy loss. But when you look at the paper in detail, there are a few things that catches my attention at least. One, they did not report the biochemical pregnancy losses. They didn't count it. That's also a pregnancy loss. So that may be diluting. And the other thing, I think that is in a way important for causal inference. Look at the AMH levels, okay, and look at the adjusted risk of pregnancy loss. The lower the AMH, the higher the risk of pregnancy loss. I mean, although in each individual stratum, it's not significant, but if you look, the higher the AMH, 1.05, the next lower category 1.12, the next lower category 122, the next lower category 188. So there seems to be sort of a biological gradient. I mean, there's sort of like dose-response relationship. I mean, maybe it wasn't possible to show this as statistically significant in the sample, but this is one of the strongest signs of a causal relationship between two factors, the dose-response relationship. The lower the ovarian reserve, the higher the risk of pregnancy loss. So despite the paper reads they were not related, it still raises a question. Then there is this Danish National Registry. It's a national registry, but at the end it's a retrospective analysis. Again, they only included women younger than 37 years old. A lot of cycles. I sound like Donald Trump now, but I mean, like, it's a lot of cycles. 2,734 cycles, defined with 5 or less oocytes. This is ART data. They only included women if they consistently yielded 5 or less oocytes in 2 different stimulation cycles. That's how they defined poor ovarian reserve, decreased ovarian reserve. And the comparator was more than 20,000 cycles who yielded 8 or more oocytes. Overall, the ovarian response was not associated with risk of pregnancy loss. Okay. But again, similar to the other study, if you look at the gradient, the fewer the eggs collected, the higher the risk of pregnancy loss. So similar to the Italian retrospective analysis, in the Danish National Registry of ART as well, the lower the oocyte yield, the higher the risk of pregnancy loss. Okay, so again, raises some doubt. This is design-wise the most reliable study. They are doing wonderful studies in Copenhagen on recurrent pregnancy loss. They have the Copenhagen recurrent pregnancy loss cohort prospectively followed up, routinely monitored, a lot of samples taken at a lot of points. Anyways, what they did is otherwise unexplained recurrent pregnancy loss patients, systematically examined, evaluated, and prospectively followed. Having an AMH value less than 10 picomoles, which is about like 1.3-ish nanograms, was not associated with the risk of pregnancy loss in a subsequent pregnancy. Okay. So by design, this is the most reliable study, but this is a particularly recurrent pregnancy loss group. The other studies were not necessarily. Again, it is, a bit, say, uncertain. And this is recently published, last week, I believe. Dr. Lawrence, Dr. Fatemi, Erkan, and Bella. So this is ART data. What makes this analysis sort of unique in a way, you see AMH is expressed in Z-scores, which is adjusted AMH levels for age. Here, patients only younger than 35 years old, again, decreasing the risk of otherwise, like common aneuploidy. What you see, the age-adjusted AMH levels had a U-shaped relationship with risk of pregnancy losses. So too high, likely PCOS patients have high risk of pregnancy loss. Also, patients who had low 4H AMH levels had higher risk of pregnancy loss in our own data as well. So whereas the data on natural pregnancies or occurrence of a pregnancy is reassuring in a way, the risk of pregnancy loss seems to be related to some extent with quantitative ovarian reserve. So if I would answer, the questions that I posed at the beginning, I would say the chance of a natural pregnancy, as long as the woman is ovulating regularly, in the next 6 to 12 months, would be similar, would not be dependent on quantitative ovarian reserve, whether you measure it with AFC or with AMH, so monthly chance would be also the same. Whereas the risk of pregnancy loss, until these recent papers, I would have chosen they're similar. And if you look at the just the crude conclusions of the papers, I wouldn't say you're wrong if you pick this one, but now accumulating evidence suggests some association. So I would have chosen B now. And if two similarly aged women with different AMH levels, low and high, are undergoing IVF, yes, the woman with low AMH, so they wouldn't have similar number of oocytes, they wouldn't have similar number of blastocysts, they wouldn't have similar chance of live birth per stimulation, but I think their oocytes individually would perform similarly in the lab. And in conclusion, the occurrence of a natural pregnancy is probably not related as long as the woman is regularly ovulating one by one, regardless of how many she has. Okay, and there are, despite some discrepancies, I think they seem to be performing similarly in the lab, and we can say quantity and quality are not that strongly associated. POI is a different story. A patient who is about to become POI would be a different story. But in terms of pregnancy losses, accumulating evidence is becoming worrisome. Yet, I guess it's important to, in what we do, let's phrase it this way, infertility is a probability business. It may take time with some patients, and as long as they keep trying, if they started young enough with adequate number of oocytes, it almost always happens at the end. So an important thing for success per couple, success per patient, whatever you call it, is to keep them motivated, to keep them in treatment, to keep them trying. So, yes, decreased ovarian reserve quantitatively may have some implications. We may use this information relevantly in informing them if they're undergoing treatment, they may require multiple stimulation cycles, etc. Okay, but we shouldn't focus on the dark sides only, okay? And we shouldn't terrorize them. And the majority of the data is encouraging for these patients. As long as they continue, it may happen, right? So it's important to keep them in the treatment loop. So thank you for your attention.
Thank you, Professor Barris. One question I would like to ask you, young patient with poor ovarian reserve, does she have the similar chances of aneuploidy as any other woman, or is she at higher risk for aneuploidies?
Based on majority of the data, I think the chance of the risk of aneuploidy is similar with a same-aged woman.
Okay, thank you.
Yeah. Professor, I would like to continue with this question. If the chance of aneuploidy is similar, in your opinion, how can we explain the increased risk of pregnancy loss in low AMH patients, and how can we prevent it?
You see, like, there are many determinants of ovarian reserve. Right? So whatever we are doing at this stage is still crude analysis, right? You know, the AMH is measured at some point in time, not necessarily that cycle that she conceived. Okay? So it gives us an idea about a woman's ovarian reserve roughly. Same for AFC. You don't know which follicle from which follicle the egg comes from. The data is convincing in a sense. The majority of the data, there's not a strong association. So data from, RMA, data from Boston IVF, data from, other centers, show in proper analysis, euploidy rate is the same. Euploidy is not the only mechanism behind pregnancy losses. We were having a discussion today. Our euploidy analysis is limited with the test resolution we have today. So there may be other reasons. In natural pregnancies, I would understand, as I said, it could be follicular function, but even in ART pregnancies, the increased risk of pregnancy loss, there is something cooking, but not necessarily euploid.
Thank you, Boris. You know, the beauty of science is I could give you exactly the opposite of that presentation. Exactly the opposite. And actually, we were supposed to have a debate in Mexico, but because the flight was so long, maybe I should do that online. You know, when you see the paper that Boris just presented, the paper which is in press, Dr. Lawrence is the first author. When we had this idea, we looked whether young women have higher risk of a miscarriage. We had this discussion in the group, and we analyzed, and nothing came out. It came out that young women are not at risk of having miscarriage. And I said, but this is not what I observe. I said, this is not what I see. Then I said, okay, let's analyze only my data, only my patients, because I really asked this question, did you have miscarriage before? And I fill it in correctly. And guess what? Suddenly it came out, with my patients, it makes a difference, but with other doctors' patients, it doesn't make a difference. So with the big data, especially from the Netherlands or for Denmark, I don't believe them. Denmark, they are doing this recurrent abortion test. It's a country which is not conducting PGTA. It's a country which started doing PGTA. You know that 6 months ago they started a study there, which is funded by the government. Now PGTA is a technical thing. It's like you have someone who never drove a car, he has to win a Formula 1 race. He cannot because he never drove a car, right? The Netherlands is the same. So the fact that you see so many miscarriages, by the way, you said we don't know the technicality behind it. There is a beautiful paper last year. Ying Yang is the first author, Human Reproduction. They described even why these women with low ovarian reserve have all these miscarriages. So if you have the miscarriages, it means they're unemployed. The reason of a miscarriage in the first trimester for 98% is unemployed, right? So if you have more unemployed embryos, you have more miscarriages, as we just published. Can it be that the chance is equal? Most probably not. Why do you otherwise have so many miscarriages with these women? So low, and then the other mistake that we do, the question that you need to ask yourself, why do they have low ovarian reserve? I think that's an important question. You know, do you have a low ovarian reserve because you have genetically low ovarian reserve? Because you have possibly some diseases, autoimmune diseases, because you have had surgical procedures, because if you had an aggressive surgeon leading to low ovarian reserve, yes, then those remaining eggs are healthy. But if genetically you have low ovarian reserve, then you have to be cautious. I think we need more data. Yes, I fully agree with you, Boris. There is a debate on yes or no, but at the end, the truth will prevail. If you have low ovarian reserve genetically, then you have to be cautious, because you will also see during the subsequent presentation that those women are also at risk for later diseases in life, which I'm going to highlight later. But this is a debate which is ongoing, but I think at the end it will come out. Why do they have so many miscarriages? Why do they have so many miscarriages? Because they're unemployed. If they're unemployed and they have more miscarriages, is it possible that their fertility is the same as normal women with normal AMH? I think the answer should be clearly no. But again, I think it's a beautiful debate, which is also demonstrating the lack of knowledge we have in the field of reproductive medicine. You see, one paper says A, the other paper says B. Why? Because most probably there are some details that we have neglected.
So then would it be justified to do pre-implantation genetic testing for women with low ovarian reserve and then do the transfer to subsequently decrease the chances of miscarriage?
This is one of the key reasons why we do PGTA in poor ovarian reserve. But again, PGTA is a technical thing. You know, you can mess it up. You can mess it up. But if you see you have more miscarriages at a young age, if you have more miscarriages, you have seen this U curve, right? So a young woman at the age of 25, if you ask me, do I want to have a 43-year-old woman who is a PCO-year-old woman with low AMH, give me the 43-year-old. I promise you she will get pregnant. The 25-year-old will not get pregnant. And this is the difference.
Thank you, Prof. And thank you, Professor Baris, for a very interesting topic and discussion. And thank you for the lovely audience.
I thank the chairpersons and the speakers and an active audience participation for such an enlightening session. It was packed with valuable insights. So moving on, just a small announcement to the audience. Refreshments are being served just outside the hall. So please feel free to help yourself at your convenience. Moving on, let us commence the ceremonial lighting of the lamp, a tradition that symbolizes the dispelling of darkness and ushering in of knowledge and wisdom. As we invoke the blessings of the Almighty, may this divine light guide us towards the path of harmony. We are honored to have Dr. Kiran Koilo, ma'am, and Dr. Amit Patki, sir, as our chief guests here. And I request our chief guests to kindly join Professor Dr. Fatemi, Group Medical Director, ART Fertility Clinics, Mr. Ibrahim, Group Director, IVF Lab and Senior Embryologist, ART Fertility Clinics, Dr. Richa Jagtap, Medical Director, ART Fertility Clinics, India, Dr. Parle Katiyar, Medical Director, ART Fertility Clinics, India. Please join us for the lamp lighting ceremony. I also request Dr. Richard and Dr. Parul to felicitate our chief guests. Thank you, everyone. Next up, we have a presidential address by Dr. Suvarna Kadilkar, President of Mumbai Ops Gynae Society and a renowned expert in endocrinology and gynecology, holding prestigious qualifications and is dedicated to deliver comprehensive patient-centered care. She is unable to be with us today due to prior commitment, so she has shared a short video conveying her message and best wishes to us. Please kindly play it.
Good morning, everyone. I welcome all of you to this one-day annual conference of ART Fertility Clinic in association with Mumbai Assisted Reproductive Society. Friends, this is the end of my tenure and the last conference of my tenure, and I will be handing over on 20th of April. This program was being planned for several months by Dr. Richa Jagta and Mr. Ashraf, and we have come out with a wonderful program designed by them. I am so happy that we have stalwarts from all over the world who have joined here to impart their knowledge to our Mumbai members. We have Dr. Harita, Dr. Lakshmi, Professor Barbara, Dr. Laura, Professor Mustafa, and we have our own Dr. Amit Patki, Dr. Kiran Poilo, Dr. Professor Human Patami, and we also have Dr. Suresh Saini. We also have wonderful panel, we have lectures on different advanced topics in the field of ART. ART is a science which is ever advancing. I hope you have a fantastic learning experience with such a great faculty. Unfortunately, I could not come personally to attend this program. I'm very sorry about it, but I had an important managing committee of Foxy in Delhi, so I could not come personally, but I wish the conference all the very best. Thank you so much.
Great. So moving on with great enthusiasm, we now begin our panel discussion on SEED, which involves a discussion on challenging clinical scenarios, various stimulation protocols, and much more. This is a platform where diverse perspectives and views are shared with a critical insight. And to moderate this panel, I welcome Dr. Meenakshi Dua, Director, ART Fertility Clinics, Gurgaon, and Dr. Akash Surana, Senior Consultant at Fertility Clinics, Vashi. And to join the panel, we have our experts. I request all of them to please come on the dais. Dr. Sonu Balara, Director, ART Fertility Clinics, Gurgaon. Dr. Shrestha Sagar, Senior Consultant, Delhi NCR, ART Fertility Clinics. Dr. Azadeh Patel, Clinical Lead and Senior Director at ART Fertility Clinics, Ahmedabad. Dr. Amy Shah, Consultant, ART Fertility Clinics, Ahmedabad. And we are also privileged to welcome Dr. Raj Kumar Shah, Sir is a senior obstetrician and gynecologist and fertility expert at Nanavati Max Super Speciality Hospital, Mumbai, and also medical director of Eva Medicare Private Limited. Sir also plays various roles of ICOG examiner and president of AFG, continuously contributing to medical education. Welcome, sir. And we have Dr. Sachin Dalal, sir, with us. Sir is highly regarded IVF specialist with a vast experience in obs-gynae and laparoscopy as well. His expertise and compassionate approach have helped countless couples to achieve their dream of parenthood. Welcome, sir.
A very good afternoon to all of you. I am Dr. Meenakshi with Dr. Akash. We are going to moderate this panel. I can't see this. Where's Dr. Sonu, Dr. Rajkumar, and Dr. Sachin?
Dr. Sonu was in Harita? So we will just wait 2 minutes for the other panelists to arrive. Slide this in. स्टार्ट कर लें क्या?
नहीं, shall we start? So we had beautiful lectures in the morning about how to personalize our ovarian stimulation. One bear in 1827 demonstrated that all life starts from an egg. The onus is mainly on the egg. So today what we have learned in our previous stimulations, we are going to apply in the real case scenarios and see how can we make the things better. Starting with the first case, she is a young, this is a young couple, 33-year-old, husband is 37-year-old, married for 8 years. She has one abortion at 6 weeks where cardiac activity was not seen. That was 2 years back. Regular menstrual cycles of 28 days. She is a known case of grade 4 endometriosis, operated 2 years back for a 6 centimeter endometriotic cyst. And now also on the present ultrasound, there is 4 centimeter endometriotic cyst in each ovary. Both the ovaries are stuck behind and the antral follicle count of 4 to 5 follicles is seen. She has undergone 2 ovarian stimulations and 2 IUI before landing up in the fertility clinic. Her AMH currently is 3 nanogram per ml. And Dr. Azadi, how will you proceed with this case?
So she's already 33 and already operated once after her abortion, and she has recurrent endometriosis. I would directly advise her with IVF unless the follicles on inside the ovaries are not accessible and we have to go through the endometrioma. I would advise the surgery. Otherwise, I would directly, if the follicles are accessible, I'll directly go with IVF, freeze the embryos, and then transfer.
Dr. Emi, do you agree with Dr. Azadi or you want that?
Yes, I absolutely agree with Dr. Azadi because she has already operated once and 4 centimeter endometrioma. We can definitely advise her for IVF and we can freeze the embryo if required afterwards. She can be treated by surgery.
Dr. Sonu, you also agree or do you want to operate first and then?
No, I agree. We first do an IVF and then maybe the operation is not even required.
Yeah. So Dr. Sonu, in which of the condition would you like to operate an endometrioma?
So if it is a very big endometrioma and the follicles we think may not be accessible, but usually when we stimulate and the ovaries, the follicles start growing, usually they are accessible. So first in this type of patient, with a low ovarian reserve who has already been operated, I would like to do the embryo freezing and then maybe go in for.
Dr. Sachin Dalal, any opinion on operating an endometrioma prior to IVF?
Can we go to the previous slide? There are
Yeah.
few discrepancies in the history that I want to. You mentioned as primary infertility. It's not primary infertility, it's secondary infertility.
Sir, the new definition, it says that if a patient has a successful pregnancy, then only she has a secondary infertility. If she doesn't has a successful
WHO
pregnancy,
guidelines.
it is still called as primary infertility. So
Okay.
even if this patient has an abortion, we have labeled it as a primary infertility.
Okay. Secondly, there is a discrepancy between the AFC scoring and the AMH.
Yes, Yeah, that is there.
So that is the thing. Thirdly, she has been operated for only an endometriotic cyst, while it is mentioned as grade 4 endometriosis. So most likely the previous surgery was not optimally done.
So it is not written completely for the short time. She had a grade 4 endometriosis which was surgically diagnosed.
Clearance was done properly.
Clearance was done, and after now she has a recurrence of endometrioma which are bilateral with 4 to 5 AFC on each side.
Perfect. So see, I do laparoscopy myself as well as IVF.
Yeah.
I would like to first operate her. As you mentioned that both the ovaries are stuck behind the uterus. So getting access to these ovaries is going to be difficult. One. Two, stage 4 endometriosis. There is a very high chance while you are going through the uterus, through the ovaries, there might be infection, there might be ovarian abscesses. So I prefer to get the anatomy as far as possible towards normal and then go for IVF.
So you wait or you immediately go for an IVF after
So
an operation?
basically what I do is I do a pre-laparoscopy AMH, which is usually around 2 and 3. Do a surgery and I see that the AMH drops to around 1.5. I give these women a dose of DHEA, 75 milligram BD.
But the loss is because of surgery.
What I am doing, I am saying so. DHEA 75 milligram BD, coenzyme Q10 100 milligram OD, and if the tubes are open for 2 to 3 months, I tell them to just try. And I've seen a lot of patients just conceiving on their own. That is one. If not, I wait for the ovarian reserve to come back. It usually comes back between 3 to 6 months. She's only 33, right? So then I would straight away go ahead and do the IVF. That is one. Secondly, you mentioned the husband's age to be 37. The history of abortion that also needs to be taken into account, the husband's medical condition,
Husband
the
factor was
DFI,
normal. That's what we have not
DFI, so that
mentioned.
can also be one of the causes of the abortion.
Even
so I would,
obesity.
so I would operate, optimize, and then go for IVF.
Dr. Rajkumar? You also-
Yeah, I think I would also agree with Sachin with whatever he has said. Probably that sounds much more better.
So we will just go on some reference. Next slide. So according to the ISHRE guidelines 2022, it is said that endometrioma should be operated only if the accessibility is difficult or the patient is having symptomatic, that is for pain. Normally for prior IVF, it should not be operated for just increasing the live birth rate because different studies has not shown much of improvement. On the other hand, it has shown that the AMH drops down. AMH in a bilateral endometrioma, it drops more than a unilateral endometrioma. So in this case, for us, the accessibility was okay. Even the ovaries were fixed, but on the scan, we could see they were accessible. We went forward with an IVF. So
this is the IVF stimulation. Dr. Sachin, how will you start IVF stimulation in this patient?
In this patient, her AMH is 3, BMI is 29. What I would like to do is, for patients and her AFCs on both sides are 4 to 4,
Yes,
4
it's
to
not
5.
matching.
It's not matching. In such patients, I prefer to do the long agonist protocol. All right. The long agonist protocol gives you a more synchronized cohort, 1. 2, we've seen that with the long agonist protocol, the oocyte yield is much better. And I would like to use a HMG, HP. My choice of drug in such cases would be Menopure. The oocyte yield is definitely better. And since there are only 4 to 5 AFCs, that is total 8 to 10, I also do fresh embryo transfers, provided serum progesterone on the day of trigger is less than 1.5.
sir, in endometriosis and adenomyosis also, you prefer a fresh transfer?
So I do operate first and then, right?
Then
so
give
that is
long
what I just
agonist and
mentioned
then
that.
transfer.
But yes, if so, I had a couple of patients who have had huge bulky adenomyomas. We freeze the embryos. I do adenomyomectomy, give 2 to 3 months of Zoladex along with letrozole. The ovarian volume shrinks very nicely. And then I would, so basically the ultra long FAT protocol is what I prefer, because that definitely increases the chances of pregnancy, implantation and live baby rate.
Just to add, this ultra long protocol was first taken in 2006 by Salam et al. At that time when fresh transfers were done, not frozen. So they used to give 3 cycles of GnRH, then do a stimulation and do a fresh transfer. But nowadays we have a better option. We can do a sandwich technique, that we do a pickup, we freeze them, then we give 2 to 3 cycles of GnRH with Letros. As GnRH, it acts centrally, and Letros, it acts peripherally. So we suppress the estrogen, so the action of endometriosis and adenomyosis decreases, and then we go for a transfer, as sir said. So, Dr. Sonu, do you do baseline hormones?
Yes, we do baseline FSH, LH, E2 and P4 for all our patients before starting the stimulation.
What are the baseline levels? I wanted to ask the question. So on what levels would you start?
No, start means there are different, like the ovarian reserve and everything, but FSH of usually less than 10, but still if the patient has a high FSH, according to other hormones also, and whether pre-treatment with something she had taken, or what is the age of the patient, everything we take into account and then we start the stimulation.
All 3
it is
markers
not
have to
only
be
the
taken into
baseline
account.
hormones, but all factors they are taken into account.
Based on FSH, we cannot say that if it's high, then we are not going to start for, especially with the AMH3.
So any techniques to reduce the FSH?
You don't have to reduce the FSH in that case. FSH actually helps you decide what dose you should give. There might be resistance, and then these patients will need a higher FSH, higher HMG, and that will lead to better collection of cohort. And that is what we did in this case. Though she is 33 with an AMH of 3, we started with 375 because the AFC was low, her BMI is on the higher side, and you'll see at the end the recruitment is much better. 13, 14 follicles were recruited and they were growing well.
Just to add one thing, so you asked that what can you do to reduce an FSH? Yeah, there are techniques. If you do a estrogen pre-treatment, or even if you give an OC to the patient, the FSH will decrease, but it's a pseudo decrease in FSH. It's not the true thing. The only thing that can help in this patient is an intercycle variation. A patient with very poor responders, you may just wait in a cycle to see if you have a better low FSH and a better AFC count.
So,
otherwise, you cannot.
So Akash, this is something what I have started doing recently in especially poor ovarian reserves, and even in normal ovarian reserve patients, we see there is a massive intercycle variation in AFCs that is happening.
25 to 30%
Yes,
you
right.
have.
So I counsel these women that not necessary that you come in the next cycle, I will recruit you. If not, we'll wait for a month. And nowadays we've started giving DHEA to majority of the women around AMH2 as well, and we've seen a drastic jump in the AFCs in the consequent cycle, and gradually the shift from short antagonist protocol to the long agonist protocol is giving us better results, is what I've seen
In poor responders.
In poor responders.
Just the
With
dose
the
would be
pseudo false, the AMH is normal, but you can see less antral follicle in those cases, or they actually have a low ovarian reserve, and then you're suppressing it.
So all the women with AFC around 10, 12, where I know that with a short antac protocol, see the problem with short antac protocol, despite giving the pre-treatment estradiol, is that we don't get all the follicles out. With the long agonist protocol, that's my personal data, is that we get a better oocyte yield. And with long agonist protocol, I go up to 450. I don't believe in mild stimulation, because I was having a word with Dr. Fadi Sharar at ISAR, whether they follow the Bologna criteria or the Poseidon criteria. And they said, okay, no, they go in full steam, get all the follicles out and do one cycle, because insurance does not cover IVF in United States. So something like us out here. So go full steam and get all the oocytes out and get the maximum yield.
Yeah.
And in 10 and 12 AFCs, you know that you're not going to get more than 8 or 9 M2s.
But how do you know, Dr. Sachin, that you have actually reached the peak? How do you decide 450 is good for her or not 300?
Fantastic. So what happens is, for a poor ovarian reserve women or elderly women, I would always count. See, there is a definite, no bias or no prejudice against anything, but there's definitely a better outcome that we get with Menopure compared to our Indian gonadotropins, right? So if I'm going to use Indian gonadotropins, the maximum dose is going to be 450. Because in the hindsight, it should not happen that I use 300 or 375 and then I'm like, okay, I can see a couple of smaller fellows out there which did not grow beyond 16, right? So with 450, with the long agonist protocol, I'm sure that majority of the oocytes have been recruited and they have grown.
Have you seen increase in duration of stimulation, increase of
Not really,
gonadotropin
maybe
consumption with long protocol?
Maybe a day or so.
Okay.
Not
Let's
more
ask
than that.
Dr. Shrestha about this. Dr. Shrestha, at what FSH level all the FSH receptors are actually covered? How do you decide on a dose of FSH?
Basically, with the FSH of 17, 18, 19, up to 20. So basically all the receptors are covered, and after that it is a accumulation that may lead to high progesterone in the later part of the stimulation.
So
that's
you are
why
telling that progesterone rise is FSH dependent.
Yeah.
Any opinion of any other panelist on this? Like sir told, long agonist protocol, or which type of protocol would you prefer or normally use in your routine practice? Dr. Sonu.
Usually, 99% of the patients we use antagonist protocols in our patient. And like Shrestha said, around 15 to 23 usually we take. Maybe if it is increasing, then we step down, and the step down regimen is the usual protocol which we follow.
Dr. Shah, any opinion on PPOS, or which protocol do you use?
I still use the antagonist protocol. I'm not a very great fan of PPOS. I've not tried it, really frankly.
Okay, so anybody experienced with PPOS protocols?
So PPOS protocol, fantastic protocol for oocyte donors and for hyper responders, PCO patients, where I know for sure that I'm not going to be doing a fresh embryo transfer. So what we do is we start with medroxyprogesterone acetate. There are a lot of studies, medroxyprogesterone acetate, dydrogesterone, no use of increasing the cost. I've come across a couple of centers who are doing medroxyprogesterone acetate twice a day. That is also not needed. Now with PPOS, there are two schools of thought. One school of thought believes to start on day 2. That is what I do. Other school of thought believes in starting on day 6 like the regular antagonist.
This is a flexible PPOS
Right.
protocol.
So, and all our donors
Belief
will
or
be...
based on something?
Beg your pardon?
How do they decide that later on also
I
they can...
have no idea. So I'm basically following the original paper and start from day 2 onwards, and so it's become so simple. Patient takes PPOS tablets in the morning, the MPA, and she gets a gonadotropin in the evening. So a lot of times for donors I use a Rec FSH 150 dose. If it's HMG, it's usually HMG 300. All right, 8-9 days of stimulation. Now another thing which I've started doing for all hyper responders, which I've shared on the groups as well, because in these women with hyper response or oocyte donors, a lot of times they are having a low level of LH. So when we give our standard trigger, say majority of us would be giving 2 doses of decapeptyl or 2 mg of lupride, and we find that there can be a empty follicle syndrome that occurs. That is one. Secondly, you've seen around 25-30 follicles all around, but your final yield is hardly 14 or 15. So I had a patient where both sides we had almost 60 plus follicles stimulated with HMG 300. And I was sure that this girl is going to give me empty follicle syndrome. I don't know why. And for the first time, I gave her 2 decapeptyls and 2 mg lupride. That was a double agonist trigger. So, and out of 60 oocytes, we could form 24 blastocysts.
16 oocyte, 24
60. 60 oocytes, 24 blastocysts, and 0 OHSs.
That was, I hope, before 2022.
No, Abhi. Self-patient.
So no, Dr.
Not
Sachin, do you have you seen that the
hurry
rate
up,
of
we won't
immature
finish.
oocytes is more with PPOS and the number of embryos is less?
Not really. With PPOS, so now for all donors, we have completely shifted to PPOS because, and we did a trial as well, where we compared PPOS with antagonist protocol and same results.
So Dr. Meenakshi, what do the studies say?
PPOS is coming out to be a promising and easily manageable cycles.
Yeah.
Especially with obese women, we don't have to worry about the LH search, and it is cheap, easy to take. But about the aneuploidy rate, we really don't know
I'll tell you
right
about
now
that as well.
because still we have less sample size and less studies are there. More studies are needed, randomized control trials are needed to prove whether the PPOS is actually leading to good embryo quality or not.
So there is a paper which is published.
So there are
where
two
they have-
papers which we have seen, we have quoted
where they
also.
have compared
Aneuploidy is also compared
same.
and they have shown
But the
same.
sample size is low in that. So we
so-
need more studies. But
And
this-
even I would like to add that we can give progesterone from maybe day 5 or day 6,
Yes.
and even in the luteal phase we can do a
Yes,
PPOS.
we can. That helps there.
I'm just curious to find out what was the marker, sir? Did you how did you predict that you will have more empty follicles from that patient?
So basically what we see in PCO women, after giving a standard 2 mg or 3 mg of decapeptyl or lupride, you see that the kind of oocyte yield that should come usually does not come.
So why so?
This is
So
just
because lupride, sir, it has a sharp rise and sharp
Sharp
fall.
fall.
It doesn't has a plateau which is required for the cytoplasmic maturation.
Correct.
But
So in
Akash,
this,
along with that, what we've seen is, people have asked on the groups as well, they had a similar problem with decapeptyl, that despite giving 2 decapeptyls, they had a empty follicle syndrome.
yes, so with decapeptyl, sir, if decapeptyl, lupride, both are, sir,
It is an
agonist trigger.
Yeah. So for a hyper responder or a donor, I never use HCG. That is one thing. Secondly, the sharp rise and the sharp fall that you are talking about is to our advantage. Like all agonists, there is a first FSH surge that occurs.
Yes, sir.
That brings about the final follicular maturation, followed by the LH surge. So this has a better advantage compared to the HCG. Like say if it's a hyper responder or a donor, I would not even let her smell HCG. Forget give her HCG. Because during our last conference that we were having, a colleague of mine referred 2 of his donors during the conference.
So we are not talking about donors specifically. In general,
self also.
Yeah, self also. When we give
No, so for normal responders, I would give them a Ovitrel or a RUCOG with 2 mg of lupride or decapeptyl. That is the standard dual trigger.
I think we are running short of time. We have other cases to discuss and let other people. Yeah.
Is anybody using oral antagonist?
No, we haven't started using it.
There are studies, sir, which has on the donor cycles. There are studies with oral antagonist and donor cycles. They have shown promising result, but still we need more studies.
In India, it's not yet.
It's not in India. It's outside.
Azadi, last question regarding again this LH trigger. Dr. Sachin was worried about the empty follicle. So what on the baseline hormonal level will make you decide that you should give GnRH agonist trigger or you should go for a HCG trigger?
So in my practice, I usually do dual trigger. The units of HCG would be dependent.
No, baseline LH level.
Baseline LH level, if I find the baseline LH level to be very high, it is indicative of LH receptor defect, or if it is very low, it tells that there is less of LH. So in that case, we need to add up HCG for sure.
There
Otherwise,
won't be
we'll end up with
receptors
more
and
empty.
then you will get
Yes,
empty follicle
empty
syndrome in those patients, especially if you have suppressed it with pills or say long agonist, and if LH is very low, in those cases, then you have to give HCG. GnRH agonist is not going to work.
Absolutely. For normal responders, poor responders, it's
PCO
always
everywhere.
a dual trigger. PCO.
Some amount of HCG, so maybe a low dose.
Maybe 2,000 units or 1,500 units, even in PCO patients, that gives us a very good yield of mature oocytes.
This is a meta-analysis of an RCTs that shows that dual trigger has a better result. Dual triggers, we give a physiological as well as artificial trigger. LH, it acts like a physiological trigger. As Sir said, it increases FSH as well as LH, while HCG, it acts as a surrogate of LH. So HCG has a benefit of maintaining the plateau also, which is required for the cytoplasmic maturation. And as Sir said, the agonist trigger, it helps in an FSH and LH rise. So always giving a dual trigger whenever possible is better option.
So Akash, not only ART, but now for even IUI cycles, I have completely graduated to the dual trigger.
Yeah, so
it's a dual trigger
just
for
we
all
need
patients.
to give a better luteal phase support.
So we had 12 eggs and out of that 11 were mature, and ultimately we had plenty of embryos. We transferred 2, patient conceived, and recently 3-4 days back she has delivered the twins, and doctor called me and told me there was no endometriosis. We did not operate on that 4 centimeter, and that 4 centimeter had completely, those cysts have completely disappeared, pelvis was okay.
So moving on to the second case, she's a 36-year female with 36-year husband, married since 14 years, primary infertility, had a strong family history of cancer. She is anti-TPO positive, hypothyroid, HSG, one-sided tube was blocked, had multiple OI and IUI failures along with 3 IVF failures. In all these 3 cycles, there were conventional follicular stimulation with an asynchronous growth. She has a mild adenomyosis with AMH of 1.7 and AFC of 10 and 6 on each side. So, Dr. Shah, how would you like to proceed in this patient?
So with 3 IVF stimulations and 7 to 8 eggs in each cycle, asynchronous of course, day 3 and day 5 transfers. Yes.
So, sir, all had asynchronous growth. So, anything on that?
I really don't know whether asynchronous growth would be associated with a better implantation or something as such, But yes, there is a role, definitely we could work on that as such. But I will be more interested in investigating for why recurrent implantation.
So what investigation you prefer?
I mean, yes, initially we would try and find out, improvise on the kind of stimulation that we are giving, one for sure. The second thing is whether the endometrial thickness is quite good enough.
Everything was good. She has
other
good
things
uterus.
were good.
Yeah.
Mild adenomyosis, that's it. Everything is all right.
So maybe work on the adenomyosis part of it. Well, maybe
Would you like to offer a PGTA?
Yes. Yes, of course. That's another thing. Sure.
Yeah, Dr. Shrestha, your opinion?
Yeah, actually the patient is having 3 failed IVFs, and every time transfer of day 3 and day 5 embryos, and there is no PGT was not done. So this time I will advise the patient to go for IVF with PGTA. Along with, I will try to synchronize the follicle before going for the stimulation. So that is the part.
So maybe I would like to do a luteal phase with frozen embryo transfer.
We can check it in luteal phase.
And PGTA, and before that treatment for like ultra long for adenomyosis
So
also.
Dr. Sonu, why luteal phase? How will luteal phase help?
It is synchronous growth of the follicles in the luteal phase.
So luteal
Whenever
phase
we
basically-
get.
So basically we give luteal phase estrogen that downregulates the FSH. So in a poor
It's
responder,
estrogen-free treatments
so
are what you're
basically
talking.
that reduces the FSH and the early follicular recruitment stops. But now here, see, she's failed 3 IVF cycles.
Yes.
I'm sure those must be 3 short antagonist protocol.
Antagonist,
They were
conventional
antagonist
follicular
protocol.
Right.
stimulation. Also.
So I would, and she's got asynchronous cohort.
Yes.
Now this is, and with adenomyosis.
Yes.
That means kahan pe to endometriosis hai.
Yes.
So this is the classical woman who deserves a long agonist protocol
You can
with
go
a
for
good
long
HMG,
agonist.
with a PGT, and also she's failed 3 IVF, so hysteroscopy as well. And not only hysteroscopy, but since there's adenomyosis, I would probably do a hystrolab both. If there are endometritic spots there, I would probably fulgurate that and then do a transfer.
But we have GnRH agonist for that. Why to
So why to do-
do
If you're doing
laparoscopy?
see, there is what I mean. I would do probably, So there
Would
is
you like
always
to do
2 things.
laparoscopy?
Dr.
before?
Shah, any difference
If there
of
is
opinion?
no finding of endometrioma or endometriosis on ultrasound, we can definitely opt for to put her on one more surgical treatment, rather than we can think about suppression and then proper PGTA normal embryos to transfer.
So this was the stimulation. We started with a 450 dose and the response were around 9 and 4 follicles. If you see the hormone, the last day hormone progesterone was around 1.28. So Dr. Sonu, what can be the reason for an increase in progesterone?
I cannot see the.
Dr. Sonu is there also in front.
Last day. We started with 450
So, simple
and FSH
question.
was 26.
Yeah.
And we still continued with 450 because the
So
follicles
maybe
were
the
growing.
FSH level was high, so that led to more of LH receptors and increase in the progesterone level. So we should have stepped down the
levels.
level of
And
gonadotrophin.
high progesterone can actually affect the oocyte quality.
Quality
and
and
that is what we are worried in this case. So regarding mid-luteal phase, what are your concerns when you are starting stimulation? What are the good side, what is the bad side of it?
of luteal phase stimulation? Dr. Azad.
Patient should not be pregnant, first thing. So that's the most
Very
important.
important.
Abstinence should be abstinence, we have to confirm with the abstinence
We
or
can do
counsel
beta
for
HCG.
that.
Beta
Or beta HCG in mid-luteal phase. Second thing is with mid-luteal phase, the good part is that we'll have synchronous cohort, probably a better number of follicle compared to follicular phase, because the FSH is more or less very better with that. And
What will
we
you
can use
for
PPOS.
LH suppression? Yeah. What you'll use for LH suppression? That's what I was about
Yes,
to
so
ask.
progesterone, because we even want to delay the menses until we pick up.
It's a very interesting paper I read, wherein they said that if you are doing, I don't do mid-luteal phase, if you are doing a mid-luteal phase simulation, already the corpus luteum is there. So you don't need to give extrinsic progesterone. So,
So one question on that, the patient...
I don't do it, so I don't do
No,
it.
no, okay. Okay. So in a luteal phase, a patient's progesterone is already high, and generally we tell in an IVF cycle, a higher progesterone is detrimental for the oocyte. So why this progesterone doesn't affect the cycle, or does it? Dr. Sonu or Dr. Shrestha?
Why luteal phase progesterone does not affect the oocyte quality?
Growing follicles. Normally we say that in an ovarian stimulation, if a progesterone is on a higher side, it has a detrimental effect on the growing oocyte at the maturity. But in a luteal phase, already you start with a high progesterone. So why this progesterone doesn't affect, or does it?
It is from the corpus.
luteum,
Not from the follicles which are producing it.
Yes. At the same time, the follicles which we are starting are less than 7-8 mm. They don't have an LH receptor.
LH receptors
So
on-
even if your progesterone is high, it doesn't interfere with the maturity. So this was an embryology part of this patient. We could get 2 embryos. We did a PGTA. One was normal. Fortunately, she conceived with that. Next. So this is a third case, 35-year female, 34-year husband, married since 5 years, primary infertility with a short cycle of 24 to 25 days, a low AMH of 0.3, sonography showed around 3 AFC, husband had severe oligoestenoteratosis.
So we did her stimulation. On day 2, FSH was 11.6 and 3 follicles were seen. We started with 300 dose with PPOS protocol. So do you think the dose was right?
No.
First of all, this patient, she had come on 7th day, and 7th day when we did a scan, she had small follicles or in between. So if a patient comes in the middle and if the follicles are small, do you start? You don't start.
We need to see the baseline hormone. If they are baseline, we can.
Okay.
So how you would have stimulated her differently?
I would have given her 450 as a dose and triggered her early.
But even with 300, FSH receptors were covered. FSH is 22, so 300 dose is okay. It is acting on all the follicles. Then the follicular growth was very slow. It went on till 10 days of stimulation, and once the follicle was 17, 18, trigger was given, and we had 1 egg that was immature. So what do you think can be the reason for this debacle?
As I said, I would have triggered early.
Because she has a high basal FSH, that means the LH receptors will develop much earlier. So the luteinization will happen early. So by 13, 14 millimeter, 15 millimeter, we can trigger them and get mature eggs.
She has short cycles
Short
also.
cycle, yeah. So this is what we have seen.
I would have done an antagonist protocol rather than a PPOS.
Yes, we can do that. We can do that. So the second stimulation, the FSH was much better. We gave estrogen priming. Letrozole was added to increase the FSH receptors, and the stimulation was much shorter. It lasted only 8 days, and once the follicle was 16, 14, trigger was given.
Sir, any role of letrose?
Can I add something? I just wanted to say something.
Yes,
So I had a similar patient who had only 2 AFCs. We had done a previous cycle 450, very bad quality embryo. And we had very clearly said that we were going to be doing egg pooling. So in the second cycle, we started her with clomiphene citrate 50 milligram TDS from day 2 of the cycle, and that continued. Now clomiphene citrate, if you are giving, you don't really need to give any additional antagonist. So my cost of stimulation was 200 rupees. And both the follicles recruited, both grew, gave trigger with HCG, I think it was HCG 10,000, picked up, got 1 M2, that went to blast, did a fresh embryo transfer, and she delivered. Fresh embryo transfer. Fresh embryo transfer.
With clomiphene citrate.
With clomiphene citrate.
Dr. Shrestha, how letrozole is different from clomiphene as adjuvant?
Actually, it is an aromatase inhibitor, and it increases the sensitivity of follicles towards FSH. So
It
that
increases
is
androgen
levels.
levels.
So that's why, yeah. So
it will also reduce,
good
there are
outcome.
studies which have shown that it reduces even the gonadotropin consumption, stimulation days, and also it increases acidic form of FSH. So that stays in the circulation for a longer time.
Because high bioavailability,
Yes, yes.
less clearance.
Basically, it increases the FSH receptor expression and the sensitivity to it. So what you are giving your gonadotropins, they have a better effect. At the same time, you have natural gonadotropins also. That helps. So this was an, you can see a study which showed that when you use letrozole as an adjuvant in a poor responders, it has shown to have an increased live birth rate.
So second stimulation, we had 7 eggs, 4 were mature, and 1 blastocyst formed on day 5, which was euploid on PGTA. Recently, I've done the transfer, hoping that she conceives with that.
All the best.
This is the last case of the day.
So it will just take 5 minutes.
Yeah. She is 38, husband is 31 years, married only for 8 months. And she has come for a fertility treatment. So is it right to offer fertility treatment to her, Dr. Sonu?
She's 38 years.
Yes, so we must. Primary infertility, no pregnancy, regular menstrual cycles of 30 days. And she had one 11 centimeter fibroid which was operated 3 years back. She's a known diabetic on insulin. Diabetes is controlled. Hypothyroid with TPO antibodies. On antidepressants from last 14 years. Stopped just 2 months back before coming to the clinic. Ultrasound shows diffuse adenomyosis. Uterocervical length is 9 centimeter. AMH 0.9, BMI of 36, husband is normal, and she has one IVF cycle before where they got 2 eggs, both were mature, 1 blastocyst formed on day 6, and because of the age PGTA was done which showed a low mosaic embryo, trisomy 21, so the transfer was not done.
So everything is there in this patient.
Yeah. So how will you manage, Dr. Shrestha?
So actually this patient is having almost everything, advanced maternal age with low AMH and very high BMI, and so I would like to stimulate her again with a high dose of starting dose because of very high BMI, and accordingly, and I will trigger her.
So when
PPS regimen because of the high
yes, because of the BMI, PPS will be good. When she came for the first time, I actually offered her donor eggs, but she said no, she wants to try with her own, and that was the 8th day of her cycle. When we did scan, we saw some 6 follicles in the right ovary and 1 follicle in the left ovary. So probably it was that intercycle variation. 1 follicle was 11 millimeter. FSH was 7.36, LH 3.2, estradiol 32, and progesterone 0.05.
So will you start her on this time or you will wait?
So we can wait. Wait this 11 mm follicle to ovulate, but as the hormones are okay, so in that case we can start the stimulation.
Any difference of opinion on this?
This might not ovulate because estradiol is only 32 and you're
Yeah,
seeing
that is
11
why.
millimeter
That is
follicle.
why we can start.
So we can start with the stimulation, and we did proceed with the stimulation. After 5 days of injection, follicle reached 19 millimeter. Only 1 follicle is dominating, rest others are actually regressed to 5, 6, 7 millimeter. So what will you do?
We could have started with a higher dose of gonadotropin because of the BMI and
addition of letrozole.
Yes, we could have done that. That's one option.
Suppose if you have with 450 also, and still if you
Ovulate, and then
we can give trigger
like
also.
luteal phase
So we
stimulation.
triggered that
Or
follicle
trigger.
and continued with the stimulation, and in another 7 days, follicles were ready. On 12th day of stimulation, we had 6 follicles were there, which were 16, 17 millimeter, and because we could see follicles and the hormones were normal. Why to wait? Last cycle there were only 2 follicles.
AFCs are better.
38-year-old,
Yeah.
her AMH is 0.9.
Yes.
I would like to primarily give her DHEA, testosterone gel, coenzyme Q10, get the follicles more responsive.
For how long?
So,
maybe 2 months, and
so
then start the stimulation.
AMH will also go down, no? In 2
No,
months.
nothing. 2 months AMH is not going to go down.
So the first question was only that with this scenario, will you start or will you
I would never
wait?
start.
And so,
Day 8, I would never start. I'm just trying to understand like what these people are saying, you know. But then day 8, why would I start stimulation? And
that
the
only, sir,
AMH,
was the first question.
38-year-old
Do you start?
AMH
You don't
0.9.
start.
This is mid-follicular phase start
Why?
stimulation.
Make it simple. Simple. Give her DHEA, testosterone gel, coenzyme Q10. Ask her to lose some weight. BMI is 36.
Everybody has tried.
Put on
She
early
is not
start.
able to lose
Put
weight.
on early start. 1-2 महीना दो. 5 kilos कम होगा उसका. So your stimulation, and 375 was not a dose I would give. I would probably give her a 450, a 336 BMI.
Dr. Azadi, will this trigger is going to affect the other follicles? We triggered one follicle in cycle.
With the leupride? No.
Will it?
Obviously,
Why?
because they are baseline, they will not have any LH receptor for the trigger to act.
Sir, just about the testosterone gel, the biggest trial, the transport trial, has not shown any effect till now.
The dose that was used was less.
Yeah.
It was just 5.5.
Just the studies which are still now not much favoring even the testosterone or DHEA.
Even in this cycle, if we are seeing a good number of ultrasounds,
Sorry.
we can continue with the stimulation.
Akash, DHEA, Cochrane database review, and plus multiple reviews. Another thing what I've mentioned, and I'm telling since last 10 years, Indian women, they need a higher DHEA compared to your Caucasian counterparts. 75 does not work.
You give 150, 75 BD.
I give 150 BD, that is 75 BD. And after a good response of 2 to 3 months, uske baad I reduce it to 75.
So, sir, this is a protocol in all the low ovarian reserve you prefer?
All the low ovarian reserves.
So, for 2 to 3 months, you give a DHEA with a coenzyme and then? So
Yes.
Do you check DHA levels before starting?
Absolutely no.
Dr. Shah, any opinion on this? How do you proceed with a low reserve?
Yeah, so poor reserves, we follow a particular protocol wherein the previous cycle, we give them a combination of drugs. One is letrozole for almost 28 days, CoQ, 400 milligrams per day, and then they are also put on estrogens for about 20 days, followed by 10 days of progesterone, and addition of growth hormone from the 21st day onwards, 0.5 units every day till the time of HCG trigger.
So how much pregnancy rate has improved by doing all this?
It has made a lot. I mean, of course, I do not have comparative figures as such, but we have seen definitely a better response after having shifted to this kind of protocol.
So let me.
This is a good outcome.
Inter-cycle variation and
Yeah, but not in all one patient. Yeah.
Because there's so many patients, if we do another stimulation after 6 months or even after 1 year, she had 3 oocytes in the previous cycle, maybe 10 or 11 we may get, even with a poor responder. So even if we are not giving these drugs, but just...
It may be just an inter-cycle variation. Maybe. Or it may be the drug, we don't know.
I thought this is a good
So we
cycle
require
compared
more,
to the
but
last
look at
one.
the outcome.
So we started the stimulation and we got 5 eggs, all 5 were mature and 4 blastocysts formed, all 4 were euploid. We transferred 1 after correcting the uterus with GnRH agonist and she is pregnant. Now she is 12 weeks pregnant.
Good job.
Thank you.
Thank you everyone. Thank you.
Thank you.
We should have had more time. Thank you. Thank you so much.
So thank you moderators and all the panelists. That was a very brainstorming session. Moving forward, so all that discussed about the role of egg in fertility, now it's time to understand the crucial role of the other gamete, the sperm. And to enlighten us on this topic, paternal aging, DNA fragmentation index, and ART and neonatal outcomes, we are fortunate to have with us our speaker, Dr. Amit Patki. Sir is a leading fertility specialist and medical director at Fertility Associates Mumbai, currently president of ISSA 2426, and he also plays a crucial role in many national and international reproductive health bodies. In addition to over 50 plus publications and author to chapters in over 100 books, Sir is also a sought after TEDx speaker. Sir is a respected voice in infertility and reproductive medicine. We truly appreciate and are very grateful for your presence here today, sir. Over to you.
Thank you. Thank you very much, and a very good afternoon to you all, and thank you to ART Clinics for having me amongst y'all, and I'm really happy that I came early morning to listen to these wonderful lectures. As the MOC just said that we have discussed women in detail, and I think it's time now to speak for the other gamete, and that is the paternal contribution to the success. Whenever we talk of aging, we often think of only women. So is aging a woman's only problem? It looks like even amongst the lay people, because the 4 Time magazine covers featured only women when they spoke of aging or age reversal. And even the science media has spoken only of women as cure for aging. We now had Brian Johnson who talks about aging, but that's a different story. But we can infer that men, just like women, carry a biological clock when it comes to reproduction and the ability to produce optimal embryos, particularly after fertility treatment. So I think it's time to look at the man, because we know that it takes 2 to tango, and it's very important that we also look at the couple as they come to us on their first visit, and also advise the same lifestyle advice that you would give a woman with a high BMI and who has a 130 kg husband sitting next to her, and we don't even tell him anything about losing his weight. I hope a Time magazine will one day have a man on their face saying that it's important to look at the man and also when he wants to have his babies. Professor James Crow, in one of his editorials, has said that the greatest mutational health hazard in the human population at present is fertile old men. Because as against women where fertility decreases with age, in men the fertility is not as affected. So you have old men who can still father children, and we have lots of celebrities and not so celebrities also who have fathered children not only beyond 50s, 60s, but even in their 70s and 80s. And according to him, they are fertile, but you do have mutational problems that happen in the children, and that is the reason why the health of the species is now at a threat, because unlike women who come to doctors for treatment when their fertility declines, these men do not come to you, but they are actually adding on to the burden of the problem. But even 2000 years back, it was known that fertility and maternal and paternal age was important. When you look at this beautiful fresco, which talks about a dialogue between Plato and his student Aristotle, and the student asks the teacher, what should be the prime age for parents? And he says it is about 20 years in a woman and around 30 in a man. And Plato goes on to say that when the woman becomes 20 years of age, she can beget children to the state, as that what they used to say, and continue to bear them until 40. A man can begin at 25, 5 and 20, when he has passed the point at which the pulse of his life beats quickest, which means he has become mature enough to hold a family and continue to have children until he's 55. I'm sure our ART people looked at this fresco when they made the rules for us. He also goes on to say, what happens if they have children before or afterwards? He says if they have children before or afterwards, the child is an offspring of darkness and strange lust. And they go on to explain this, that there are mutational hazards which is there in all those frescoes. So why is male reproductive aging considered as a radical road to ruin? And this is because with advanced male age, there is dysregulated cell metabolism, environmental toxins, unhealthy lifestyles, obesity, hypertension, diabetes, comorbidities, which will diminish your antioxidant production, causes an imbalance in the redox potential and will increase the ROS. Now, along with this, there is decrease in the testosterone production. So there are erectile dysfunctions, and the paternal age at conception, the years to conceive increase with increasing paternal age, and you land up with not only subfertility, miscarriages, but more important, mutations in the children. The other problem is that there is a significant decline in the sperm counts globally. Now, if you look at sperm counts in 70s, 50, 60 years back, the average count was 100 million per ml. In 2018, 50 years later, the average count is 50 million per ml. So there is an accelerated decrease. And before 1972, the fall in the sperm was minus 1.16%. But we see after 2000, the fall is more steeper. It is minus 2.6. So all over the world, the global trend is that the male counts are falling and they're decreasing at an accelerated decline. There are large epidemiological studies, but this is the largest study coming from USA, which says that the average mean age of fathers has increased from 27 to 31 years. So there is an increase in the mean age of 4 years. And the percentage of people who father children after 40 has increased from 4 to 9%. And percentage of fathers who beget children after 50 has increased from 0.5% to 1%. So it may look insignificant, but you can imagine the number of children that are born to fathers over the age of 50, particularly over the age of 45. So this is a graph which shows you the sperm counts according to the age. And if you look at it clearly, you find that things start going wrong around 45 to 50 years of age, when you find that not only the semen volume becomes low, the count becomes low, the motility becomes low, and also the morphology. So men who are younger, less than 45 years of age, had significantly greater semen volume than men who are more than 45 years of age, and also associated with a significant decline in the sperm counts. So the probability of producing an abnormal semen increases with age. The abnormality is not only with count, volume, motility, but we also see that there is an increase in the DNA fragmentation and the aneuploidy rates. So when you have fathers of advanced paternal age, you find that there is decreased implantation, increased miscarriages, leading to lower live birth rates with this problem. So the impact of paternal age, you can very clearly see that after 45 months to conceive dramatically go up once the paternal age also starts rising. Look at this graph again. Incidence of miscarriage, relative risk remains almost the same till 45 and then dramatically moves up with increased miscarriages once the paternal age is more than 45. Now, really, frankly, even as fertility specialists, we used to just look at the semen report, and if the semen report is normal, I think from that day onwards, we would only focus on the female and try and treat her. But now, we know that advanced paternal age is associated with an increase in the spontaneous risk of miscarriages, which even I did not know till I started getting deep into this. And these miscarriages are not only very early first trimester miscarriages, but also miscarriages as late as 20 weeks of pregnancy. But what is the silver lining in all this? Because as I said, they are fertile old men. You get pregnancies happening. So two large studies, 2017 and 2019, published in very reputed journals, where they have fertilized donor eggs with men with advanced paternal age, they find that the aneuploidy rates are not increased. So that is the silver lining, as against maternal increase in age, which increases the incidence of aneuploidy. With advanced paternal age, that is not seen. So there was no significant trend in the prevalence of aneuploidies across paternal ages. This is a very fantastic paper which I like to quote, a single center. So single center doing NGS have found that there is no increase not only in the aneuploidy rates, but also in the mosaicism, translocation. So they were all same across the ages, up to 40, 40 to 50, and beyond 50 years of age. Then why am I standing here and talking to you all? The aneuploidy rates are normal. There are miscarriages. But the more important is now, I think we have to shift our goal. No longer should we be just talking of live birth rates. We should be talking about the health of the neonate, and that is what gets affected when there are pregnancies with advanced paternal age. So a father of 25 years has a 53% chance of getting a 4-celled embryo and a 38% chance of getting a blastocyst. But a father of 45, the chances are decreased. So the blastulation rates decrease, and that's why you have implantation failures or early miscarriages. And I think it is extremely important that you counsel the patient of advanced paternal age if they happen to come to you, because large number of times we see elderly men with younger wives who come for fertility treatment, and this is an opportune time for us to talk to them and do certain tests for them. We also know that male infertility is a window to a man's health, which means that when women are getting older, they necessarily do not have any risk in life. But we know that when you have infertility in men, you have to look for other things. And what are the other things? You look at cancers. If you have men with severe male factor infertility, there's a very high probability of getting testicular cancers. So I often say that when you do a testicular biopsy, please send a small sample for histopathology, because you have almost a 1% chance of picking up carcinoma in situ. And even if you cannot give them a baby, at least you have warned them and saved them from a cancer problem. What happens with cardiovascular? You know that when there is male infertility, look at their cardiovascular issues, because the incidence of cardiovascular mortality in male factor infertility is extremely high. And also with other autoimmune diseases, diabetes, multiple sclerosis, and Graves' disease. So this is an opportune time for you to pick up these issues and inform them of the risk that male infertility is concerned. We often talk about sperm DNA fragmentation. Now, what is the sperm DNA fragmentation? We all know about the DNA, and we know that the DNA gets broken at multiple levels, and this DNA fragmentation increases with age, and I'll tell you why it increases with age. The problem is that the amino acids are coding for a certain protein. So when you get breaks, the sequence of the coding goes off, and after multiple breaks, an abnormal protein gets coded, and that is where you start having mutational problems in men who have got severe DNA fragmentation. So in the first stage, there is less compacting of the sperm chromatin, and you have a high incidence of histone. And in the second stage, this vulnerable DNA, which is not well compacted, is affected not by nucleases, but by ROS. And that is why the ROS starts going up in men with severe DNA fragmentation. Fathers transmit DNA modifications to the offspring, and this was picked up many years back by this gentleman Weinberg. He said that in a high order children, somebody having 7, 8, 10 children, the last born child always had mutational defects. Now, often we would attribute this to the mother's age. And they weren't very sure, but they knew that, and especially they found this in dwarfism. So they found that if the last born child always had a risk of mutational defects. It was only in 1955, this Nobel laureate Penrose demonstrated that it was the paternal age and not maternal age of these de novo mutations. And how did he prove that? He said that spermatogonial cells replicate every 16 days, so approximately 200 divisions by age 20 and 660 divisions by age 40. So if you have sperm DNA fragmentation, every time it divides, the fragmentations increase. By contrast, the oocytes undergo only 24 cell divisions, all but the last one occurs before the woman's birth. So the mutations are because of the paternal age and not because of maternal age. And that's why James Krause suggested that the greatest mutation and health hazard is the fertile old men, high risk of spontaneous mutations because of age. And you know, cannot see this slide, I know it's time to change it, but what are the defects that are mutationally seen in advanced paternal age? So we start with achondroplasias, thanatrophic dwarfs, syndactyly, cleft palates, patent ductus arteriosus, preeclampsia and preterm births, childhood cancers, leukemias, retinoblastomas, and more important now are these neurodevelopmental disorders, attention deficit disorders, autisms, bipolar diseases, adult onset bipolar diseases. So maybe that's the reason we are seeing a large amount of ADHD and autism in children, because over the years, the average age of the man has gone up, and maybe that's why we are getting these mutations. Look at advanced paternal age and autism. It's clearly seen that when fathers are 40 and over, the incidence of autism has gone up. When you look at schizophrenia, adult onset schizophrenia, it's almost double when the fathers are less than 40 than when the fathers are in the age of 50 and over. So biological clock in a man is also ticking. One way that we can look at this and perhaps try and reduce the DNA fragmentation is by doing the sperm DNA analysis. We know that when it is less than 20%, 60% of your patients will have no issues. When it is 20 to 25%, 9.2% of your patients would have no issues, and more than 25%, 31% of your patients. Now, how do you treat or how do you reduce? It is by giving antioxidants. There are 3 antioxidants which really work very well. The one of them we always use, which is CoQ, but hypotaurine is another antioxidant which we can use, and glutathione. So it's hypotaurine, glutathione, and CoQ10, which are antioxidants which are given to reduce this DNA fragmentation. And once this DNA fragmentation comes down, maybe the incidence of mutational defects that you see in the children will start coming down. So increasing paternal age, but also in young men who have got comorbidities. So next time you see a person with diabetes, hypertension, increased BMI, please get their sperm DNA fragmentation done, even if their sperm counts are normal, because you do not just want to have a live birth, I think we have to shift our goalpost into having normal children and normal neonates. And that is how these antioxidants work. It reduces the ROS and help to reduce mutations, reduce miscarriages in these. What was the eye-opener for us at Fertility Associates to get into this? The eye-opener was there were 200 couples who were referred to us with a previous IVF failure. I'll just take a minute. With previous IVF failures. And in them, there was no indication of male factor infertility. So when we did their sperm DNA fragmentation, we found that the sperm DNA fragmentation was high in almost 40 to 50% of them. And they also had these various different sperm morphology changes. We found 62 of them diabetic, 35 of them hypertensive, thyroid issues, obesity, smoking alcohol, infections, varicocele on examination, chronic medication. There was one man who was on dapsone for 10 years because some dermatologist had written it for him, and he went on using the same prescription, and we found that was the highest DNA fragmentation. I have seen 92% DNA fragmentation, but with a normal semen report. So where are these antioxidants working on the sperm? This is a chart which is very good for my UGs. They know exactly which mineral, which antioxidant works on the head, mid-piece, and on the tail. So we conducted a small study, 30 patients from 10 IVF centers where the DNA fragmentation was increased. 3 months of antioxidants. They were allowed to continue whatever treatment they were doing. Even if the couple got pregnant in between 3 months, the men were asked to continue for 90 days, and a sperm DNA fragmentation was repeated at the end of 90 days. We found that the DNA fragmentation came down, the sperm counts and the motility went up, and antioxidants in fact worked in the severest of cases more than the cases which were on borderline. So men with very severe sperm DNA fragmentation, I think you need to give them not only lifestyle advice as you would give it to the wife, but also to them and put them on antioxidants. And then we had a paper which was published on this. So there are guidelines for advanced paternal age. I think it's time we look at the man in the couple, because as I said, it takes two to tango, and we need to move our goalpost not only from live birth, but to a healthy neonate. And I think that is the message I want to give. So thank you very much for a patient hearing.
For an exhaustive talk. I would like to know which test do you use for DNA fragmentation?
See, now the tunnel test is actually the benchmark, but most of our units can't do tunnel test. So we do the indirect test, which is sperm dispersion test that we conduct. Tunnel test, the platforms are very fragile, so you need to have a proper lab, and they are also much, much expensive.
So you do it in your own lab, or you send the samples somewhere
Previously,
else?
we used to send the samples to one lab, but now we have started doing it in our own lab. For the last 3 years, we are doing it in our own lab.
Also, I just want to add that you highlighted that these patients have autism and the babies can have autism. Even there are studies that these babies, there is high chance of having schizophrenia if the father is more than 45 years
So
of
we did
age.
say adult onset schizophrenia. So adult onset schizophrenia, neonatal cancers, autism, ADHD, these are problems. I think this has to be explained to the couple, because we always talk of live birth rate and when we lose the follow-up.
Any questions from the audience?
Seal, what do you do?
If the varicocele is felt on physical examination, I never do a scan for scrotal Dopplers. If it's felt on physical examination and the testicular volume and turgidity is normal, then I think operating on that varicocele will give you a better result than if a varicocele is just picked up on a scan, or the testes has become small, flat, flaccid. It will not work. So it is very important how you choose your patient for the surgery. So you have to examine the man. That is also important. Put them also on the weighing scale, get their blood pressure, do their sugars, and examine them.
Thank you, sir. Thank you very much.
Thank you, Dr. What is your opinion, sir, about the procedures like microfluidics or physiological ICSI for
Yeah, it
selecting
works
sperm?
well. Microfluidics works well. In fact, there is a Scandinavian center whom we were collaborating on sperm DNA. Now, sperm DNA fragmentation is extremely expensive in their countries. So they would prefer, they do microfluidics for all patients with male factor. So because for them that becomes a more cheaper alternative. So microfluidics does improve you to decrease the cohort of sperms with low DNA. See, there is no technique, even if you do whichever technique, that you can say this sperm has low sperm DNA fragmentation. There is no technique. So with microfluidics, your cohort becomes better. So you choose the cohort which will all have low DNA fragmentation.
Yeah, but any literature where they have used this technique and found that the incidence of the anomalies like schizophrenia and ADHD
Very
is low?
difficult, because follow-ups should be for 10, 15, 20 years, and microfluidics is something which has just come up in the last 5 years.
Thank you, sir.
But there is no technique which will ensure a sperm is normal. You can put them under whichever microscope, put them on PIXI, put them on IMSI, but when you do microfluidics, the cohort that you get will be most of them will have low sperm DNA.
Thank you, Dr. Amit, for an excellent talk, Oration.
So that ends our exciting first half of the day. So I think now let's recharge ourselves for the brainstorming sessions planned ahead by taking a short lunch break. Just a small announcement, your food coupons are attached with your ID and shall help you at the dining area. Thank you, see you back soon.
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए. तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और ट्रांसपेरेंसी. ना झूठे वादे, ना हिडन कॉस्ट्स. आर्ट फर्टिलिटी क्लिनिक्स. हम जोड़े नेचर को साइंस से.
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए. तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the झूठे वादे ना हिडन कॉस्ट्स। आर्ट फर्टिलिटी क्लिनिक्स, हम जोड़े नेचर को साइंस से।
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए। तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और ट्रांसपेरेंसी। ना झूठे वादे ना हिडन कॉस्ट्स। आर्ट फर्टिलिटी क्लिनिक्स, हम जोड़े नेचर को साइंस से।
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए। तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और ट्रांसपेरेंसी। ना झूठे वादे ना हिडन कॉस्ट्स। आर्ट फर्टिलिटी क्लिनिक्स, हम जोड़े नेचर को साइंस से।
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए। तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और ट्रांसपेरेंसी। ना झूठे वादे ना हिडन कॉस्ट्स। आर्ट फर्टिलिटी क्लिनिक्स, हम जोड़े नेचर को साइंस से।
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए। तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और ट्रांसपेरेंसी। ना झूठे वादे ना हिडन कॉस्ट्स। आर्ट फर्टिलिटी क्लिनिक्स, हम जोड़े नेचर को साइंस से।
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और transparency. ना झूठे वादे, ना hidden costs. Art Fertility Clinics. हम जोड़े नेचर को साइंस से.
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और transparency. ना झूठे वादे, ना hidden costs. Art Fertility Clinics. हम जोड़े नेचर को साइंस से.
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और transparency. ना झूठे वादे, ना hidden costs. Art Fertility Clinics. हम जोड़े नेचर को साइंस से.
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और transparency. ना झूठे वादे, ना hidden costs. Art Fertility Clinics. हम जोड़े नेचर को साइंस से.
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए तब luckily my mom-in-law told me about 3T factor of Art Fertility Clinics.
3T है 3 trust factors which led us to the world's highest pregnancy rate. Treatment, technology और transparency. ना झूठे वादे, ना hidden costs. Art Fertility Clinics. हम जोड़े नेचर को साइंस से.
सब कहते हैं I'm lucky. यूनिवर्सिटी में गोल्ड मेडलिस्ट, a great career and a super supportive husband. मगर सिर्फ एक बार I felt a bit unlucky. जब हम कंसीव नहीं कर पाए. तब luckily my mom-in-law told me.
Check, 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 check.
I request everyone to please settle down. Welcome back. I hope the lunch was as fulfilling as the sessions ahead promised to be. So moving on to our second session, I take the privilege to invite as our chairpersons Dr. Kiran Koilo, Head of the Department, Lilavati Hospital and Research Center. Dr. Kiran is a celebrated obstetrician and gynecologist with over 30 years of experience in infertility, high-risk pregnancies, and advanced gynecological surgeries. With over 5,000 laparoscopic surgeries and hysteroscopic procedures to her credit, she is a pioneer in minimal access surgery, an award-winning specialist and an esteemed medical educator. Dr. Kiran is known for her compassionate, cutting-edge care that has transformed countless lives. I also would like to invite Dr. Amit Patki sir to chair the session along with ma'am. The next session is a Mumbai Ops Gynae Society and ART Oration on women's health and fertility.
A very good afternoon, and thank you very much once again to ART Clinics for having me and Dr. Koilo to chair this session. It's a proud privilege to introduce Professor Huma Fatemi, a Group Medical Director at ART Clinics. We all know him as a global expert in reproductive medicine. He has done his PhD and has more than 200 publications in peer-reviewed index journals. He's a clinical professor at the University of Brussels and has got visiting professorship worldwide in many universities. He has over 3,800 citations, and we all know him as he's widely recognized for his research, teaching, and his leadership in IVF. It gives us proud privilege that today he'll be delivering the MOGS ART Oration on women's health and fertility. The stage is all yours.
Thank you very much for the kind introduction. It's always a pleasure to be back in India. The only problem is I would become very obese if I would come too much to India. You know, I love paneer, so I have to be very cautious with the food because I love the Indian food. Now, the topic which I'm going to speak about is, I think, a topic which should be of interest for all of us who are experts in reproductive health. And I hope at the end of the session, you will have a different view on reproductive health and the general health of a woman. Now, if you look hundreds of years back, human being has always been looking to remain young and not to age and to remain healthy. You see, once we pass the age of 50, this is what happened to me last year, you start thinking more and more about your health and about factors that you never have thought about before. So the question is whether it is possible, whether there is this fountain of youth to remain young. And if you go back in time, 500 years ago, there was one of these Spanish conquerors, Leon, where they went to Florida to look for a fountain of youth in order not to age. So it has been since centuries that human being has tried to look for the fountain of youth and not to age. The question is whether we can identify problems very early in life. You see, not having the problems, but whether we can identify these problems earlier in life. Now, if I would ask you, IVF, that's what we do, in vitro fertilization. When it was developed, for whom was IVF developed? For whom was IVF developed? Tubal factor. So IVF initially was not developed for many reasons that we do today. IVF was purely developed for tubal factor. So the first IVF which came, it was purely after hundreds of failed trials, they succeeded. But the reason was tubal factor. Then people came and said, be cautious, because if you do IVF, you increase the risk of developing cancer. I'm going to repeat myself. People said, be cautious doing IVF, because if you do IVF, you increase the risk of developing cancer. Most probably, you have patients asking you, doctor, if I do IVF, do I increase my risk of developing cancer? That's a question which I think all of us have been exposed to. But the answer is no. And I'm going to highlight why no, but still we have to be very cautious. This is why IVF initially was done, tubal factor. In vitro fertilization was for tubal factor. Now, what are the indications today that we do IVF? I mean, I didn't mention anything here, but you see tubal factor, male factor, reduced ovarian reserve, ovarian failure, uterine factor, immunological factors, what have you. So today, we are not doing IVF for tubal factor. Tubal factor is just a fraction of why we do IVF. If you ask me today in my own practice, I would say it's less than 10%. 90% is for various reasons. So the IVF today has nothing to do with the IVF 45 years ago. I think that's an important point. Now you might ask me, why are you talking about that? What does this have to do with the health and longevity of a person? I'm going to come to that. This is an interesting slide. You know, if you look to various ages, and you look at the outcome of IVF, you see, the male factor seems to have the best results because sperm is not important. Life comes from an egg. Ovulatory dysfunction, these are usually PCO women with a lot of eggs. They also have good chances. But what does have the lowest chance of conception? Reduced ovarian reserve at any given age. So if you have low number of eggs, independent of your age, your chance of conceiving is lower. And these are huge databases. Now, and it's nothing novel. You see, recent studies, especially there are some colleagues of Indian origin in the UK who are promoting the so-called mild stimulation, and I will tell you why. Look at the number of eggs that a woman gets. You see, obviously, and this is present in all age categories. In all age categories, the same is present. The more eggs you have, the higher is your chance of conceiving. So the number of eggs is in direct correlation with a positive outcome. Number of eggs is important, age is important, but number of eggs is at least as important as age. So we know IVF was initially designed for tubal factor. We know that women with reduced ovarian reserve have the poorest outcome when they do IVF. Now, if you stratify based on various age categories, you see less than 31, all women who have less number of eggs have the lowest pregnancy rates. You have heard previously the discussion, most probably they are creating more unemployed embryos. Good. So we know that independent of age, the number of eggs is predictive. Low ovarian reserve, it means it's preventing a woman having offsprings. Then you have to think about evolution. Why is that? Most probably, in the evolution, things have developed for a reason. They have developed for a reason. So nature is preventing a woman having offsprings by low AMH. Could it be that the health of that woman is possibly affected, that she would die earlier and not be able to take care of her offsprings because she has low ovarian reserve? And this is the factor that we have to look at. Now, we know that an embryo and endometrium, they are communicating with each other. So the embryo and the endometrium talk with each other. Okay? Normally, an abnormal embryo is giving a signal to the uterus, I am abnormal, don't let me implant. And a healthy embryo is giving a signal, I am healthy, let me sit. So there is a crosstalk between endometrium and embryo. This is a beautiful study which was published 10, 12 years ago. You see, this is the endometrium. What you see here, this is the endometrium. This is the embryo. Okay? A healthy embryo gives a signal to the endometrium, I want to implant. The endometrium is surrounding the embryo. It's accepting the embryo. It's embedding the embryo. This is an unhealthy embryo. You see, the cells of the endometrium stay away from it. They're not embedding it. So this beautifully explains the interaction between embryo and endometrium. So most probably, a lot of these eggs, because they're unhealthy, they are being rejected. Now you might argue, but what about miscarriages, abnormal children? Endometrium needs to be receptive, but also needs to be selective. If it's too receptive, it will accept any embryo, normal, abnormal, anything can come and sit. And if it is too selective, it will postpone a pregnancy. So it needs to be selective and receptive, both of them, okay? Now, again, coming back to the number of eggs and the ovarian reserve. And this is a beautiful paper. You see, how many eggs do you need to have at the age of 30 to 34, 35 to 37, 38, 40, 41, 42, 42, right? So if you are 30 to 34, if you have, let's say, 4 eggs, you have 4 eggs, your chance of ending up with one baby is, let's say, 25, 30%. Now, imagine the same lady has 30 eggs, the same person, at the same age. Her chance of having one live birth is almost 98%. Now, let's go to a 40-year-old woman who has 4 eggs. Chance of a live birth is maybe 10%. But the same lady at the same age, she has 30 eggs, the chance is 70%. So here you realize how important the number of eggs are. So the number of eggs are predictive for a certain outcome. Now, if you look further, it seems that there is a direct correlation between number of eggs and aneuploidy. So there are several studies. Also, we published some studies where we demonstrate that there is a link between ovarian reserve and aneuploidy. And before we go further, I'm going to tell you a small story. A small story which was, for me, the trigger a few years ago to put a link between ovarian reserve, miscarriage, and the general health of a woman. So in Belgium, you go to university for 7 years, then you do 5 years of gynecology, then you do 3 years of subspecialty. So opposite to India, there you have to study 15 years to become an IVF doctor. So you have to study 15 years to become an IVF doctor. So at the first year of medical school, it was 60 of us, and we knew each other very well. And there was a couple, they were girlfriend and boyfriend since we were 18. So these two were together since we were 18. We finished, I became a gynecologist, the male partner became an orthopedic surgeon, and the female became a maxillofacial surgeon. Really very nice people. And when I started as a junior doctor at the IVF unit, they came to me. At that time, we were around 30, 32 years of age, so still young. And they came to me, they said, look, we have had 3, 4 miscarriages now, and we don't know what's the problem. And we examined, we checked everything, and I said, look, everything seems fine. And that was, let's say, more than 20 years ago. At that time, we didn't have the AMH, but she had slightly reduced ovarian reserve. She had an antral follicle count of 3 to 4 on each side. She had a small septum. I resected the septum, but I said, I don't think that this is the reason. And then, after a while, she conceived naturally. And then she delivered. She was very happy. They were sending me messages. Then I moved out of Belgium. About 10 years ago, we had a reunion of the university. And then her husband told me she developed a few years after the delivery severe breast cancer with metastasis and so on. So then I started thinking, was there possibly a link of reduced ovarian reserve, a lot of miscarriages, and then developing cancer? So this is where you have to start thinking there might be possibly a link between the health of a woman, the reproductive health of a woman, and what is possibly going to happen in future. So we published, you saw this this morning, a paper which is last week it got accepted. So it's not out yet. It's going to be published maybe in 2 to 3 months, but it's accepted for publication. You see young women at a young age with very low ovarian reserve and PCO women, they are at risk of developing miscarriages. What is the cause of a miscarriage? Aneuploidy. So it means even at a young age, you are at risk of having aneuploid embryos. So it's again linked together. Reproductive health, aneuploidy, miscarriage, difficulties to conceive. Now, what is the reason that young women with poor ovarian reserve have more miscarriages? This is a beautiful paper which was published 1.5 years ago, and they describe the genetic architecture, how these women are developing or having miscarriage, even though they are young but poor ovarian reserve. So low ovarian reserve is linked to miscarriages because there is some genetic issue within the oocytes. So every woman has a different number of eggs. Not everyone is having the same, but the pattern of decline differs. So at any given age, you might be a normal responder or you might be a high responder. The question is, this response, the number of eggs that you have, does that correlate with the general health of that woman? And for the last 5 minutes, I'm going to go through a couple of slides, and I hope this is going to be an eye-opener for all of you, because whenever you see a woman at the infertility clinic, and you see that woman is infertile, I'm not talking about endometriosis, I'm not talking about tubal factor or azoospermic male, I'm talking about a woman's health. Then maybe you should think and then ask for the patient, do you have any cancer in the family? Is there anything special in the family back history? Because that could be the first light going on that there might be something with that particular woman. We know that the mitochondria within the cell play a role for the health of that cell. And we know that the aging of the mitochondria is also linked to the health of that egg. And we know that the mitochondrial copy number increases the more oxidative stress you have, which is directly related to the egg and the aging of that egg. And you know, this is a very funny but beautiful study. I don't want to give you bad ideas, but imagine you have a female mouse, an old female mouse, and you have a young female mouse. You take one ovary of the young mouse and donate it to the old mouse. The old mouse becomes young. This is very interesting. So it means the general health of an animal seems to be linked to the ovarian health. This is very interesting, right? Then, if you look at the age of menarche and menopause, so the shorter is the reproductive health, the lower is the general health of that woman. And you know, when you see a woman, she is 46, 47, 48, and let's say you do a hysterectomy because of fibroids or whatever. What we usually used to do, we used to do a bilateral adnexectomy because they said you're going to menopause, or you're almost in menopause, you don't need your ovaries. Studies have shown that those women where you remove the ovaries, even though being in a menopause, they live shorter. Because the ovary still produces some factors which might be of essence for the general health of the woman. So it seems that the ovarian health is a direct reflection of the general health of that patient. The secret of aging is hidden in the ovaries of a woman. You know, we published a paper 4 or 5 years ago in Fertility Sterility, where we also described that the naturally reduced ovarian reserve is directly linked to an increased risk of cancer. It's linked to DNA cell repair damage mechanism. So the moment you see a very young woman with a low ovarian reserve, ask her, do you have anyone with cancer in your family? Or if they have repetitive miscarriages, ask them, do you have someone with cancer in the family? Kurt Barnhart, who is the editor-in-chief of Fertility Sterility, did a lot of publications on this. And actually, he describes, and here, I have to say exceptionally, I agree with all the points here. Infertility may be harboring future disease. Infertility, future health risk, early mortality, between ovarian aging and cardiovascular diseases. And childlessness, being infertile, seems to be linked directly with cancer and cardiovascular diseases. So there are several studies. These are huge databases. This is 3-4 years ago. If you take a look at the mortality rate in the US, these are infertile women. This is the control. You see there is always a gap on mortality between infertile women. And we used to think it's because of IVF. It's not the IVF. It's where is the chicken, where is the egg. It is the infertility, specifically low ovarian reserve. That is the bad guy in our field. And you see you have 32% higher risk of death if you are infertile. This is a huge number. And not only cancer is increased with these women, but also cardiovascular diseases are significantly increased among these women. So heart failure is significantly increased. Infertility and cardiovascular diseases, history of infertility, no, look at that. It's a huge gap between them, right? So this is for female, and for the last few seconds, I don't know if you saw the news over the past few weeks. Sperm quality. Man with sperm quality live 3 years shorter with low sperm quality than man with good sperm quality. So most probably, infertility, is it male or female with reduced ovarian reserve, with male with poor sperm count, seems to be linked to the general health of the couple. So I think we need to understand infertility, specifically reduced ovarian reserve, can be linked to higher cardiovascular diseases, cancer, and if you see women at young age with reduced ovarian reserve, ask the question and then try to find out. Usually you identify there are certain cancers in the family, colon cancer, ovarian cancer, breast cancer, leukemia, lymphoma. These are the bad guys that you always have to ask, and usually you will find out, okay, there is the problem. And I think early detection is important. Thank you very much for your attention.
Thank you very much, Dr. Fatemi. You really given so much food for thought. I think if we look at all the women who come to us with low ovarian reserve and tell them that you may live shorter, I think put all the IVF people out of business. Point number one. Point number two is a very interesting ovarian transplant in the mouse. So would it lead to, people who want to, women who want to live longer, lead to ovarian transplant and donor? That's a good point that you brought up.
Yeah, I mean, this is an important point. The question is whether only the ovarian transplant is leading that. So there has been studies where even repetitive blood transfusion, let's say I would donate blood once every 6 weeks, and I receive blood once every 6 weeks from a 20-year-old. Okay? So it seems that this blood transfusion is having more or less the same impact. So ovary is one thing because you do it once and it's there, but most probably, if you would, it would be a beautiful study to do. The question is who's going to donate and how can you do that ethically? How can you get it through the ethical approval? But if it is working with mice, why should it not work with human being? But absolutely. But there will be other ways, maybe blood transfusion with a younger person. When you are 18, you fall down, you stand up and you run.
Right.
When you are 54, you fall down, you get to the bed and you don't move anymore. I think there are many other factors that we need to put in cohesion.
And also your theory is, Darwin's theory of survival of the fittest. I think your study with ovarian reserve and poor fertility and not, increasing species of those would come within the norms of Darwin's theory of survival of the fittest.
That's a very interesting point. So the question you could ask, why do women go to menopause and what's the purpose of life? Do you know that I think whales and human are the only species going to menopause? If you go in the evolution, there are only 2 species which go to menopause and continue living. But if you look in the evolution, all the other species, they reproduce until they die. Human and whale are the only species which are stopping reproducing and they continue living. But if you go back 500 years, do you know what was the average age of male and female until we died? 40.
Yeah, 40.
35 to 40. If you go back 1,000 years, it would have been even 35 to 40. So the fact that we are growing older, it's a recent evolutionary phenomena. It's a very recent phenomena. This is called evolutionary mismatch because the evolution goes over a long period of time. Now we are looking to a very short period of time. And this is a very recent phenomena. So if you look at millions of years of evolution and the change that we see today, it's just a few hundred years. It's 300-400 years. There's nothing in evolution. So most probably, time will tell us whether in 1,000, 2,000, 5,000 years, maybe also the reproductive health of human being is going to prolong. But that's a very interesting point you highlighted. Thank you for that.
Thank you very much, Prof. And thank you once again to EAT. You have any questions?
Just one question. So Dr. Fatema, you just mentioned that when we see at the longevity of women, and women with diminished ovarian reserve tend to have the lowest longevity or shortest lifespan per se. So, and then it was linked to infertility. However, what we see is that women with PCOS too are infertile, but they have good ovarian reserve. So this would be a contradiction to, and they are also at a higher risk for some other malignancies as well. So this group of patients, are they different from women with diminished ovarian reserve, or is there anything else that you would comment on?
So first of all, I don't think we have to tell all women with reduced ovarian reserve you are at risk for cancer. I don't think that this is the correct approach. The only thing that I mentioned is when they have very, very low ovarian reserve at a young age, be cautious. because there are also different reasons why it's low. Maybe because of endometriosis. Maybe they had a very aggressive surgeon. Maybe the surgeon destroyed the eggs. Now, PCO is a different entity because PCO is a metabolic disorder. They also have systemic issues. They also have high rate of mortality because, not because of the egg issue, it's because of metabolic disorders. But if you take a look at the reproductive health with these women, they do much better because the more eggs you have, the higher is your chance of getting pregnant. And if you are a PCO today, let's say you are a PCO today at the age of 25. When you are 40, then you're not a PCO, but you're a good responder. Maybe the reproductive health of these women is just postponed, is prolonged, and they will get pregnant a little bit later, even though they will have more unemployed embryos because they're getting older. But I think the reason of not getting pregnant between these two entities is completely different. Like high progesterone luteal phase or high progesterone because of stimulation, the reason is different. You cannot compare these two together. But thank you for the question.
Thank you, Dr. Fatima.
Thank you.
I thank our esteemed chairpersons for their valuable contributions, and we are also truly privileged to gain valuable insights from the vast knowledge and wealth of experience of Professor Fatemi. Thank you, Prof. So I think by now we have enlightened ourselves enough about the embryo as a seed, and now is the time to delve into the importance of the nurturer of the seed or the soil, that is the uterus or endometrium environment, which plays an indispensable role in successful conception and pregnancy. As we strive for excellence in infertility care, refining our knowledge of the uterine contribution is both timely and essential. So is our next session. It highlights about perfecting the uterus or the endometrium environment, the so-called nurturer. And to chair this session, I welcome Dr. Prakash Trivedi. He is a leading gynecologist, obstetrician and infertility specialist with over 46 years of experience. And he is the director of Dr. Trivedi's Total Women Healthcare Center and Akar IVF Center, a respected member of FOXI, ISAR and other reputed bodies, and is known for his clinical excellence and compassionate approach to women's health. Welcome, sir. I also invite Dr. Azadeh Patel. Okay. Sir is just struck somewhere. We can expect him in within 10 minutes. I invited Dr. Azadeh Patel, clinical lead and senior consultant at ART Fertility Clinics, Ahmedabad. She is a renowned IVF specialist with over 10 years of experience in managing complex fertility cases. She specializes in the management of PCOS and poor ovarian reserve and is very well known for her patient-centric evidence-based care. Dr. Azadeh also combines medical precision with a personal touch. Welcome, Dr. Azadeh.
Thank you, Dr. Harita. We begin this session, the third session for today, perfecting the uterus endometrium environment, the nurturer. So the first speaker for this session is, let me introduce Professor Dr. Barisata, and he will be talking on endometrium, how thin is thin. So Professor Barisata is a globally recognized expert in reproductive endocrinology and infertility with more than 150 publications on IVF, endometriosis and clinical ART. And he's a McGill trained subspecialist and award-winning researcher, and he holds a master in clinical trials, and he has led leadership roles at Koch University and Eshrei. Currently president of the Turkish Society of Reproductive Medicine, he brings academic excellence and global expertise to ART Fertility Clinics. I welcome you, sir.
Thank you. Good afternoon. I'm happy that Professor Fatemi woke us up after lunch. Otherwise, it's difficult. People lose attention. Anyways, the session is titled Perfecting the Uterus. I won't be talking about how you perfect the endometrium, but I'll just try to question, the dogma that a thin endometrium is a bad thing, and maybe, by just changing how we see it, we can improve our patient care. So, again, just to start with a rhetorical question in a sense, consider, if you find the evidence strong enough to suggest that when the endometrium is thin, you should cancel an embryo transfer, or the patient will have lower chance of live birth. Okay, so let's start. Disclosures are the same. Here's the line of thinking, okay? To do anything in medicine, to do any test, to look at any marker, okay? So if you do the test, if the results A and B require different approach and give you that different approach give you different results, then you should do the test. Okay? So if you apply this to the endometrium, the thickness story, the first question is endometrium thin? And then if it is thin, if a thin endometrium is associated with worse outcomes, and if that happens to be the case, is there anything you can do about it? Can you make a thin endometrium thicker? And finally, even if you can do it, does it improve your outcomes at the end? If the answers to all of these questions are yes, then you can cancel the transfer, try to do something about the endometrium, which will improve it. Or if the answer to any of these questions are no, then you should just probably move forward. Okay. Now the first question, how thin is thin or how thick is thin? Is the endometrium thin? We use the same words to describe different things. That's not rare, and that also applies to a thin endometrium. Once we reviewed the literature and compiled the studies looking at the effect of a thin endometrium, on the right you see the different thresholds that have been used to define a thin endometrium. It could be as low as 6 millimeters. There are papers which define the thin endometrium with 10, 14 millimeters. It's sounds unbelievable, but they're published, they're in the literature, you can find them. So what is really thin? Okay, in the general sense, in the common practice, usually the number hovers around 6, 7 millimeters. And why is it 7? I was looking at the history of it, but then I came across a different paper. This is from Psychology, okay? Published more than 50 years ago. A coincidence, the magical number 7. Okay? See, the quote, either there's something really unusual about it, or maybe I'm suffering from sort of persecution. It is a bit exaggeration in the context, but let me show you how we came up with 6 or 7. The earliest paper was published in 1990, when IVF was relatively in its infancy. The ultrasounds were not the same. They were not even doing vaginal ultrasounds, okay? And in a retrospective analysis of about only 120 patients, they were doing sort of, you can call it a fishing experiment, but it's a retrospective analysis to see, exploratory analysis, to see what could be affecting outcome, not necessarily showing or demonstrating causality. And they reported that nobody got pregnant when the endometrium was 6 millimeters or less as they assessed it. Okay? But even in the paper, you don't know if there was only one patient or there were 2 patients, but probably not even 5, given the total sample size of the study, 123. Okay? We all know, it's not necessarily the case. There has been a lot of papers published later on showing pregnancies with an endometrium of as thin as 3 millimeters, 4, 5, etc. So it's not written in stone. The question is, we know it's possible, but if the probability has changed, okay? So now, if we take 6 or 7 as the thinness, why would it affect the chance of pregnancy? Why would it affect the implantation process? Why would it affect placentation, etc.? Okay, so this is a Japanese study done, 16 years ago. What they did, they collected endometrial samples from women who had an endometrium thicker than 8 millimeters or thinner than 8 millimeters undergoing ovarian stimulation, under ovarian stimulation, a stimulated cycle. And then when they did some analysis, what they found is the uterine artery resistance was higher in women with a thinner endometrium. And in the histological analysis, there were less blood vessels per power field in thin endometrium, and the expression of VEGF was decreased with thin endometrium, so it was hypothesizing maybe that it's not vascularized enough, it's not getting thick, and it's not able to nourish the embryo with adequate oxygen and other nutrients. And they particularly mention oxygen. So here is another theory. It's authored by Robert Casper, who published the first paper. Okay? And then the point he was trying to make is, over time, this is published in 2011, through the studies, we've learned that the embryos don't really like that much oxygen, and with modern low oxygen tension incubators, they even grew better. And maybe the reason with, if you believe it to be so, lower live birth rates with thin endometrium, because once you transferred it in a thin endometrium, the embryo was closer to the arteries, the spiral arteries, and was exposed to higher oxygen tension, more oxygen radicals, etc. So my point is, we can go through a lot of papers, but the idea is there is not a unified theory that gives us a biological rationale as to why a thin endometrium be a bad thing for the embryo. So this is just to show the contrast. Now, does it translate to clinical outcomes? Recently, you see, it's an interesting subject. A lot of papers are being published. One reason is because it's easy to publish. You just review your retrospective records, okay, and then if what you find is consistent with the mainstream idea at the time, it gets published even easier. And then comes, paper after paper showing that thin endometrium is a bad thing, thin endometrium is a bad thing, thin endometrium is a bad thing. But the problem with retrospective analysis is how you generate the data that you analyze retrospectively. If you have been canceling embryo transfers because the endometrium is thin, or if you have been intervening or altering your management of the cycle, the reality might be distorted. Right? So you're observing the results of your practice. None of the retrospective studies can ever claim or demonstrate causality. Right? It just reflects what happened as you did it. Anyways, there are multiple systematic reviews on it, mostly saying the same thing with a few exceptions. But does something become the truth if it's repeated over and over? In sociology, yes, it does, but in biology, it shouldn't. If you look at in detail into all these papers, you would be surprised at not only the thresholds used to define a thin endometrium, you would be also surprised, on how many different days endometrium has been measured. It's not unique. And what has been done in the studies, and if the results, the association has been adjusted for other relevant factors, confounders, which may simultaneously affect both endometrial thickness and the chances of a live birth or pregnancy. Let's say if someone has a good ovarian reserve, responds well, produces a high level of estrogen, it likely affects endometrial thickness as well, which is shown in the studies that I'll show you later. And then, as you have more embryos, you have more option to select. It's a better prognosis patients compared to someone who produces just few eggs. I mean, it's just one example. And then, how do they define the thresholds, and how they did the analysis? It's a lot of arbitrary variation. So I'll give you I'll show you the limitations of different approaches, and then I'll try to define how a proper study should have been done. First, statistical significance does not necessarily mean clinical relevance or does not necessarily mean a causal association. Okay? Until 2000, the studies in our field were usually limited with up to even as small as 20, 30 patients. Okay? So in a small sample, you can observe random effects, and these are the earlier studies. And more recently, with electronic data, we come across a lot of large samples from China or national registries. So on the left-hand side, you see the famous Canadian study, 96,000 cycles, Canadian registry. In a sample of 96,000, if you do a statistical comparison between two things, they will absolutely look different in any way. Even in the third decimal or the fourth decimal doesn't mean clinically relevant. And in that particular study, just as I explained a minute ago, the confounders were not simultaneously adjusted. Okay? And even if they would be adjusted, despite it is huge and impressive sample size, I practiced in Canada. People try to avoid transfers to thin endometrium, I'll show you later again, and do a lot of modifications. So it does not reflect the natural course of the event. It doesn't show you, it doesn't tell you what would have happened if patients with endometrium of like 6 millimeters, 5 millimeters were transferred just as anyone else. So it's not proof of thin endometrium in the natural course being associated with worse results. And is there proof of this? In a way, there is. Human biology, despite some differences between different ethnic backgrounds, etc., still, you would expect more or less similar incidence or similar prevalence of thin endometrium. If you plot the prevalence of thin endometrium less than 7 millimeters across different studies, you see, like it could be as low as 1-2%, it could be 5-7%, and this yellow dot is a study we published from Istanbul 4 years ago. I've been transferring regardless of thickness for years now. Once we published the data, in our case, it was more than 10%. Okay, so some variation is inevitable, but you see, it's determined by the practice pattern. And this is a joint study that we did with EV and RMA. So there is data from 25 centers, more than 30,000 euploid transfers. Each color represents one of the groups. Yellow is us. As we put less emphasis on endometrial thickness, as we published before, you see the proportion of embryo transfers with thinner endometrium is much higher with us. And we also observed the Americans were most obsessed with thin endometrium. And see, if it's not 6 millimeters, there's almost no transfers done. So the data is shaped by the practice. It's unlikely to be shaped by differences in biology. And again, this is HRT cycles, program cycles, it's more obvious there, but even in natural cycles, by the way, when we say natural, in our practice it's pure natural. In Spanish and American practice, it's modified natural. Still, as you see, the difference is even more pronounced now. This is just to reflect retrospective data, just shows you the practice pattern. Now, another problem with endometrial thickness, is it a reliable marker that can justify an important decision as canceling an embryo transfer? Okay. Endometrium is not marble, It's not rectangular. It is like a spindle in a way, okay? There are contractions, and it depends on your orientation, how you align, how you measure. And this is a nice Swiss study done years ago. Even if the same doctor measures the endometrial thickness for the same patient a few minutes apart, okay, the results vary by a millimeter. And if it's two different doctors scanning the same patient few minutes apart, you see how wide the differences can be. You know, not only 1 millimeter, could be 2 millimeters even. Depends on how you put it. So a measurement should be precise enough to inform a clinical decision. All right? Then, all these aside, once you collect the data, once you analyze it, how should you do that? Okay? Remember the causality criteria that I was mentioning for pregnancy losses and ovarian reserve. The lower the reserve, the higher the pregnancy loss, was supportive of causal association. It's the most important, one of the, if not the most important, one of the most important criteria for causality. You would expect to see, like this I would expect to see, to some extent, a linear relationship, okay, in the natural course of events, not in the data we distort by practice. Okay? And the associations could be different. It doesn't have to be linear continuously. It could be quadratic, like a U shape or an inverse U shape. You know, both extremes could be bad. Right? So you first need to plot the data, try to understand if there is a relationship, then how it is, and then you have to analyze accordingly. You see, in these papers with large sample sizes, we did that analysis, this analysis, we did regression models. They are not properly reported in detail. Just having said that, oh, we did a regression analysis doesn't mean the analysis was completely correct. Different types of associations require different models, and not every model always fits the data or explains it in its entirety. These details are very seldom explained in any paper. Right? So that's a problem in general. So to understand the relationship, if it really exists, what needs to be done, you know, ideally it should be prospective, and the cycle management should not be modified based on the endometrial thickness. You know, other factors should be ruled out for the sake of time. You know, I'll just move faster. And if you look at the available data through that lens, in the prospective studies, which are the minority of all studies, the prospective studies do not claim such an association. Okay, so it's coming from almost exclusively from retrospective studies. And this is what we had published 5 years ago. If you just transferred regardless of thickness, you see, I mean, there's not a particular pattern, and even with thin endometrium, you can get, you know, very decent live birth rates, even without PGTA. This is Istanbul data. And this is what we published with ART data 2 years ago. Almost 1,000 euploid blastocyst transfers, eliminating the variation by aneuploidy. And if you plot the probability of live birth across endometrial thickness in natural cycles, in program cycles, and overall, some fluctuation is normal, but I don't see a certain threshold below which there's a huge or clinically relevant difference that would necessarily require canceling the transfer. Okay, we observed a higher live birth rate around 11 millimeters, but you see, it's you know, the higher, the thicker areas are again lower, and it's probably coincidental, or it's the majority, or if you would just take these as proof, then you can also say, you know, maybe 4.5 millimeters is as good as 11 millimeters. Okay. Anyway, so the point is, I fail to see a certain threshold, and this is the revision is under review now, more than 30,000, you know, all cycles, program cycles, natural cycles, all 3 clinics combined, last 2, So US, Spain, and our data, again, I fail to see an obvious breaking point. That's one thing. And secondly, remember the differences in practice. You see, as they provided the majority of the data, in HRT or modified natural cycles, you can see this trend towards 7, which might be caused by the practice pattern as well, but I would argue the best model to study would be the pure natural cycle. And this is the pure natural cycle. Okay. And regarding obstetric outcomes, these papers report completely contradicting results. So the jury is out yet. We don't know if thin endometrium is necessarily associated with bad obstetric outcomes. You can find everything in the literature. And I think, what I understand from all these, the answers to these questions are not uniformly yes at the moment. And this is also a fact at the moment. Okay. So I don't think canceling is justified. If you have any doubt, you can try simple stuff, wait, compare with former cycles, but we shouldn't be dragging patients, cycle after cycle, canceling and canceling and canceling. Okay? So this is, and because canceling ensures, failure anyways. So thank you for your attention.
Thank you, Professor. Sir, I have a question. Okay. Sir, you mentioned that the intracavitary pathology should be ruled out. Would you consider the lateral convergent walls or the fundal convergence resulting into low volume uterine cavity to be a problem, leading to thin endometrium?
Certain uterine abnormalities like complete septum, like severe dysmorphic uterus, in my personal observation, may be associated with a thin endometrium. Okay? And if that is the case, their association with the adverse outcomes are also controversial, but if the patient's reproductive history is bad, we can try correcting. What I'm generally referring is once you rule out everything, just the thickness itself is not a good marker of function. I'm not saying endometrium is not important. It is important. I'm just saying that thickness is a measure of convenience because it happens to be there. We happen to see it, then we try to make sense of it. It's a measure of convenience, and the threshold is also, is a threshold of convenience.
Thank you, sir.
Thank you very much for a thought. One is, do you think measuring E2 would help you to decide which patients to transfer? And second is, do you think doing endometrial blood flows would again help you to decide which ones to transfer?
Thank you. Let me start from the second question. Doppler has been used, commonly in obstetrics because the blood vessels are bigger. Okay, it is an extremely operator-dependent procedure. It's not that precise. In large vessels, extreme changes are predictive for the outcome. Let's say if you have reverse flow in the umbilical artery, then it is something obvious. But uterine artery is smaller. People even try to do on spiral arteries. I would never think, I think they would be even worse than endometrial thickness. They will be never that precise with the current technology, and I don't think it's a blood flow problem. Secondly, would estradiol levels matter? In the natural cycle, we don't have control over anything. We just observe, and the follicle, the ovulation happens unless there's an obvious problem with transfer. And in a normal, ovulatory cycle, the peak estradiol level is about 250, 300 picograms per ml. Okay? So some data in frozen embryo transfer cycles, in program cycles, suggests the estradiol level may be relevant, but there's data otherwise as well. Maybe extreme lows could be bad. Okay? But what I suggest in practice is if you think the endometrium is not as thick as you wish it to be, you can review the patient's chart. See how it was in the stimulation cycle. If she had a prior cycle, see how it was. And if it's a program cycle, if you have any question, I don't necessarily recommend it. You can prolong estradiol exposure a little bit, but I don't think dose increase would make a difference, because I mean the doses are really low anyways. And then, probably the best is just to move forward at the moment. Otherwise, I've seen people, being cancelled month after month.
Okay. Thank you, Professor.
Thank you.
It's first of all a pleasure to be invited here as a chair. Richa, thank you for this wonderful conference. And we have a very eminent speaker who is going to brainstorm on adenomyosis. Adenomyosis in management, we all are aware that it's a very tricky subject, and that will be handled by none other than Professor Huma Fatemi, Group Medical Director of ART Clinics. Professor Fatemi, apart from being the CEO, the Medical Director of ART Clinics, is a well-renowned global expert in reproductive medicine with PhD, 200 plus publication, clinical professor in University of Brussels, visiting professor worldwide with 3,800 citation. He is widely recognized for his research, teaching and leadership in IVF and reproductive health. I am sure he will make the journey of adenomyosis easy for all of us. Professor.
Thank you very much for the kind introduction. Unfortunately, you have to listen to me one more time, so I'm very sorry for that. Now, the topic now is on, but you have to push the button there. So the topic that I have, I'm going to present to you now is adenomyosis, which is a very challenging topic. We used to say 20 years ago, 20% of cases are idiopathic infertility. It means we don't know what's the cause, right? Today, that doesn't exist anymore. I think today, if you give us a patient, 99.9%, we will tell you what is the problem. And I think adenomyosis is an entity that we did not diagnose before correctly. So it's important that we look a little bit more into detail into adenomyosis. The key concept of adenomyosis is you only see what you are looking for. If you do not look for it, you will not see it. And one important factor of adenomyosis is, and that is our own mistake, when we went to universities, we learned the first thing of adenomyosis of a patient is painful period. That's a mistake. That's a mistake. A lot of patients with adenomyosis are completely asymptomatic, yet they are infertile. Okay? So this is why we need really to look for adenomyosis. For the sake of time, I will not go into detail, but this is something which was initially described by this guy whom you most probably know, Rokitansky-Küssner-Meyer-Hauser syndrome, so it's the same guy. So it's the same guy who described the Rokitansky-Küssner-Meyer syndrome. He described also the presence of endometrial glands into the myometrium. You see, the uterus, you have your endometrium, and you have your myometrium, okay? So you would say this is all from one entity, but it's not. It's like India and Pakistan. There is a border. You should keep them separate. You should keep them separate, okay? So they should stay here and they should stay there. They should not go and invade each other. But unfortunately, like in Kashmir, there are sometimes some tensions, okay? So here, some of these cells migrate and go somewhere where they don't belong. And they do bad things there where they don't belong, okay? So you see these glands, they go there, they sit there, but they don't belong there. And they start doing some stuff which is not correct. Good. So if you do a histopathology, you will see the glands of endometrium in a place where they don't belong. Okay? Now, like everything in reproductive health, is this true or this true? Is it bad or is not bad? But I guess anything which should not be there doesn't belong there. If the endometriotic cells should belong to the myometrium, they would have been there from the beginning. So the fact that they're not there means they don't belong there, right? So whether it is affecting, like everything in reproductive medicine, there are some studies saying yes, some studies saying no. At the end, of course, it has an impact. But the question is how you're going to address this question. Now, we see that more and more recently. The question is why? Is it because we have better technologies? We are looking more? Is it really more present? Older patients, multiparous patients, more cesareans, more DNCs, more miscarriages, all that could lead to more. Now, again, you have to look for it. If you do not look for it, you will not find it. It can be up to 70% of women who underwent the hysterectomy. So if you do a hysterectomy and you check it, there is a high prevalence of adenomyosis. You know, very often we are looking at endometriosis. So we are worried about endometriosis. And we tell to women, oh, you have endometriosis, so that is your problem. But what we neglect is that most of these women with endometriosis also have adenomyosis. So at the end, is the endometriosis the cause of problems? Or is adenomyosis the cause of the problems? And you see, 80% of women with endometriosis suffer from adenomyosis. So it's a huge number. And as you can see, the causes, it's mostly iatrogenic. It's caused by us. Mostly it is caused by us. Cesarean, myomectomy, abortion, DNC, endometrial ablation. So any invasive procedure in the uterus can open the border between India and Pakistan, and then you have a problem. So it's important that the border is closed, because the moment you have interaction, there is an opening, then problems can happen. Okay? Now, the only problem is that we have no guidelines. How do you say guideline malum nahi hai? Dr. Ibra, you have to learn my Hindi. You see, don't be jealous when I speak Hindi. So we have no guidelines. We do not have any guidelines. So if you don't have any guidelines, how do you want to do studies with it? Because if you say, I want to do a study with PCO, you say Rotterdam, Amsterdam criteria, I randomize the patients X, Y, and Z. Here, there are no guidelines. So if there are no guidelines, it's very difficult to conduct studies with that. Now, another problem that we have, look at the number of publications. You see, this is the number of publications about endometriosis. This is the number of publications with adenomyosis. I mean, you see the difference? It means our knowledge on adenomyosis is extremely, extremely limited. And this is important, that this is a blind spot that we are dealing with. It is a blind spot, but we should not neglect this blind spot. Now, we know that there is something, it's called a cross mutation, and we know that this is creating a kind of inflammation in the endometrium, and it has an impact on the receptivity of the uterus. The pathogenesis, we don't really know what's happening there, but we know there is a migration of the cells into the myometrium, creating inflammation, and we know that this is estradiol dependent, it's steroid dependent. And we know that this is creating progesterone receptor resistance. Now, there is something, it's called the triad of adenomyosis, but it's not always there. So do not take for granted that all of that would be there. Abnormal uterine bleeding could be there, not always. Pain could be there, not always. Infertility, the fact that we see them, it is there. And miscarriages. So specifically late miscarriages, 12, 13, 14, 15 weeks. This is where the light should go on, that maybe we should look into adenomyosis. Now the question is, how do you diagnose adenomyosis? Obviously, you can have invasive way of diagnosing adenomyosis, and it can be a non-invasive way of diagnosing adenomyosis. Non-invasive, obviously, MRI, ultrasound, but invasive is obviously through hysteroscopy. Now, what do you see if you do a hysteroscopy? Now, first, there is something it's called a strawberry pattern. You see red, and you have these white spots. This is a typical sign for adenomyosis. You have these cystic mucosal elevations. This is a typical sign of adenomyosis. You have some areas of hypervascularization. You see, this is a sign of adenomyosis. You have, like the streets of Mumbai, some holes in the streets. You see, you go into the holes, okay? So these are the typical signs of adenomyosis that you see if you do a hysteroscopy. Do you have to do a hysteroscopy to diagnose adenomyosis? No. I mean, there are easier ways to diagnose adenomyosis. MRI, it's an expensive tool. You can diagnose it, but it also depends on the radiologist, how much he knows. So it's not always diagnosed correctly. But since we are the ones dealing with those patients, it's up to us to diagnose it correctly. So what we have to do, with a simple transvaginal scan, we can diagnose adenomyosis easily and clearly. How? You know, there are certain features that we're going to look at. I will not name them, but you will see clearly through images that we're going to see now how easy it is to diagnose adenomyosis. Now, you don't have to have all the symptoms, but the more symptoms you have, the higher is the risk of having menorrhagia. So the more symptoms, the higher is, the more of these features, the higher is your symptom. Okay? Now, and this picture I took last week, by the way. This picture I took last week from the patient with 15 failed IVF cycles who came to us, and it was a clear case of adenomyosis. Now, what happened here? If you look at the face of a woman, let's emphasize, beautiful woman, would you agree that the face needs to be symmetric? Right? Face needs to be symmetric. If this part is not equal to this part, the woman suddenly becomes less attractive because it has to be symmetric. Good. Now, the same is with the uterus of a woman. So if you take a look at the uterus, this part and this part need to be symmetric, right? So if suddenly you have one of them big, one of them small, that means there is something not correct here, right? Good. So look at this ultrasound. This is your endometrium. Look at this part and this part. Are they equal? No, they're not equal. Okay? So you see clearly this asymmetria of your myometrium is a very easy and clear sign that you can identify. Then you have the globus aspect of the uterus. You have the asymmetry of the myometrium, heterogeneous myometrium. You see linear stratification that you see here. These cysts, and they don't have always to be that big, by the way. They can also be very small. You have small cysts in myometrium, sometimes just below the endometrium. And then you see some calcification around it. You see this calcification around it. You see this calcification here. So there are very easy ways, especially with the ultrasounds that we have today, very easily you can diagnose adenomyosis. And then the junction zone. You see, if you look at the normal junction zone, at the thickened junction zone, it's very irregular. If you see these irregularities, this means that you are dealing with adenomyosis. Another one here, you see calcification clearly here. So we have a lot of ways to diagnose with the ultrasound, is it 2D or 3D, whether a patient is having adenomyosis or not. Now, also the junction zone. You see, if you take a look at the junction zone here and here, you see there is a clear difference between that area and that area. Now, recently, over the past 2-3 years, there has been a new classification, which is good to have, the called Musa classification. So this classification describes the pattern of the cysts and all these variables that you have in order to describe more objectively the presence of adenomyosis. And this is a beginning, it's a good step in order to diagnose. Now you might say, okay, it's beautiful, now we know with a scan, we know what we have to look at. And then, what do? We know the patient has adenomyosis. How do you treat that patient? Now, obviously, one is the pain, if it's present or not. Of course, all of you would say downregulation, GnRH agonist, give progesterone, danazol, dynogest, and so on. But we as infertility experts, what tools do we have in order to treat these women? Now, there is also the so-called three-flap technique according to Osaka. I don't know why, but in Japan, the prevalence of adenomyosis is very high. Is it because they have a lot of food with high estradiol in it? I don't know. But the prevalence of adenomyosis is very high in Japan. But I don't think that surgery should be the first way to go ahead with the treatment. Surgery should come at the end, right? It should not be the first step to treat. This should be really avoided as much as possible. It has obviously an impact, a mechanical impact for transportation of the sperm, but also for implantation of an embryo. And we know that the gene expression of the endometrium changes with women with adenomyosis. There is a disruption of the window of implantation based on a gene expression. And this has been described by various factors and the genetic differences in the endometrium that you have. So what is happening? We are creating with adenomyosis, we are creating high level of estrogen because adenomyosis has aromatase activity. It means adenomyosis is producing its own estrogen. What does estrogen do? It creates progesterone receptor resistance. It means the more estrogen you're exposed to, the more progesterone receptor resistance you have. Why do you think obese women have higher risk of miscarriages? One of the reasons is progesterone receptor resistance. So we need to understand that estradiol aromatase activity play a role. And we know that this is directly linked to the interaction of estradiol and progesterone receptors. So the window of implantation is altered, there is inflammation, and there is progesterone receptor resistance. And this is leading to more miscarriages. So all studies again and again have demonstrated that you have higher risk of miscarriage with the presence of adenomyosis. Now, if you know that you have adenomyosis and you have less pregnancy and you have more miscarriages, how do you deal with that? You would say, okay, let's go for a long agonist. Because with a long agonist, you suppress the hormones and that should be better. The only problem is if you suppress the hormones and you give injections, what happens to the hormones? They go up because you have multifollicular recruitment. So you put water and oil on the fire because first you suppress, then you stimulate. So this is why even long agonist is not beneficial. What is beneficial is going for a frozen cycle. Good. You go for a frozen cycle, you can downregulate, that is okay. On the other side, even if you go for a frozen cycle, we know that the frozen cycle is doing better, but also there are some differences. So if you go for a frozen cycle, do you go for a natural cycle? Do you go for an HRT cycle? Do you do a downregulation? Or are there other options to increase the outcome? Now, if I would ask you, why do we give a GnRH agonist? What happens if you give a GnRH agonist? What happens? Exactly. So first you have a flare-up. You have but then you have a desensibilization. So then you suppress. What do you suppress? Pituitary. What does pituitary do on the ovary? Stimulates the ovary. So if we block the axis of pituitary and ovary, we block the ovary to produce steroids, right? Good. So our aim is to suppress the ovary, not to produce estrogen, because we know estrogen is the bad guy here, right? Good. But in adenomyosis and endometriosis, what else is producing estrogen? The adenomyotic tissue by itself is self-sufficient. It's producing its own estrogen. So you cut one, but the other one is still active. And we as simple physicians, we always thought, just give an agonist, case closed. But that's not fully correct. Because if it is only the pituitary, the ovary, then there should be no estradiol production, but there is. And the biggest problem with these women is the local aromatase activity, as Dr. Akash correctly mentioned. It's the local aromatase activity. So if you look at the data which was published, obviously freeze-all is better. Agonist alone is not really the way to go. You improve, but really not a very significant manner. But we know there is some aromatase activity with these women. So the question is there any other tool to address that? You know, 20, 25 years ago, when I was in university in Brussels, once a week we had to do an emergency consultation for the whole university. So the big university. So the other departments were asking advice from different departments. So I was sitting in the gynecological ward. Then someone from the 6th floor called me. This is the neurological department. We need your advice. I said, what is the problem? We have a, 65-year-old woman. She has no uterus, she has no ovaries, and she cannot walk. So we need a gynecological advice. I said, I'm a very simple gynecologist. I mean, the fact that she cannot walk exceeds my brain activity. So really, I don't know. He said, no, let's listen to the story. And it was a very interesting story. So this lady, years old, she had fibroids, and she had some bleeding. They did a hysterectomy, and they did a bilateral adnexectomy with her. So when she was 50, they removed everything. They put her on HRT. Now, after the surgery, about a year after the surgery, she developed a mass in the Douglas. So they didn't know what it was. They opened her up again, and it was endometriosis. So after removing the ovary and the uterus, with HRT, she developed a big endometrioma in the Douglas. They removed it. They stopped the HRT. They stopped the HRT. After 1 year, the mass came back again. And they did, over the course of 6, 7 years, I think 5 or 6 operations with this poor lady. And at some point, those among you who are surgeons, you will understand that you have a lot of adhesions. And it was at that time laparotomy, it was not laparoscopy. So then what happened, the mass came back, grew and grew and grew, so it was pushing to the iliac nerve, so she could not walk anymore. This is why she was sent to us. So we did an MRI, we did a lot of examination, scan, indeed it was an endometrioma. Now the thing is, we could have punctured it. The only problem is if you puncture it and she has an infection, I mean, it's a big risk of infection, you cannot even operate her. So we excluded anything else, and at that time I was working on my PhD, and one of my studies was comparing clomiphene citrate versus letrozole. Then I said, why don't we put that lady on letrozole? Because there is aromatase activity. So I put her on 5 milligram letrozole. Look what happened with the mass. Disappeared. Disappeared. So this is where we are. And that lady started walking. Within a few weeks, started walking. And you know, when I was working in IVF, they were always young women. But for her, I was the god. Every year, she was coming to me until I left Belgium because she never, ever needed any operation anymore because of that. So I think sometimes we need to think out of the box in order to have a better understanding how we can treat those women. So putting it together, GnRH agonist is one thing. But we need to think that aromatase activity is also there. So the moment we think about that, we need possibly to combine agonist with an aromatase activity. So this has been published a few years ago that they said maybe we should do that. Recently from EV in Spain, they did the same where they combined aromatase activity with agonist. Now we do that since 4 or 5 years, but unfortunately, you know, we didn't publish it yet, I think, no? So we are doing it since 5 years, but they published 3 cases. We have treated 100, maybe 90 patients with that protocol very successfully. But because Dr. Barbara was always saying it's a heterogeneous group, you cannot compare them, so we didn't publish it yet. Now, what is happening? They say, look, indeed, it makes a difference if you combine it together. So this is how we came together with a group of experts a few months ago in Switzerland, in Lugano. And then we published the first Lugano workshop on adenomyosis. So this paper was published, I think, 2 or 3 months ago, where it's a review article where we describe that actually how do you diagnose it, what you just have seen, how do you treat it? Simply suppress the estradiol, and also the luteal phase with these women needs to be individualized. Again, it's not one size fits all. So putting together, increase awareness. Whenever you have so-called idiopathic infertility, be cautious. There might be adenomyosis. With an ultrasound, you can easily find it. It's a disease which is based on estradiol, progesterone receptor resistance. So also the suppression is important, and luteal phase support is important. Remember, you only see what you are looking for. Thank you very much.
That was a wonderful talk, and it was very impressive to learn that we ourselves cause adenomyosis. You know, by operating and so many other things. That's a new fact which we gather. Any questions from the audience? Yeah, please.
Kaya.
Sir, I want to know what is your particular protocol when you do an oocyte retrieval, create embryos, cryopreserve them, give them a break, and then prepare them for frozen embryo transfer? What do you do in that interim period? You give agonist, you give letrozole, and I have heard, I may be wrong, but you do something which is known as uterine flushing. So I want to know about that.
Yeah. So first of all, based on the severity of the adenomyosis, we suppress those women, and we suppress with an aromatase inhibitor and agonist. Now, this is based on the severity, and we are working on different protocols now, because obviously you don't want to suppress them too long because they have these menopausal symptoms and so on. So we are evaluating whether we can suppress for 1 month, whether we have to suppress for 2 or even 3 months. We have one case, and actually she delivered last week. This is an impossible case. I mean, that lady, I never thought she would ever get pregnant. When I saw her uterus, I could not see anything with a vaginal scan. I could not see anything. Her uterus was in her lungs. Her uterus was here. So with the abdominal scan, we saw a huge uterus. And every time she had a period, she went almost to shock because bleeding and pain and so on. Everyone told her you have to do a hysterectomy, but she didn't because she just married. She was 39. She wanted to have a kid. So she came to us, I want to have a kid. We checked the sperm of the husband. He was azoospermic. So he had Sertoli cell-only syndrome. So first we did a microtester with him. We found sperm. Then we said, okay, let's see whether we can do something. So we put her 3 months under this protocol. First we collected some eggs. We had some embryos. We did PGTA because she was 39, 40 at that time. And we found one healthy embryo. 3 months, the uterus went half size, but still it was not where it was. I mean, it was too big. We continued 3 more months. After 6 months, the uterus was like a normal uterus. I mean, if you would have looked at it, you would never have thought that this is the same lady. I mean, it was unbelievable, unbelievable. We put back that embryo. She got pregnant at 11 weeks. She got COVID, high fever, and she lost the baby. We were at square zero because we had no eggs, no embryos, nothing. Then we stimulated again, but the problem is this goes back rapidly. Yeah. It goes back rapidly. Within 3-4 months, it grew back, not like before, but really half the size. I think we did 2 or 3 cycles. We found another embryo. We did the same protocol. She got pregnant and she delivered last week, but the whole thing took us 2.5 years approximately. So the length differs based on the severity. What we do with these women, after the downregulation, we do a hysteroscopy. This hysteroscopy creates a kind of aseptic inflammation of the uterine cavity. And we do that just before we start with the HRT. So it is very individualized, and this is also why we never published it, because it's such a heterogeneous group, you know. Everyone is treated differently, and you cannot publish it, even if it's a case series of 80 or 100 women. Everyone was treated differently. 1 month, 2 month, 3 month, hystero, no hystero. Luteal phase support. These women require much higher dose of progesterone. They require maybe 30 nanogram per ml of progesterone. So when we speak about individualization, this is what we have to look at.
Thank you, sir.
Sorry, Professor, very well, as usual, presentation. The few signs which you showed on ultrasound regarding the adenomyosis, the few of the signs like irregular endometrium, subendometrial calcifications, especially if it is associated with hypomenorrhea, and if there is regularity of the myometrium in India, please keep in mind the tuberculosis, early tuberculosis. Because as you also say, what mind doesn't know, your eyes will not see. And secondly, what dose of aromatase inhibitor which you gave it to that lady, how long you gave it, and if you stop aromatase, will that endometrioma or endometriosis recur once again? Because she came to you for a couple of years and I hope that it has not recurred, but chances are there that it will recover if you stop aromatase inhibitors?
Yeah, I mean, when you stop it, it will come back. That is for sure. And the dose also differs on the body mass index of the patient, because obviously if a patient is obese, the aromatase activity of the fatty tissue is also contributing to that. Then you have the adenomyosis tissue, endometriosis, and the fatty tissue. So you have several factors. So this is why the dose varies between 2.5 to 5 milligram, and the length varies between on the severity. Tuberculosis, I'm happy that you mentioned that. It is true that it happens in India. The only thing is, obviously, I see also a lot of difficult cases who come to our clinics in India. And honestly, I think this is overdiagnosed and overlooked at. Very often, you know, people say, okay, this patient has uterine tuberculosis. We have to be cautious. It is true that India is one of the few countries, together with Russia, that there are still lots of cases with tuberculosis where the prevalence is also increasing. But whether the uterus is affected and whether the endometrium is affected, that could be with some patients, but the prevalence is much less than we think. So I think very often this TBC and endometrium is overdiagnosed. And I have seen many patients who came to me, I have TBC. Then you look at it, that's not. Even if you do a biopsy, you do all the tests, it's negative. So I think it is absolutely true that you have to keep that in mind, but I would not put that as the only differential diagnosis for that. But thank you for your comment.
I think so. Both the speakers deserve a bigger round of applause for wonderful talk. And we'll move forward with the program. Thank you.
Global experts, we have gained an extensive theoretical knowledge about the soil or the nurturer, that is the uterus. So now let's delve into the practical aspects of the same. Next up, we have a stimulating panel discussion on soil, where we'll be focusing on myths and facts of the uterine factors. I invite Dr. Parle, Medical Director, ART Fertility Clinics, India, and Dr. Manjushri Kotekar, Senior Consultant, ART Fertility Clinics, Mumbai, to moderate the panel. I also would like to I also would like to invite the panelists, Dr. Padmavati Ravipati, Clinical Lead and Senior Consultant, ART Fertility Clinics, Hyderabad, Dr. Pankaj Gupta, Consultant, ART Fertility Clinics, Faridabad, Dr. Kanimoli, Director, ART Fertility Clinics, Chennai. Dr. Haresh Vagasia, Consultant Gynecological Endoscopic Surgeon at multiple prestigious hospitals in Mumbai. He specializes in hysteroscopy, laparoscopy, endometriosis and challenging reproductive surgeries. With strong commitment to patient care and medical excellence, sir is dedicated to helping women navigate their gynecological and infertility concerns. Welcome, sir. Dr. Ganpat Sawant, a renowned obstetrician and gynecologist, infertility specialist, and an endoscopic surgeon, serving as a professor and unit head at Padma Shri Dr. D.Y. Patil School of Medicine and Hospital, Mumbai. Sir contributes his vast knowledge in managing high-risk obstetric cases, handling challenging endoscopic surgeons with minimal invasive approach. He is in collaboration with Morpheus German IVF Center to fulfill the parenthood dreams of many couples. Welcome, sir.
Thank you.
Okay, good afternoon, everyone. Without much ado, we'll start with our presentation. Next slide, please. Who's managing the slides? Okay. Which? Okay. So, to be a successful farmer, one must first know the nature of the soil, and for us, reproductive endocrinologists, uterus is our soil. So, in this panel discussion, we'll be brainstorming about various clinical scenarios with respect to uterus, and we will back it up with the solutions and the available literature about those cases, and we'll conclude with a take-home message. So let's begin. This is a patient who is 33 years old with a BMI of 24.5. She has undergone IVF for low egg reserve and IUI failure. She has normal uterus, no evidence of fibroid or severe adenomyosis. Menses are regular with 26 days cycle, 3 days flow. But her endometrium in OI and IUI cycle, we have always seen that grows maximum up to 5 millimeters trilaminar. Now she is on HRT in FET cycle with estradiol valerate, started with 8 mg and then 12 mg. And on 17th day, her endometrial thickness is 5 mm trilaminar. So, what will be your next step, Dr. Kani?
So with this endometrium, if it's a trilaminar endometrium of 5 millimeters and 17 days of HRT with 12 milligrams of this thing, I think we can give it a try for going ahead with an embryo transfer, because even just now everybody spoke that even an endometrium of 5 to 6 millimeters you get a pregnancy.
Yes, we just had a talk, nice talk about that topic, but still we'd like to understand.
Would you do anything before proceeding for an embryo transfer in this patient?
See, adding sildenafil or adding any GCCF, there are multiple things, but none of the RCTs or anybody has proven that. I mean, the guidelines doesn't recommend all these things to go for an embryo transfer.
Dr. Pankaj, would you do anything apart from trying the empirical treatments before, just to rule out if there's any other additional problem?
Hysteroscopy has already been done.
I have just added that thing. It was done and it was normal.
So we have to rule out any adhesions. Apart from that, yes, the various meta-analyses have not shown any benefit of the adjuvants, but some are suggesting for use of intrauterine HCGs and GCSF, and PRPs have also been used, but again, the evidence is very much limited on the usage of PRPs and stem cells in endometrium.
Yeah, thank you. We knew that this topic will come, even though we know that the thickness doesn't matter. But that is why we have dug up some evidence, and these are the guidelines from Canadian Fertility Society, and where we can see that the adjuvants are not backed by a good number of RCTs, and the benefits are seen only in observational studies. So the use of GCSF and the other things like sildenafil and pentoxifylline and all that is not backed by evidence.
So, however, you know, the evidence and the guidelines don't even recommend using PRP currently, but that is something that has been really being investigated, and there are now a few randomized trials available for it. So if these are the two recent studies that have been published, and one of them is a meta-analysis of the randomized trials, which has,
It's a meta-analysis of 8 RCTs, and where they have seen that intrauterine PRP does have some beneficial effects in terms of improving the endometrial thickness, which brings us to our next question. What is the relationship between live birth rate and endometrial thickness in your opinion? We know we have just attended Professor Barry's lecture, but Dr. Ganpat Sawan, what is your opinion about this?
First of all, I am not the IVF expert, so I don't know much about live birth rate, frankly speaking. But coming back to the previous things, one scan showing 5 millimeter of endometrium and jumping to so many solutions, sometimes these solutions can harm more than the benefit. Because all the procedures to be done, if not done properly, the chances of putting an infection or damaging endometrium, putting injection somewhere else can lead to the problem. This is the one scan which we are saying, but what we have to see is patient's history, what's our menstrual cycle, how much is spotting, how much is the bleeding, all these things. So putting all things together, then we can think of doing all these things.
So actually,
next thing is,
just to interfere here, because this woman has undergone, an IVF cycle, and we've already mentioned it's a normal uterus. So this means this is just an add-on finding or an incidental finding wherein we are not suspecting any pathology. After that, a hysteroscopy has been done. So, and that is also normal, and therefore we are asking that what is the point of view of the panelists here about doing it.
So in this thing, I think the live birth rate should not vary between the normal patients and this.
Yeah, so actually a lot of times, as Dr. Baris clearly had pointed, that a lot of times, especially, we are biased and we don't want to do the embryo transfer when we see a thin endometrium, even if we see a good character. And this is what we wanted to emphasize, though it's already been very well discussed. However, thin endometrium is our favorite topic to discuss. So therefore, we thought we'll have a case around it.
Here we have put 2 papers where it's clearly mentioned that the thickness is not related to the live birth rate, even if we don't consider any cutoffs.
And even for PRP, the problem.
Harish wants to say
So
something.
can I just make an addition
Yes, sure.
to this? So basically, it's not about, it's not about only the thickness. If you see the scan, the sagittal view on that, on the previous slides, it is the character, the overall picture of the endometrium, which tells you that, yes, I am ready for, reception of embryo. So what I feel is it's not only the, yes, so it's not only one thing that the thickness, is so much, so and so. Like, even if you do hysteroscopy in this patient, you will not find much of the density of the glands, the vascularity, everything will be great. So I think depending upon the other characters of the findings, it will depend. Like if there is a fluid, if there is some fibrosis, some hyperechoic areas, then maybe you will think of doing something.
Yeah, I think it's like the image and the history is 5 mm triple line endometrium. That is why you were trying to emphasize. Rightly said that it's a normal looking.
So then the thickness is no role here.
So the idea was just to discuss that we do not have enough evidence, or the evidence is pretty clear that thin endometrium will not really affect the chances of pregnancy or live birth rate. So we should not kind of keep postponing the embryo transfers, and after a while, when you know that this is what it is, you should probably plan an embryo transfer in this patient. And even for PRP, the question that Dr. Laura today really mentioned is that when we are doing PRP, there is so much heterogeneity in how we are doing the PRP, what are we doing, what are our cutoffs. So there is no clear-cut guidance around it. Even better studies and more studies are needed to really say that this is really working for majority of the patients here.
So the consensus is that we'll go ahead with the embryo transfer.
So first, HRT. Of course, we've extended the duration and increased the dosage. I think it's worth to try one natural cycle and see.
So we have seen her in ovulation induction cycles.
Ovulation induction, it could be, she should have had ovulation with clomiphene citrate. So
we have done it, it was with injections.
So I think it's worth trying a 2 natural cycles.
Yeah, we'll definitely try 2 natural cycles, but if we see the same findings, we'll go ahead with the transfer.
The thickness, if it would have been same, we'll still go ahead with the embryo transfer.
Yeah, I would like to add something. I would like to do a serum estradiol level also on day 17 when it is 5 mm, and if I'm getting any value which is less than 250 to 300, I would like to extend it a bit more so that I reach the adequate levels of estradiol, then do the transfer.
How much do you think is an adequate adequate level?
So the studies are suggesting various values, but usually if anything more than between 300 to 500 has been shown to be the optimum levels of estradiol for the pregnancy.
No,
So
but that
it's
is
a
the
new
optimum
thing
level
and-
for the pregnancy, but is it the optimum level to achieve that thickness? Because we might see a good endometrial thickness at even 90 and 100. That's how the lining starts growing. But
Plus,
agreed,
it
we
also
have to
varies
ensure
as-
just to rule out that there's any other additional problem.
And it will also vary as per the route of administration of estradiol tablet. If we are giving intravaginal tablet, the values will be very high. So we'll go to the next question because we'll have limited time. This is the original Godzilla versus King of our field, Godzilla versus Kong. Sorry. So on one side we have people who will vouch for hysteroscopy for all patients, and the other side there are people who will vouch for no need of hysteroscopy at all. So what is your personal opinion? Do you recommend pre-IVF hysteroscopy for all? Dr. Padma?
No.
Okay, not just no, we are having a panel discussion. I will like you to elaborate the answer.
I would do hysteroscopy only if I find some anatomical defects, like if there is any polyp or if I'm suspecting any adhesions, or in case of adenoma, I regulated them if I want to do a hyster wash, or if she is having any symptoms of white discharge or any chronic pelvic pain where I'm suspecting there could be any infection. And if I want to rule out chronic endometritis, then probably I would do a hysteroscopy, or if she's had previous transfer failures.
Dr. Kani wants to say something, I guess.
Though evidences say doing a pre-IVF hysteroscopy increases the chance of pregnancy. I mean, there is a likelihood that pregnancies are higher, but routinely it is not recommended. Pre-IVF hysteroscopy is not mandatory for all. If you do a HSG, we will know the cavity, and we're doing a saline sonography also will tell us the cavity and all that. So it is not a routine thing, but studies have stated that pregnancy rate is slightly better in patients who underwent a pre-IVF hysteroscopy prior to an embryo transfer.
Dr. Ganpat and Dr. Harish will like
It's
your
only
opinion.
clinical pregnancy rate. Again, the live birth rates and miscarriage rates is same whether you do a hysteroscopy routinely or don't do a hysteroscopy.
Okay.
Hysteroscopy is basically like a vaginal sonography. It's the eye of the uterus, what is there inside the cavity. There are so many things will be picked up by putting hysteroscope inside, which were otherwise not thought of it. For example, adenomyosis, just now we saw somebody tell us. The adenomyosis need not be symptomatic all the time. Chronic endometritis, there are sometimes flimsy adhesions, and some other pathologies. Sometimes negotiation of cervix, we may not be able to do it. And all these factors, if you are able to do it, and hysteroscopy can pick it up, it will be very nice, because to see and treat, that will be the phenomenon that will be definitely
Would you
useful.
recommend to do it for all patients?
Of IVF, yes. Not for a patient of infertility which are coming for ovulation induction on IUI. IVF, yes, because I have seen people have been given IVF treatment, it is failed. Now we'll do hysteroscopy and let's try and find out something else. I think that approach is not good. IVF is not a simple thing, we should do it.
Normally, with a good scan, we can pick up things like adenomyosis and flimsy adhesions as well. I will also like the opinion of Dr. Harish.
You are correct, but what happens now, that means you are in more favor of sonography, but that depends upon the machine, that depends on person, that depends upon experience, there are so many other factors. And then you write a comma saying that query, there could be something like this. Hysteroscopy, it is at the same cost of a little more than the 3D sonography. And it is definitely C and it, as I said, is going to be different. Of course, that's my opinion.
3D sonography
Sir,
costs up to 5,000, so
hysteroscopy also
hysteroscopy at
again-
least cost more than 20,000.
Hysteroscopy also, like how 3D sonography, like you said, there is interpretation difference. Even hysteroscopy also has a similar.
Yeah.
What looks like an addition to me might not look like an addition to somebody else.
Okay.
And associated, there is anesthesia
So,
involved in this.
can I add? So basically, hysteroscopy is a procedure wherein you can add some complications also. It's not necessary that all the hysteroscopies go without any. The procedural related complications are there. So if you find that the patient is really doing well, have good history, and looking great on sonography, all other parameters are have been ticked right for, then I don't think those patients need hysteroscopy compulsorily. But then of course, if there is additionally, like suppose a failure, apart from all the things are okay, then you add up those patients, because not everybody would be able to do hysteroscopy in a great way, like without complications, without any damage to the endometrium. Yeah. What if everything was normal before hysteroscopy and the hysteroscopy is complicated now and the patient becomes infertile because of that, like a false passage, So something
Totally
like that
agree
can
with
be,
you. So this is a very valid point that definitely there are many studies which have stated that there is a increase in pregnancy rate when you do hysteroscopy. These are randomized trials and the meta-analysis of those trials which have come up. However, the problem is that there is no increase in live birth rate so far which we can conclusively see. So we should decide that on a case-to-case basis rather than doing it for all, because suppose you are doing an IVF cycle for a patient with all normal parameters, it's a plain male factor infertility, and you're doing it for azoospermia. The woman is just absolutely normal. You've not picked up any problem. Would you do a hysteroscopy? No, there is no indication for hysteroscopy. So we need to be deciding this on a case-to-case basis and then only offer hysteroscopy because of the added risk as well as added cost to the patient, especially in a market like ours where every penny counts.
So just 2 lines. One is every procedure has a complication, including HSG. HSG has a complication something like more dangerous than the hysteroscopy. HSG itself is not done by the gynecologist, it is the sonography centers, and it's a very pathetic. If you take a history of all the patients, those who have undergone HSG, they will be very, very badly traumatized, pains, and they will remember throughout their life. And at the top of that, whatever diagnosis has been done by HSG may not be perfect or may not be correct. Thank you.
I totally, again, this is a point of view which is different from what we are saying. We are not saying a badly done procedure is what is the
Let's
way.
not discuss that. That is basically, there has to be difference of opinion.
Yeah, that's a
As
difference in
panel, you
opinion.
said.
That's why my
so
picture
if it
was
is
correct.
my IVF center, I will do hysteroscopy for all. Because we are quite pro at doing hysteroscopy. No, what I'm saying is it has to be availability of hysteroscopic surgeon who is quite well versed with the anatomy, well versed with things what to look for. Like chronic endometritis. When I say chronic endometritis, 80% of my patients, if I show my fellow colleagues who come and see our procedures, they don't see anything in them. And I go zoom in and close to them and then find out that, okay, there are things.
So that
these
is
are
why
the
the picture which I have selected is true. It's an ongoing debate. It's Godzilla versus Kong for us.
Yes.
Yeah. Now we'll come to the next case scenario. She's a 35-year-old patient with 29 BMI, a primary infertility with bilateral tubal block, and undergone IVF. 1 failed embryo transfer, 2 embryos, AA blastocysts were transferred and negative. And we did hysteroscopy. It shows a picture like this. So what is the provisional diagnosis and what is your plan of treatment?
So there are micropolyps, hemorrhagic spots, and hyperemia. This is a typical picture what we see in chronic endometritis.
Okay, and what will you suggest for this patient?
Definitely antibiotic treatment needs to be given. Doxycycline and metrogel is what is preferred.
And for how many days?
For 2 weeks.
So are there any other diagnostic tests that you would like to recommend for this patient?
Yes, we can do a histopathology and send for CD138 immunohistochemistry. So to identify if there are plasma cells.
Do you do it routinely?
Yes, I do it routinely in my
IHC
practice.
testing?
Yes.
Okay, but I think, so if we define endometritis, we know it's the colonization of the endometrium by bacteria, and therefore presence of plasma cells and all those things are seen. However, we don't have a conclusive, or there is no specific battery of tests which is recommended to be done before diagnosing chronic endometritis. Even a good like a hysteroscopy finding, if there are signs suggestive of endometritis, we can give a course of antibiotics and then we can take it further. Would you recommend, doctor, would you recommend rebiopsy after treating this patient?
So basically just giving antibiotic wouldn't work because this is not an infection per se. The population of the bacteria is not like how you see an acute infection. Otherwise patient would have had pyogenic, abscesses or something like that. So there is subtle infection like an exposure to the bacteria, and that's why these micropolyps are there. Micropolyps' main role is to generate and supply immunoglobulins constantly so that the bacteria don't come. They act like a security guard. So, they are present even if so if you send this patient for a biopsy like culture, you will not find any bacteria in it. Doesn't mean that their patient doesn't have infection. Now the reaction remains, and what is your role is to remove these micropolyps physically. Because by giving antibiotics, there is no bacteria, it will not make any sense. So what is more problematic is the presence of micropolyps rather than the infection.
The clinical picture matters.
So
the
what you have to
hysteroscopic
do is
picture
you have to
matters.
physically remove all the micropolyps with the grasper or something, so that you don't damage the endometrium and even the stromal edema and the hemorrhagic patches, because this is where the micropolyps will generate in future. Okay. So this is the recommended treatment now amongst the hysteroscopic surgeons, and of course we have seen that we yield quite good result with this particular therapy. We added up with antibiotics in these patients, and not only doxycycline, at times we give minocycline and azithromycin as well. We have skipped metrogyl altogether because many of the the cultures have shown there is no role of giving metrogyl in
So
this
actually even we are not aware that surgically we need to remove the stromal or the micropolyps. Is there a recommendation around that, or is it just like a practice that we are following?
So basically we don't have any guidelines like that as of now, but the idea is that if you understand the natural history of generations of micropolyps there in the cavity, micropolyp is not bacteria. So giving antibacterial therapy has no meaning. You will do hysteroscopy again, you will find micropolyps.
Okay.
And micropolyps do not shed along with the menstruation. They remain there. They have a deeper
Chronic
base.
endometritis, all the three features might not be seen. You may see
Yeah, you
only
may just see
micropolyps,
stromal
you may
edema.
see only hemorrhagic spots, or you may see edema. But yes, if we see micropolyps, they definitely need to be removed, and we do back it up with antibiotics, and also give them some probiotics.
Would you do rebiopsy again?
No, I don't do rebiopsy, and yes, we don't do routine hysteroscopy just to diagnose chronic endometritis. I usually during pickup I take an endometrial sample and send for ILC for plasma cells, and if it comes positive, we give them antibiotics, and if I see some fluid or something, probably go back and do a hysteroscopy.
Can we see these micropolyps on the sonography?
No, we can see some stromal edema.
Because we'll avoid
We can see some stromal edema and some
So
slight irregularities in the trilaminar appearance in the.
Micropolyps on ultrasound also.
Even Raju Giridi, who is in Karnataka, he has sent me many pictures, but not in all patients.
Yeah. Yes,
you can't see them. If there has to be done on specific day when there is endometrial fluid for it to make it enhanced. Like you miss polyp for what reason? Because there is no fluid in the cavity. The polyp just sticks to anterior and the posterior wall, and you cannot diagnose them on sonography. Like routine polyp, I'm talking about the bigger polyp. We can't diagnose it.
But most of the studies which have been done on the resolution of chronic endometritis by doing the rebiopsies, they have shown almost 95 to 98% resolution by giving either intrauterine. I don't think doing micropolypectomy will be required in this case. Maybe.
Yeah, so I think this is a difference between IVF and hysteroscopic surgeon. This remains.
Polyps is basically reaction to the infection. So it's basically remove the polyp doesn't mean removing the infection.
Yeah, we got it.
So we have to basically treat the infection, and once we cure the infection and remove the polyp, that should be the end.
Yeah, I think that's the ideal case scenario. So the evidence also says is about treating endometritis, and patients with recurrent implantation failure as well as RPL. The current guideline is to do the antibiotic therapy and probably remove the micropolyps if we've seen them, and probably that will give us the best outcome possible.
But there is a substantial variation noted in the pathological criteria, and there is a need for optimization of the diagnostic criteria as well as the treatment criteria. Now we'll come to the next case scenario. She is a 33-year-old patient with a 30 BMI, paraven, living 1, secondary infertility with tubal block, bilateral corneal block, previous LSCS with isthmocele, as you can see on this picture. And she has frozen embryos, and she is for frozen embryo transfer on HRT protocol under depot, date 10, and ET shows 8 mm thickness with fluid within. So is there an impact? What do you think? Is there an impact of isthmocele on IVF success?
Dr. Manorma, would you like to take this question?
Yes, ma'am.
Yeah.
So there is definitely the endometrial fluid inside is embryotoxic. So the success may be decreased if you transfer.
Dr. Kani or Dr. Padma, would you like to comment?
Yeah.
So isthmocele without any intracavity fluid And if it's a small isthmosele, it might not have great impact on the implantation rates. But if it's an isthmosele with having an intracavity fluid, definitely requires correction because it will have a significant impact on the implantation rates.
What will you do in this case?
So how probably a hysteroscopy or a laparoscopy, that will again depend upon the thickness of the residual myometrium that is there at the level of apex of this isthmosele.
How much it should be?
If it is more than 3 centimeter, then probably we can 3 mm, 3 millimeter, we can do a hysteroscopic approach. The isthmosele can be operated.
No,
by
I would like to differ here. It's only 2 millimeter. The latest study shows that the 2 millimeter is what is the thickness required of the cutoff.
For hysteroscopic
Beyond that,
correction.
you should not do hysteroscopy. Yeah, if it is 2 millimeter, the remnant myometrium, then you should not attempt hysteroscopic resection. You should do laparoscopy only, because you will render it much thinner by doing resection at hysteroscopic. But again, hysteroscopic resection of isthmosele will not yield the best result. If the fluid in the cavity is one of the reason, then the uterus which is completely retroverted or a question mark sort of post cesarean, then the fluid will tend to remain on the fundal area at times, even if you do hysteroscopically. So we'll have to try and do, if there is more than 2 millimeter thickness there and you do hysteroscopy, you tell the patient, counsel the patient that we will do hysteroscopic resection, however they may not have any effect on you. So there is always a chance of failure. That's what we always counsel, because it avoids the laparoscopy and the major surgery on that. That is the benefit that you can tell the patient that you have at hysteroscopy.
Yeah, this was our next question actually. For the correction, what is the best approach, hysteroscopy or laparoscopy? And the decision has to be, obviously the surgical correction improves fertility and the symptoms regardless of the surgical route. That is what is the consensus from the available literature. And the RMT has to be considered before deciding the route of
So Dr. Harish, I have a question here regarding the surgery. So when you do a laparoscopic correction, do you do it combined with a hysteroscope and try and identify the lesion? As we see quite a few papers around it, that combined approach will give you a better outcome. And in cases with follow-up, how many cases have you seen a complete resolution? Because what I've seen in many surgeries for isthmosele correction, we still continue to see the same niche and fluid in the endometrial cavity.
I would like to comment here. The picture, this picture is of a patient who has undergone embryo transfer after correction, and the beta HCG is very good, positive. I mean,
but otherwise, on a percentage basis.
Yeah. So basically, ma'am, the thing is that fluid in the cavity will still persist if the uterine axis is not corrected by round ligament plication. If the uterus is hanging down upside down, then the fluid is going to accumulate post menses, because some area of scarring is going to remain. It is the angle where the isthmosele remains, and the laparoscopically it is corrected by, there is a fibrous band which is seen, because if it those images, then it is easy to explain. But there are typically the image, the fibrotic band which runs right at the angle of both the isthmosele on both the side, and that's the one which will guide you to completely resect it. If that is not followed, then you will remain, the patient will have some remnant isthmosele. Combined approach, I mean, I really don't know. We always do hysteroscopy in these patients pre and post correction. Combined approach means I did not understand that you resect part of it hysteroscopically. No, I wouldn't do it.
Actually, there was a publication in which they identified via a
I agree.
Yeah,
so that is what. So concomitant hysteroscopy at laparoscopic correction.
Yeah.
What I would say, simultaneous hysteroscopic like combine means, I thought that maybe resection at hysteroscopy partly. No, that we don't do. Yeah.
And vaginal approach also has been mentioned in the literature, but I guess that is not.
No, there are people who are doing vaginally also, and I mean, because there are not many vaginal surgeons left now, we don't have such a number, but yeah, there are people who can do it.
Isthmosele.
Yeah, so that is what. So bands are not to be corrected; they are to guide you at laparoscopy, and vaginally they can definitely there is.
So vaginally, you will not be able to cut the bands, right?
Yes. So each and every procedure has its own limitations and benefit. Like laparoscopically, if somebody is not really good at laparoscopy and good at vaginal, like when you're talking about me, if they challenge me to do vaginal, I will not be able to do it. I'm sorry. But if they tell me to do laparoscopy, I will do fantastically. So this is what is depends upon the operator. Now, of course, because in our field there are many vaginal surgeons, very laparoscopic surgeons, we cannot say that the vaginal surgery is not good.
No, I'm trying to understand your same thing.
Ah.
You said if the niche is just corrected histoscopically,
yes,
the question mark sign of the uterus because of the
yeah,
adhesions
that will remain. So that is
and
what
the
I'm
fluid
saying.
will remain, so
Yes.
the fertility will not be addressed.
Yes.
The same thing if I can approach vaginally because we do a lot of Shirodkar circular
Yes,
routinely,
yes,
so the
true.
isthmocele is at the same place.
True.
So we may able to correct the isthmocele by
But the uterus will
refashioning,
hang still,
but we
yeah.
will not be able to correct those adhesion bands which
Yes,
are going
yes.
up.
So that's the
it will
limitation of
also-
vaginal correction.
It will not then solve the fluid at the fundus,
Yes,
which you
it
said
will not.
earlier,
It
and
will
it will not be useful.
So that's the limitation of vaginal.
That
That's
is
what
the
I'm
question,
saying. Yeah.
sir. Which
But
approach
the
is the
question
right
is, vaginal correction is possible? Yes, it is possible.
It is possible, but it will not optimize the treatment.
Basically, there are so many isthmosoles, if our mind knows, we will be able to pick it up. But all isthmosoles are not infertile patients. So which patients have this collection in the endometrial cavity which you showed?
Yeah.
One is retroverted. Second one, if it's a big isthmosole, whereas lower end of the isthmosole acts like a flap. When the menstrual fluid comes, it gets collected in the cavity. Some amount goes down, the isthmosole remains like that. Once the menstruation gets over, whatever is collected starts coming down, dripping down. Some part again comes down, that is through the external os, and some part goes into the endometrial cavity. So this is the bad isthmosole. Otherwise, isthmosole, since tomorrow if you start scanning patients, it's quite common because we have so many number of patients
Yes,
with
yes.
previous
So
LSS.
we are only, literature also says that isthmosole associated with the intracavitary fluid needs to be treated. Now we'll go to the next scenario. Okay, she is a 40-year-old patient with a BMI of 30. She has tubal factor infertility and she has undergone bilateral salpingectomy for 2 ectopics. Now she is in perimenopausal picture, 0.001 AMH. Hysteroscopy was normal. On ultrasound, we can see a 3 centimeter intramural fibroid which is not touching the endometrium, and endometrium is nice 7 mm trilaminar. She has undergone donor egg treatment and undergone one good blastocyst transfer, and it was negative. So, will you go ahead with the second embryo transfer, second attempt of embryo transfer?
So
This is also Godzilla versus Kong.
Yeah,
of
so
our
basically
field.
it's a question about this fibroid which is not touching but still very
not
close.
distorting, not
yeah,
touching.
not distorting.
3
So for a
centimeter.
non-distorting myoma, what are the IVF specialists going to do about it? So
Yeah,
Dr.
Dr. Kani.
Pankaj or Dr. Kani?
I would not operate on it because it's not distorting the cavity, it is not doing thing. Maybe we can go for a suppressed cycle, putting her an agonist and suppressing the fibroid to a certain extent and go for a transfer. But this point of time, but if you don't find any other reasons other than this fibroid, then we can go for a myomectomy. But it is based on the case basis because she had already failed 3 failed embryo transfers.
No, one embryo transfer, but with donor egg cycle.
Yes.
Yeah.
So,
Okay.
may I add? Do you get any patients of myomectomy who have poor endometrial thickness post-surgery? You
Yes,
get
yeah.
yes,
Yes, yes,
So
yes.
this surgery
Depends
then
upon
will
where
render.
the
Yeah, no, no,
Yeah,
no,
surgery
I'm
done
just adding
badly,
to it.
yeah.
What I'm saying is that the surgery can make the patient infertile. So one minute, sir. Listen. Yeah, no, badly done. But sometimes the reaction, the healing is poor in the
Yeah.
patient. So
Patient's bad luck.
you may render this patient with 7 mm now, will become 5 mm with not good lining. So I would not touch this myoma unless it's really
Yeah,
very.
so rightly said, that's what the evidence tells us is that removing these myomas may not really improve the pregnancy rates in patients. So therefore, we should rather try something else if we think that this is maybe suppress and try and transfer. Otherwise, probably just go ahead with another transfer and it should be a good outcome. That's what we can hope for in these patients.
Okay, now we'll go to the next scenario. She's a 35-year-old patient with a BMI of 27.88, primary infertility, and she is for IUI. And the routine screening 3D ultrasound shows a small fundal dip like this, arcuate, quadricepted. And endometrium is nice, 8 mm trilaminar. Treatment plan, anybody?
Just go ahead with the IUI.
Okay. Anybody wants to say something different?
No, you have to go ahead with the IUI because it's an arcuate uterus which is equivalent to normal uterus as per the classification by ASRM. So we can go ahead with an.
And if this patient doesn't conceive in IUI 2 or 3 cycles and for some or other reason she is for IVF, and what will you do now?
Still, it remains the same. We won't be doing anything about it.
Okay, so the answer is not just because she's only for IUI.
Yeah.
Okay. Anybody wants to comment anything differently? No, right? So we'll go to the next scenario. She is a 31-year-old patient with a 26 BMI, primary infertility, male factor, endometrial cycle and HRT cycle grows maximum till 7 mm trilaminar, no fibrosis or severe adenomyosis. And when she had done her HSG, the picture was like this. This was before she went for IVF. So the question is, what is the most accepted criteria for diagnosing a T-shaped
Pankaj, you can
cavity?
take it. I think it's more of theory. You will be good at it.
T-shaped uterus actually is not very well recognized, and also the latest ASRM, the MAC tool does not even say that T-shaped uterus is any entity at all. So in this case, yes, I would like to do a hysteroscopy to rule out any lateral adhesions present, giving this kind of a picture on an HSG.
You won't consider first the ultrasound findings?
Ultrasound, I'm supposing.
Okay, so yeah, that is what we want to emphasize, that we should not just rely on the HSG picture, and we should take into consideration the 3D ultrasound picture. Dr. Padma, you want to say something?
So yes, you can do a 3D scan for this patient, and yes, you measure the lateral indentation, the lateral angle, also the angle at the cornua, which we call it as a T angle. And if there is a lateral indentation which is more than 7 mm, and if the angle is obtuse, if it is more than 140, 130, and if the T angle is less than 40, then we take it as a T-shaped uterus. But this is a quite rare entity. Like Dr. Pankaj said, we have to rule out adhesions. So any intrauterine surgeries can also cause this. This is mostly iatrogenic.
Yeah, so this is a CUME classification which you just mentioned, in which they've classified and basically defined the T-shaped uterus. Apart from that, we don't have any specific classification to define it. And a 3D scan is considered a good enough diagnosis for it, but HSG should not be taken as a diagnostic tool to diagnose this. It's not a very common entity per se that we see, and we have to be very cautious if we are diagnosing a T-shaped uterus.
Which brings us to our next question. Would you consider correction for this? Any?
Then yes, we would try to do an adhesivolysis, and if the cavity is adequate for implantation, then probably a lateral metroplasty is not required. If it is very narrow or tunnel-shaped cavity, then yes, a lateral metroplasty would help.
Yeah, Dr. Kani wants to say something.
Doing a metroplasty in this patient can put the patient for intrauterine adhesions also. So it's better to not to do a hysteroscopy.
Again, the badly done search. Yes. Which I don't want to say badly done, but yes.
So basically, it's not like that. See, if you're looking at the HSG picture of the previous slide that you shown, it is very clear that it is a symmetrical T-shaped uterus. It's not asymmetrical. Now, no adhesions by any means will be symmetrical. Okay, you cannot have absolutely symmetrical adhesions. Of course, you can have. I'm not saying that you cannot have ever, but it's not common to have the adhesions which are symmetrical. When you see symmetry which is gone, then it's something to do with the dysmorphic uterus. And ASRM does not recognize it, but there are other societies or other groups of interested people who call themselves as experts. They recognize it. If you go 2 slides back and you see further. I'm talking about the conjuta, okay? Now look at the picture. The first one is showing U0. Now U0, the size is really good, okay? Now coming to the U1, which is the dysmorphic uterus, the size itself is smaller. You see all the uteri, you see distinctly the size of the U1 class is small. So the uterus which is a small moiety tend to have implantation failure higher.
So you'll do metroplasty for this?
Yes, I would do metroplasty because if you see the lateral walls, they are thicker than the mean myometrial thickness of these patients.
So you will correlate it with the ultrasound picture?
Of course, you should be, yes.
That is what we want to say.
So actually any uterus having a Mullerian abnormality will have a decreased implantation.
Not a hysteroscopy.
So just to, they will have a decreased implantation because their gene expression itself is different. They have HOXA10, less expression. So just trying to increase the implantation by doing a metroplasty in a normal uterus is definitely not indicated. If cavity is adequate, I think good enough.
We can go ahead.
Yeah.
Yes. So the decision is on case-to-case basis.
But at the same time, if hysteroscopy is being done, it's diagnosed T-safe, why not I know everybody will focus on it can cause adhesions again, but at the same time look at the advantages. For example, yes, whatever benefit is there for implantation, but think about patient reaching till the term. Think
So
about the
exactly
malpresentations.
in which patients will you consider
Think about
metroplasty?
the malpresentations, malpositions, patient going till the term, preterm deliveries, and so many problems at the time of delivery. So it's basically very important that if you are going inside and doing it, we must focus more on the benefits than the risks.
So exactly on what basis will you decide you will do metroplasty for this patient? And
With all this diagnosis, if you said once you go in and if you find it is there, we will do it.
so
We'll
on
do it.
ultrasound, if you see,
Yes, it is
Yeah,
diagnosed, we'll do it.
yeah. So that is what we wanted to say. So this question again looks like a very simple question. Are you sure? Time is up.
Long back.
This is the last case now.
Yeah. So this is 29 years old patient with 24 BMI, and she is also for IUI, and incidentally on ultrasound we see an endometrial polyp of 7 mm into 6 mm with a follicle which is ready for triggering. So what will be your next step?
Dr. Sawant, will you proceed with the whatever we've planned, like an IUI for her?
No, we have to remove this polyp. That is straightforward. I have to remove this polyp, and even if it is badly removed, we have to do it. It has to do it.
Sir has taken it to heart, I guess.
Pankaj, will you remove it? Dr. No. Yeah. Centimeters. Yeah. Right.
So here the literature is not supporting polypectomy much, but practically I guess everyone will consider removing the
So I
polyp.
always tell them that they are autologous IUCDs or IUDs.
Yeah, but this patient is just for IUI, and because her follicle is ready, I mean going ahead with IUI in this cycle after counseling also.
No, but
is a
how
valid
did she reach the IUI? This polyp is quite big. Should have been picked up
So
earlier.
suppose she has just come to us with a follicle
Suppose
which
if
is
there is
ready
single
and
embryo left for her now.
This is an IUI cycle.
Now what will you do? That's the scenario. So it's up again,
Yeah.
there are so many factors that you
However,
have to look into.
yes, right, but
it's not only one factor that you see and you decide that you do this, you do that.
of course, see, we do a lot of things that we think has to be done,
So
but
metroplasty also
does,
same way,
but do
chronic
the-
endometrium same way.
Yeah, so this is with
It's
the
not only one
polyp that honestly the evidence doesn't support that removing the polyp would really, or keeping the polyp inside would really have a great impact on the outcomes. That's the whole thing. But yes, if you, as you said, if you have one embryo and you see anything, you'd want to go ahead and remove the.
Every time we should not go by evidence. Sometimes we should go by experience and the logic, and what is seen in front, we should treat it. Thank you.
Okay, thank you for a very fruitful discussion. Thank you everyone.
Can somebody take photograph? I just wanted photograph with everyone.
Please come join. It's okay. I thank all the experts for such a thought-provoking and stimulating session post-lunch. So we can never end any conclusion related to when we are discussing fertility without focusing on discussing about the heart of the assisted reproductive technologies, that is the IVF lab. So let us keep our postprandial energies high to discuss the third and most important aspect to achieve a successful IVF outcome. Our next session is all about the IVF lab. And to chair this session, I would like to invite Dr. Rajvi Mehta, Senior Embryologist and currently consultant at Cooper Surgicals, India. She is a pioneer in human IVF with one of India's first PhDs in the field. With over 3 decades of experience, she has made significant contributions as a researcher, embryologist, and trainer. She serves as a convener of IFS SIG, Holistic Medicine,
With her vast experience and knowledge of embryology, she continues to influence the field of reproductive medicine. Welcome, Doctor. I also like to invite Ashwini Dahale, embryology lead, ART Fertility Clinics, Mumbai. She is an ASHRAE certified clinical embryologist with over 15 years of experience. She specializes in advanced IVF lab setups, team training, and techniques like PGS and PGD, consistently delivering high success rates in assisted reproduction. So I request you to introduce the speakers.
Hi everyone. So moving on to next topic, which is AI in ART. I would like to welcome Ibrahim, who is a Group Director, IVF Lab Senior Embryologist, ART Fertility Clinics. He has a degree in Genetic Engineering, Healthcare Management, Data Science and AI, and IVF Biotechnology. A PhD candidate in Reproductive Genetics, he brings over 10 years of experience in embryology and was a part of the founding team of ART Fertility Clinics in the Middle East. He has contributed to several scientific publications in reproductive medicine.
Thank you very much. Good afternoon, almost good evening. So, yeah, my topic, luckily, it's an interesting topic, not only in the field of reproductive medicine, but I think in almost every part of our life today. There is a lot of focus on artificial intelligence. Is it in the medical part? Is it in the engineering part? Or simply in social life? So in this presentation, I thought instead of talking about details in neuroscience, or these CVS, or these kind of techniques that they are using, maybe as scientists, it will be nice to understand why do we need artificial intelligence today, give some examples, and most importantly, look at the challenges so that when we jump on the train or when we use the AI, we use it correctly. So let's start with our ultimate goal, a successful pregnancy that will result in a live birth. Now, in order to achieve this, we know that we all need to collaborate our effort, physicians and embryologists. And if I look at the results over the past decade or two, we can see that there is continuous improvement. How do we explain this improvement? It's very simple. It's because of the knowledge we're gaining. In this paper, which was very interesting, they looked into the number of citations in the past 10 years compared to the decade before, which, as Dr. Fatemi said today, it's still a relatively new field of medicine. You can see there is an exponential increase in the number of citations, which shows that we are more interested in doing research, and we are developing more research, which will develop into better knowledge. Also, the amount or the number of keywords being used increased as keywords themselves, and the number of keywords, which shows that not only physicians or embryologists are searching about scientific evidence when it comes of IVF, but also maybe the patients. So in addition to the knowledge, luckily we had also advancement in the technologies. And one very simple example of advancement in technologies were the incubators. So we started with large box incubators to benchtop incubators. Now we have time-lapse incubators, which is a very nice improvement in our field, a very nice utilization of technology in our field. What are time-lapse incubators? Simply, it's an incubator that provides temperature, provides gases, with one addition. This feature is a camera that takes a picture every 5 minutes or 10 minutes. Now, after 5 or 7 days of culture, you will have hundreds of pictures that you can display as videos. Now, with the introduction of time-lapse technology, we also introduced a new term in our field, which is morphokinetics. Morphokinetics is simply a specific cellular division at a specific time. So T3 is a morphokinetic point, which means time between going to 3 cells from 2 cells. This is an example of a video of an oocyte. You can clearly find the timing of fertilization, exactly when the PN were faded, first division, second division, and so on. And the nice thing is you don't need to take out the embryo out of the incubator. So you don't need to expose the embryo to undesired conditions. Now imagine, before using time-lapse technology, every day or every 2 days, we take the embryos, 5 seconds, we take a look, we write down what do we see. So is it 8 cells, is it 7 cells, and that's it. But After introducing time-lapse, there is a new world that we didn't know about. A lot of information we gained. We learned a lot about abnormal division. You can see here it went from 1 cell to 3 cells, and then back to 2 cells. This is referred to as reverse cleavage. Now, if I don't have a time-lapse, and you will take it when it was 2 cells, you write 2 cells, I will take it 3 cells. Both of us, we will not know that we went from 3 cells to 2 cells back to 4 cells. This is another example of multinucleation. You will see now it will divide to 2 cells, and here there are multinucleation, and then it disappears. So if you took it 1 hour later or 1 hour earlier, you might have missed this phenomenon. Why these phenomena are important? Because all of these were linked to outcomes. Is it blastulation? Is it implantation? Or is it miscarriages? And their prevalence was not very low. So some of these features, I think it's not clear here, but it's 18 to 20%. So 18 to 20% of our embryos, they have abnormal division that is associated with lower reproductive outcome that could have been easily avoided if we have this technology. So since then, I mean, we all heard about so many studies. They compared to select embryos for a transfer based on morphology only or morphokinetics. Many of the studies, they support the use of morphokinetics. They see you get better ongoing pregnancy, better implantation, and lower miscarriages. But that is not the point. No, we learned a lot, which was perfect, but we wanted more. So we started to see if by this morphokinetic points, we are able to predict the diploid status of the embryo. So instead of doing biopsy, PGTA, it's a cheaper, non-invasively, we can find this information. Now, there were several studies. Just to give you an example, this is a model created by the group of Evie, Natalia Basilli. Was working very well for them. The group of Laura Rienzi, they tried to use the same model, but it was not working. And then they found out that maybe one of the reasons is the embryos were subject to day 3 here, and in the other group, day 5. What I mean is, what was working for one group didn't work for the other, for maybe protocol-related, maybe population-related. So we focused a lot on this. There were a lot of papers, including the Esri papers, explaining why these models, they don't work for everyone. Is it the patient population, age, the infertility factor, many factors. Add to these information that we have in the lab. Is it the type of media that we use? Is it the temperature? Is it the insemination type? Is it the insemination time? Is it the protocol? Is it the sequential media, culture media, pH, light, all of these factors. So add all of these time points to the morphokinetic points. Add to that what Dr. Fatemi and Dr. Barish were talking about. Very simple. Actually, the morning session, all of this information should have been used. Is it related to the patient with their BMI, with their AMH, with their AFC? Is it related to stimulation? What type? What was the dose? At which size did we trigger? All of these eventually will have an influence on the quality and the destiny of the embryo that we want to select. And we were naive enough to think just by taking a couple of morphokinetic points, we will be able to replace PGTA and use it. Why I'm going to this information? Because already in these 3 slides, we have more than 100 data points. So simple statistical methods, we will not be able to create these models that we are expecting. What do we need here? We need machine learning capabilities. We need artificial intelligence. And this was the first application of AI in our field, utilizing big data. We have a lot of information, but we don't know what to do with it. And having newer technologies mandated that we use artificial intelligence because we're getting constantly higher, a lot of information. Now, in general, in any field, is it our field or other medical field, AI can be used either if you want to do classification, you want to do prediction, or if you want to do automation. So these are the 3 ways that you can use machine learning and artificial intelligence. Let's take some examples. So remember we said that having time lapse, doing the annotation, is better for the embryo because you don't need to take it out. But it's also time consuming. And there is variability between the operators. So this is one of the first and good automated annotation software that were presented in our field. So simply, it will take the video, it will do the annotation itself. And if you calculate how much time you would save for the embryologist, it will be approximately you're saving 1 month worth of work for an embryologist every year, just by having this automatic annotation. This is one advantage. The second very important advantage is inter and intra-operator variability. So especially in the context of studies, especially if you want to use this as a basis for a more progressed model, here we avoid all of these variabilities. Because it's the same software, it's very objective, it's doing all the annotations the same way every time. Another example is the image analysis. And this is something I find very interesting because really with humans, this is something we lack. We don't have the ability to analyze images. So if I give you a picture of a blastocyst, you can draw out 3, 4, maximum 5 data points. But with a specialized software for image analysis, it's totally different. They don't look at it as only a picture. They do this segmentation. This picture for the software is almost 50 pictures. It divided into planes, segmentation, you change the contrast, and so on. So it could and can see things that we cannot see with our eyes. One nice presentation of the image analysis was this paper, and I like the way the author presented it because it really showed why we need artificial intelligence. So what they did is very simple. They said, give me images, I give you grading for inner cell mass and for trophectoderm. And to show you that I do good job, or the software is doing a good job, I would compare my results to 6 embryologists. And they asked the software, the embryologist, to choose either good, yellow, poor, blue, fair, gray, and brown, uncertain. These first 6 lines represent the embryologist. It's a multicolor. You can see almost all the colors because this is a human nature. We're not very decisive, right? Is it excellent or poor? No, it's in between, right? If you take a look at the first time, which is the software, it's only 2 colors. The software either chose good or poor. Very objective way. And what is also more interesting, when they took the majority of the votes of the embryologist and they compared the consensus against each one of them or against the software, they found that the software is closer to majority of votes than any of these embryologists. This is another application. So this is an AI tool. We'll take the images and the videos of the division, and then we'll give you a rating of high score, which is recommended for a transfer. It means high chances of live birth compared to low score. Now, of any embryologist, even physicians, if you take a look at the ones scored as high, almost all of them we agree. They look like good quality embryos. But what was surprising that there are some good quality embryos in the low score ones. And the explanation was the software identified a pattern that we cannot see. So it saw that sometimes you have these slight clumps of granulation in the trophectoderm, and this was associated with lower live birth rate. So this is identified by the software, but we cannot see it. The second explanation of the authors is they noticed that if the inner cell mass was not focused enough, the software gave a lower quality, which shows that sometimes also with these tools we need to be careful because there could be some bias. This publication caught a lot of attention for one reason. This is one of the very few studies that had an accuracy or area under the curve of more than 0.9. And it was, they tried it in different centers, and the results were reproducible in all the centers. What they did is they took these embryo-related information, and they created this model that will be able to predict fetal heartbeat. One of the things is excellent, very nice, more than 0.9, but we don't have any information about the clinical part or the type of endometrium preparation and so on. Tools, you know, this is still in the, I hope it works. Yes. So this is still in a trial phase. So this is how ICSI maybe will look like. It will take the sperm. This is a robot. Will take the sperm. Will inject the oocyte. This is a clinically applied tool where while you're searching for a sperm, it will select for you the sperm with the highest chances of fertilization. Yeah, so I don't think Dr. Fatemi will be able to ask the robot why oocyte was not fertilized. This is published by the group of Santiago Monet, very interesting, the first live birth after an automated ICSI. And what was interesting / provoking is the one who did the ICSI is an engineer with no training in embryology. So it's an engineer, he's using a robot, right? They did the ICSI, you can see here in the pictures, got fertilization, good fertilization, blastulation. They first validated it in mice and it has similar results. They validated it with the human, they had similar results. It's not better, but at least you don't need to go through training, all of these things. It's an engineer who did the ICSI. Even I think for me, this is one of the things I would like to have in my lab. And this picture, I hope you can see it clearly. This shows the difference between an AI or a robot and a human. So this is how we prepare the media where we put the embryos. So you can see in this dish, hopefully, that the distance between the drops is not consistent, which is normal because you're manually preparing it. You can see here that also 2 of them were so close that they merged. This is, you can see even the size of the drops, you can see this size different than this side, different than this side, which is again the manual. Look at the machine. Same volume, very consistent, time is consistent, so you don't need to worry about the evaporation, you don't need to worry about osmolarity and all of these things. So these are the things where I think artificial intelligence is needed in automation in the lab. This is one of the things that also I admired the idea and the application, and actually coincidentally, we were discussing with our statistician, Dr. Erkan. We gave him this idea and we were in the process of combining to do. So out of courtesy, I was searching and then I found this. I was slightly disappointed, but also happy. So what they did is they said, instead of waiting till the end of the month, where you do your KPIs, you meet with the doctors, you decide that you have lower fertilization, you go investigate it, and then it's 5-6 weeks to know that, yes, this incubator requires fixing, for example. This will be integrated in your system. It will catch trends in the division and will tell you before the problem happens, look, based on this, we expect that this month you will have low fertilization. So you take action immediately. This is for the doctors. Also, if you have many patients, even we see this in studies, follicle size of 14, but is 14 for me, 14 for you, and so on. So you have these automated tools. It will count the size, the number of follicles automatically. So these are a list of some of the publications in the past 2 years. This doesn't even include 2024. So you can see that there is a lot of focus on artificial intelligence. But what I want us as physicians and embryologists to really think about is the next few slides. What are the main challenges? The first challenge is bias in dataset. So if someone develops something, not necessarily in, for example, Europe, not necessarily it will work well for your population or for our population. A nice example is this. So this is 2 universities or 2 centers in Germany. They wanted through images to be able to detect melanoma, okay? And they had this machine learning model. It was working perfectly. They tested it. It was excellent. And then they got a black patient. Immediately, he was diagnosed as cancer. Why? Because all the training set where we developed were Germans with white skin. So of course, the system cannot identify this is a dark spot or this is a skin color. The same in this paper. So this is 2 centers, one of them in a university hospital with the biggest oncology department. What they wanted is they wanted to detect a lung disease through the X-rays. Okay? They created the model, but while they are using it, they saw that the system is constantly giving higher chance of being diagnosed with the disease to patients of this center more than this center. And later the explanation was, you can see clearly one center has brighter images, the other center darker. This is the center where they have the biggest oncology in the city, right? So most of their patients are already patients with cancer. That's why the software cannot identify all of these things. For the software, having darker pictures is a sign or is associated with having cancer. We've published and we've discussed this before. Look, there is something called ethnical and socio-cultural differences. So that's why we need to not immediately utilize the tool. You need to see which data set, what was the training data set, does it work for us, test it first before we jump on it. This is, again, one of the most important is the quality of data, the clinical data you have. And this is a very nice paper. What they did is they checked if the number of missing data in your electronic medical system is associated with the area under the curve with the model. And they saw that the more missing data you have, the lower the accuracy. Okay. This is number one. Number two, if this happens on a model that is already validated, imagine if you still want to develop the model and you have missing clinical data. So for example, let's take this. This is a machine learning model that the aim of this model is to predict what is the best starting dose for the patient. Okay? And the information you need to put is female age, BMI, AMH, and AFC. Now, it's an excellent tool, especially if you have these satellite clinics, you have junior doctors, then it's easier for them. But my question is, how come we will rely on a tool will tell me what is the starting dose if until today we are debating the importance of basal FSH levels? If until now we are, so based on them, to give X unit of recombinant FSH is equal to giving X unit of urinary FSH, right? Because it's not in their model. So imagine all of these differences. Of course, it will invalidate the outcome. So having and developing one thing is nice, important, because we need to start from somewhere, but jumping on it, utilizing it without understanding all of these limitations is something else. This is my favorite example of all. So for who doesn't know what is this is the dish that we use for a time-lapse incubator, okay? So it contains 12 wells. In each well, we put one embryo, okay? So for example, assume that out of these 12, you have 2 embryos. Both of them are AA quality, identical, exactly the same. Which embryo you will select for a transfer? Embryo number 1 or 12? They are exactly the same. It's human nature. We will use one. The software doesn't know that this is human nature. So for the software, if the embryo is in any of these wells, immediately you will get higher chance of live birth. Why? Because of selection bias. Because the data set that we used was biased. If I have 1 and 12, you transfer 1 gets results in live birth, 12 doesn't result in live birth. So it's an advantage for the software that you are in 1 to 12. That's why we need to be very careful when it comes to this. Simply in the next few slides, I want to show you what we learned out of this. We understood that AI is coming, it's very important, it's helpful for physicians, for embryologists, and for patients. The question is how to use it. The best way is you develop your own models. This is one of the examples of the models that we have published recently, just a couple of months ago. This is a selection model, and the idea behind it was to develop something similar to the fetal growth charts that mainly fetal medicine doctors they are using. So you take the morphokinetic points, you put it in the system will give you a score. The lower the score, the better. The concept is, what we found is, fast embryos, not good. Slow embryos, not good. The best are the embryos with low fluctuation. So if they are slightly slower, that's okay. If they are slightly faster, they're okay, but it should not be huge differences between time points. And just to show you how it works, I mean, we applied it, we saw that it's even more important than the embryo morphology. So the score that it gives is more important than the embryo morphology because these are euploid embryos. So look, this is the morphology, C quality, this is the red C quality. But the C quality, when it was considered low variability, which is very good, it had higher or similar pregnancy rate than the A quality of high variability, which shows how powerful is this tool. So it's very simple. You have a link, you press on the link, you put all this information, and you will get the results as a score. If you have 2-3 embryos, then you do, and you select the embryo with the lowest score. The second thing is something also we're working in collaboration with the university, New York University, and our aim is to have this holistic model. We want to include patient information, we want to include stimulation related information, embryology, endometrium preparation, and so on, in order to have this tool. Of course, this requires a lot of data, it takes a lot of time, so it was divided into phases. The phase was published or presented at ESHRE last year. So it's a forecasting model. So based on the first 24 hours of division, the software can do the annotations and can give a very high accurate prediction of what will happen with the embryo. This is important in cases you debate, for example, you want to do PGTA, yes or no, if you want to do fresh or not, right? If you want to accumulate, to start preparing the patient, luteal stimulations, and so on. So I think over time, so I would conclude with this, the IVF on chip. I think you heard this terminology, so we're going there at a certain day. Everything will be done with this simple chip using technology, microfluidics, and all of these things. You will put the oocytes, they will be automated with the denudation, automated with the insemination. Even imagine if you can also utilize non-invasive DNA and the metabolites, right, in order even to select the embryo. So hopefully by that time we'll find another thing to do. So conclusion is, yes, we should not be intimidated by AI. We should not jump on it. Clearly, we're still learning in our field, so for sure, whatever we have now is not the final version of what we want. It's still version 1, and it will keep improving. Of course, if we have the correct data, correct collection for the data, interpretation of results, the most importantly, to know when and how to apply it. Thank you very much.
Thank you for a very comprehensive and balanced talk. You didn't go into either directions. You talked about ethnicity, which is very important in clinical diagnosis. Do you think at this very early stage also it would make a difference?
Yeah, especially at this stage, because this is a learning process. It's a train. If we don't jump on it, we will miss it, right? So actually, the take-home message should be identifying these differences. It means that you should know that you should, at a certain day, if you want to use such a tool, you should use your own
data.
So what does it mean? It means that you need to start collecting the data from now and correctly. You know what I mean? You cannot, if someone published something that is useful in Europe, it doesn't apply for you. You cannot wait for you. You will do it for yourself. It requires big data and so on.
So with your very preliminary work, have you seen any differences with ethnicity?
No, it depends what we're talking about. What
No,
I mean
I'm just
is
saying the general use of AI.
Yeah, but for example,
selection.
If you want a model, for example, to select the best embryo for transfer, I doubt that we will see these huge differences. But if you want to develop the model that will be able to predict the starting dose, yes, it will.
Yes, there is
you know what I mean?
You're dealing with humans,
of
yes.
course.
I'm talking of embryos.
Yeah, it depends on the application.
I think we're running late, but
in terms of predicting the outcomes for PGT relating with the morphology, it is also useful.
Yeah, even that we can debate it because, for example, if we compare the population in UAE compared to here, in PGTA only, I would say we should see differences. Why? Because the prevalence of consanguinity in UAE is much more than here in India. Consanguinity was associated with segmental aneuploidies, so you expect that you will have higher aneuploidies. So maybe, yes, this is something where we would see differences in the population.
So just one thing, when time-lapse came in, everybody was very excited and it didn't give the results, it gave a lot of knowledge and information and knowledge. Do we need to standardize the procedures to a great extent? Because that point of time, you ask anybody, they said you create your own data, which is fair enough. But at least the range. So, the major difference was the time zero. People started talking, but time zero, should it be time zero of time of ICSI or it should be the time of HCG or the trigger? So do you think those kind of standardizations will need to be now done?
Yeah, now there
more
are
standard protocols.
Yes, so at the beginning this was challenging because People wanted to discuss or interpret what results in other studies, and they saw that the definition of time zero starting to compaction, all these differs. But now I think there are several references. It's either we're using the one from ISHRE or the one from SRM or the one published in RBM Online or something like this. So I think now it's a little bit easier, but still we see these differences. That's why also what will be helpful is this automated grading, because automated grading, whether you refer to this or this or this, I know that you will always be consistent, right?
So just on a lighter note, we have about 30 universities in India offering a master's in clinical embryology. And the graduates from these universities, their primary aim is to do ICSI. So with automated ICSI in the very, very near future, what do you want to tell them?
No, I want to say that...
It's a light question.
Yeah,
so
you know, there is difference between being an embryologist and being a lab technician. Both of them are needed. But anybody in the hall, if they want to learn any procedure, they can come spend a couple of days with us in the lab. We will teach them. It doesn't matter. And actually, this is one of the things that we try to implement and instill in our internal network, that doing biopsy, not only a privilege for the lab manager. No, everybody is doing it. It's a training process. All of us, we do it. Technical is very easy, but to have the proper background, to know how to utilize it, how to improve it, how to use it, this is what we need the people to do the masters for. Thank you. Okay. So I go to the next one, right?
You are starting, you want to take a break.
No.
So the next talk is on objective decision making in the IVF laboratory, bringing research and practice.
All right. Thank you very much for the kind introduction. So, yeah, unfortunately, our colleague Sorleen couldn't make it for personal reasons, so we will jump into the next topic, which is, I think it's a perfect timing after your question, because my aim of this presentation is to explain how we should take decisions in the IVF lab, how we can be as scientific as possible, as objective as possible. So let's start with a simple definition of what is a subjective decision. A subjective decision is a decision that is influenced by or based on personal beliefs or feelings rather than based on facts. In our field, what is the opposite of a subjective decision is an evidence-based decision. What does it mean? It means that you need to utilize your experience. You need the best external evidence with patient expectations or what the patient needs. And it's very important, this best scientific evidence, it should be best validated scientific evidence. And in the next few slides, after this example, which would be maybe interesting for physicians, if there are any left, you know, there are many studies. You can read title, conclusion, and assume that you're following a scientific evidence. And the best example is an example Dr. Fatimi gave to me. He told me in 2000, early 2000, when they introduced the antagonist, if we are to decide to use antagonist or not based on scientific evidence, we wouldn't have been where we are today. Because all the first studies, the first couple of years, studies comparing antagonist to agonist, all of them were supposing the agonist. Actually, they showed that there is higher risk, with worse outcomes, the antagonist. Where we are today? Today, most of our cycles are antagonist cycles. Why? Because using scientific evidence is not something published. You say, no, read it, check materials and methods, check population, check the results, see interpretation of result. Does it work well for you? Yes? Okay, follow it. Not how we can improve it. And this is what happened. They found what is the mistake with the first study, second study, third study, and then it's almost always consistent, antagonist is better. So let's apply the same concept in the next few slides. So how I will present this presentation, I want to give you 3 practices in the IVF lab and explain to you, in my opinion, how we can take an objective decision about it. So we're going to talk about the rescue IVM, the extended culture, and about PGTA. So let's start with the rescue IVM. So we've seen this slide with Dr. Fatimi today. The number of eggs is associated with your chances of live birth. the higher the number of eggs, the higher your chances. Correct? We also know that maturation rate of the cycle is also a good representation or associated with your outcome. So even if you collect 15 eggs and you have only one mature, we know that the chances are very low, right? So two facts that we know. The third fact is, we all know that 80 to 85% of our eggs are mature at the metaphase 2 after we do the pickup, and 10 to 15% are what? Immature. So the question that we had in mind, what if these 10 to 15%, if we can do something so that these 10 to 15%, these immature oocytes are the source that we will increase the number of eggs, hoping that we will increase the chances of live birth. And this is not a new idea. The first publications about this were in the 80s, showing live birth from transferring embryos coming from M1 and GV. So it's not new. But what happened after that? A couple of studies. Outcome is not good. We gave up on it until a few years ago. Again, the topic resurfaced again because we thought maybe we have better knowledge, we have better culture conditions, the media is now better. So this is one of the studies that if you compare blastulation rate, just to explain it quickly, the first column is M2. Second one is M1 became M2 the same day. The third column is M1 became M2 the next day, and the last one is GV became M2. And we can clearly see that fertilization rate is lower, but it's relatively good. Cleavage rate is lower, but still okay. Blastulation significantly lower, but it's not zero. So let's look into the design. What are the things that we've seen? Number one, there is no consistency in the protocols. For example, some of these patients, they did fresh transfer. Some of these patients, they transferred the best at the cleavage stage, or they kept the rest for blast. So, it's not very strong. Then you go to the next paper, which is from the group of Evie. And their conclusion is, maturation rate is excellent, fertilization rate, even morphokinetics, euploidy rate is not even different than the M2s. But if you take a look at the design, they included patients less than 38, so younger patients, with a minimum of 4 GVs and a maximum of 6 eggs. Most likely, how often do you see this? A patient less than 38 with 6 eggs, 4 of them are GV. Maybe it's a mistake in the stimulation, right? So I cannot take this outcome and generalize it to all our patients, right? And for physicians and the embryologists, this next day ICSI is a lot of extra cost, a lot of effort. Because it's like you have a full OPU again, right? You need all the resources, ICSI needles, biopsy, culture, oil, all of these things, right? So it's cost and time consuming. So we said, look, we cannot decide based on the evidence. So let's create our own evidence. So what we did is, for 1 year, we did for every single case, next day ICSI, we call it. So any mature oocyte, is it a patient with 1 egg or a patient with 29 eggs and only 1 of them was immature? We extended the culture till the next day. We performed ICSI. We followed with the fertilization, blastulation, and we did PGTA. And we said, look, let's put our evidence and take an objective decision. What we found was consistent with previous literature. So fertilization rate was lower. Okay? Biopsy rate was lower. And is it M1 became M2 or GV became M2? It's the same. Okay? But what we found interesting is euploidy rate was not different. It means if the M1 or the GV became M2 the next day, you inject it, fertilize, it reaches the blastocyst, its chance of being euploid is similar to that of M2. So that was interesting, and that was not presented before. So we said still that doesn't answer our question. Which patients? Because you clearly see that everything is lower, right? Fertilization and blastulation. So to whom I should do it? So what we did is we said, okay, let's divide into contribution to the whole cycle. It means if the whole cycle we ended up having 2 blastocysts, one of them is coming from a GV, then this is 50% contribution. If the patient has 10 embryos, one of them is coming from a GV, then this is 10% contribution, which is fair because it shows the value of the embryo, right? When we did this, what we found is patients who would benefit from the next day ICSI are patients who are of advanced maternal age, more than 37 years old, less than 10 oocytes, less than 34% maturation rate, and less than 60% fertilization rate. Now, more objective decision than this, I don't think we can take, right? So a second example is the extended culture, which is again something about it's a cost for the patient. You need to counsel the patients, and I understand in India it's a decision taken between the physicians and the embryologists. You need to explain it also to the patients. So shall we routinely for all the patients go to day 7, yes or no? This is not our question. This question was out there for a long time now. So let's look into what do we know so far. So we know that day 7 embryos, they have much lower reproductive outcome. And this is from several studies. However, these studies were in fresh embryo transfer. And we can argue, yes, they have much lower outcome because there are 2 days difference between the endometrium and the blastocyst. So what's the solution? Let's try in frozen cycles, right? Maybe then if it's only the asynchrony, maybe we correct it for it. What was the outcome? Again, several studies, day 6, day 7, when they compared day 7 to day 6 or day 7 to day 5, even in the frozen, still the outcome was not, there is live birth, but it's not as good as the day 5 and day 6. So it must be something else. So we thought maybe you have higher aneuploidy rate for the day 7, right? So the solution would be to check what is their euploidy rate. So when we checked for the PGTA, so we did this study in our lab. Also, we extended the culture for all the patients. Any blastocysts that reached the blastocyst biopsiable stage on day 7, we did the biopsy. And then we compared, considering the female age categories, the euploidy rate, and indeed, this is what we found. Day 7 embryos, they have significantly lower euploidy rate compared to day 6 and day 5. It means that somehow I can explain why we have in fresh and in frozen lower outcome, because they have higher aneuploidy rate. It means that I extend the culture, do biopsy. If it's euploid, maybe the results will be more good. What was the challenge here? In order to know if it will reach blastocyst, if it's euploid, you need to extend the culture and you need to do the biopsy, which is the extra cost. So we said, okay, now we can explain, but I still don't know which patient would benefit from this. So what we did is, all the patients that we've done this, we plotted them like a heat map, and we wanted to see which factors were associated with utilizing these day 7. And what we found is, the prevalence or the chance that you use it overall is not a lot. However, one of the most important factor was female age. The second most important is the number of embryos on day 5 and day 6. So now, instead of saying, shall we extend day 7 for all or none? No. Now, we also published this. It's the same way. It's a link. You press, it takes you to the a website. You will put information including the numbers. Okay. So here you have, I will tell you, this is embryo biopsied on day 5. This is the first one. The second one, this is number of embryos biopsied on day 6. This is how many embryos left for extended culture, and this is the female age. The numbers I put is 2 day 5, 2 day 6, 1 day 7 embryo, and female age is 30. And the software gave a probability of benefit of 8.3%. Okay, so for this scenario, 8.3% your chance to benefit from extending the culture to day 7. This is another example. It's the same female age, but instead of day 5, 2, I put 0. Day 6, 2, 0. And then number of embryos left for extended culture, 5. So the same female age. Now, the benefit is 34%. So that's an objective way. You don't need to decide all yes or no or flip a coin. Just you put this information, you will get a percentage, and then at least your decision, whether it will work or not, but at least it's an objective way of doing it. The third example I want to give is PGTA, which is one of the really debatable topics in our field now. So all of these evidence supporting PGTA, right? So if you use any of these studies, all prospective across different age categories, different infertility factors supporting PGTA. So if you want to tell me, yes, PGTA is good, and you use any of these, this is scientific evidence. But again, we want a validated scientific evidence, because science is dynamic. As much as there are studies supporting PGTA, there is also studies against PGTA, or at least showing that there is no benefit of PGTA. So our responsibility in order to take an objective decision is to understand what is the reason for this discrepancy in the results. Why you have two different opinions, all of them with scientific evidence, all of them with good studies. So let's think together. Maybe we draw a conclusion and we see how we can explain these differences. What is involved in any PGT cycle? Patient, stimulation, IVF lab, genetic lab, right? Let's focus on the labs. The genetic lab. Does the genetic lab has an influence on your PGTA results in a way that will affect the outcome? Meaning, if I do with genetic lab A, you do with genetic lab B, could it be that you get good results with PGTA, I don't get good results? This question, several authors, several groups had that questions. One of the studies I like is this by the group of Mina. What she did is very simple. She took 8 providers of genetic testing. And she said, I want to compare for the same population, same female age. I want to compare the euploidy rate, just to see if there are differences. Good? Because each one of them has their own technology, own interpretation, own references, limits, all of these things, right? What she found is, yes, there is differences between the lab, and it's significant. So there are labs reporting much higher euploidy rate than the others. What she did also, she said, okay, let's look into mosaic rate. And she found, again, that there is significant difference between the different genetic labs for the same patient population in reporting mosaicism. But what was interesting is, the lab that reported the highest euploidy rate reported the lowest mosaic rate. It means that for some groups where you go to genetic lab X and you get a diagnosis with as a mosaic, if you just send the same, you've done the same genetic lab, same stimulation, same patient, same cells, we send it to another lab, it would have been euploid. And this brings your attention to how important is your partner or your genetic provider. And in order, the author said, in order just to prove that the reason for this discrepancy is the genetic lab, not the IVF lab, there were a genetic lab that provides the same service for 3 IVF labs. So they said if they have the same euploidy rate, same mosaic rate, it means it's the genetic lab. If they differ, it means it's what they found is it's the genetic lab. Another very good example is the same IVF clinic used 4 different genetic labs. For which population? Donors. Donors, we assume that they have much lower aneuploidy rate, right? And what they found is Lab A reported almost 74% euploidy rate. Lab D reported 52%. And this difference was significant. So the author said it's the same patients, the same IVF lab, the same doctors. The author said it's either that lab A is not good and they are missing some of the abnormalities, that's why we have a lot of euploid, or lab D is over-calling abnormalities and we are throwing away euploid embryos. And the best way to know which scenario is better is to look into live birth rate, their live birth rate with each of these labs. And what they found is lab A that reported the highest euploidy rate also reported the highest live birth rate, which means that genetic lab matters. Now, going to the IVF lab, this is Santiago Monet, they published opposite. They took one genetic lab, different IVF clinics, donor patients. And they found that some genetic labs, some IVF labs reported 3 times more aneuploidy than others. In which population? Donors. Which means the only difference is whatever is happening in the clinic. What can go wrong in the clinic, or what factors can influence this? Your biopsy. This is presented in X-ray showing that if you use a method that depends on the laser compared depends on mechanical cutting, you have here in the higher one, I think this is empty, much higher mosaic rate. This is another study showing that if you make an opening or hatching on day 3 compared to the at time of biopsy, you have higher mosaic rate also when you give the laser shot. So this is not to show that one technique is better than the other, but it's just to show that there is evidence there showing that the biopsy technique in the lab can have an influence. So if someone else publishes a paper, while I don't know which technique they used, how good they are doing the biopsy, how can I rely on these studies? The integrity of the cells, this is something nobody knows, right? We take the biopsy, we see it, we don't write anything on the paper, genetic lab they don't do. They do the amplification, they give us the result. Now, in this paper, they showed that if you have many degenerated cells in this, the piece that we are doing biopsy, it will cause, after amplification, it will look like these embryos are aneuploid. So you are decreasing euploid rate just by sending lower quality embryos. Biopsy pieces. And the explanation is very easy. It's a mechanical, it depends on the use of laser. Laser produces very high temperature that can cause necrosis. Necrosis, unlike the apoptosis, it will produce material that will degrade the DNA. And then when you amplify this degraded DNA, it will look like you're missing chromosomes, but actually it's not. It's only the quality of cells that is bad. Number of cells. I mean, in every single paper about PGTA, it's written in materials and method, 5 to 8 cells were biopsied. These are examples of biopsy pieces that has been taken. Can anybody count the number of cells? We cannot count the number of cells, and yet in every paper we say we biopsied 5 and 8 while we cannot confirm it. Why this is important? Of course it's important because the more cells you biopsy, the happier the genetic lab. They have more DNA to start with, amplification will be better, resolution will be better, you will have excellent results. But the problem is, the more cells you take, the lower your implantation. So it's a very thin line that we need to find to the optimal number of cells that the genetic lab will have enough DNA, and also we will not affect the results. All of these things are not presented in the paper. So how we would know that paper showed no benefit of PGTA because of any of these factors, or really because PGTA is not good? So let's apply the factors that we discussed about PGTA in these two PGTA. This is the non-selection study of Ashley Teagues. So what was the design of this study? They do biopsy for all the embryos, okay, but they don't run the test. They select the embryos based on the quality, they transfer. After they do the transfer, they did the PGTA. And then they compared what was the destiny or what happened with the aneuploid embryos compared to the euploid embryos. So 80% was the starting pregnancy rate for the euploid, 40% for the aneuploid, which is not bad. However, if you take a look at live birth, we ended up with 65% for the euploid embryos and 0% for the embryos that they were aneuploid. Now, what factors we talked about? The genetic lab. The technology that we used here was the most advanced one. It's the targeted NGS, which is very accurate, very good, validated. It was the IVF lab. What they did in the paper, they said in order to prove that the biopsy had no impact on the outcome, they compared the sum of these patients, because they were subject to biopsy, euploid, aneuploid, to all the clinic cycles without PGTA. Okay, because if you don't know the outcome of euploid and aneuploid, this is similar to you didn't perform PGTA, you only did biopsy, right? So they should have, actually, the sum of these should have the same outcome as the embryo that were not subject to biopsy. If they have less, it means the biopsy was not good. What they found is there was no difference between the total live birth of these two groups compared to the group with no PGTA. It means that they safely did the biopsy. Okay. Now, the second study showing that you can get live birth from transferring aneuploid embryos. This is the table. Unfortunately, it's not very clear, but I will read it for you. This is the table where they explain from where they got the live births. So first of all, if you look into the genetic lab, we will see that we have 4 different genetic labs, 3 different technologies. 2 of them we stopped using 7-8 years ago. One very interesting thing is almost all except for one were actually mosaic embryos. And we've just explained how do we get mosaic embryos, right? It's a technical mosaicism, not biological mosaicism. Or simply maybe if you send it to another genetic lab, you would have had a different result. So it's only one aneuploid that resulted in live birth. And this aneuploid it's an AA, has 5 chromosomes affected. So I leave it to you to judge if you want to take an objective decision, would choose which studies will affect your decision. Would you choose this study or that study? So in summary, we need careful interpretation for scientific evidence. So not only refer to a title with a conclusion, you need to see if it works for you, the protocol, or if it fits your population. PGTA is not meant to improve cumulative live birth. It's meant to improve transfer per cycle. Also emotionally, psychologically, less miscarriages for the patient is better. Artificial intelligence and the utilization of artificial intelligence is coming. And the minimum that we need to do now is to clean our data, because at a certain point in the future, the one who has proper data is the one who has leverage. Thank you very much.
Thank you everyone for a wonderful lecture. Any questions?
Nothing.
No? Yeah, we are moving on.
There is one question.
Yeah, Mr. Han.
I think what you try to say here is that there's still a lot of things wrong with the design of studies and the execution of the analyses. Do you feel there needs to be a new area in the IVF lab where, for example, people are taken into account that can really do the computer studies? Because analysis of data is currently not really part of the embryology training, or at least it is an underdeveloped part of it. So seeing this, you really need to have a higher degree in computer science. And how would you see this going towards the future?
Yeah, no, actually you can see this if you look into, for example, in embryology now, most of the PhDs, the thesis is about machine learning and artificial intelligence. I mean, before that it was morphokinetics. So I think the embryologists code the train. We understand that we need to catch up with the technologies. I would not say that to the extent that we will be able to train to do the analysis, because it's something that requires really proper engineering, proper data scientists. It's a teamwork in general, it's not one person. And it's a little bit much, actually not a little bit, it's much more complicated than what we see. And sometimes it's simpler than what we see. So I mean, honestly, what I saw, the trend here, very fancy titles, very fancy names, artificial intelligence, so at the end, it's a simple logistic regression model. So I believe that yes, we should be educated enough in order to differentiate between yes, what is a model, what is machine learning model, what is really artificial intelligence. You know, like anything else, at the beginning, nobody is asking to comprehend it completely, but at least not to give up on it, because we need to build on what we have. My advice is for the embryologist is, yes, you need to be familiar with technology. What we will be able to stand against these machines or is the knowledge. Because the machine will do the XE, but the machine will not decide that this is a patient that is indicated for IVM instead of this, right? So, yeah. Okay. Okay, thank you.
I thank the moderators and our speaker, Mr. Group Director, IVF Lab, for such an insightful. For such an insightful talk on advanced as well as very sensitive and practical aspects of embryology. and that too with a strong evidence-based recommendations, as these play a very significant impact on the success of any assisted reproductive technology outcomes. Thank you. So now we have saved the most exciting panel till the last to discuss the practical nuances from an ART lab. I welcome our highly skilled embryologists, Parita and Akshi, to moderate the panel. I also like to invite our panelists, which includes all our young and energetic embryologists who show equal enthusiasm and responsibility to contribute to the patient's IVF success. I would like to invite Bhagyashree, Ashwini, Aheli Chaudhary, Sanika, Atul, Mr. Ibrahim, and I also request Dr. Rajvi to please participate and contribute to our discussions. Thank you. I think you have to use this. Oh, no, these are working. Yeah. Over to you.
How do you go next? How does this work? Even this is working. It's fine. Okay. Let's start the introduction.
Yeah. So good evening, everyone. Now we are moving on to the embryology panel titled Surroundings, Practical Nuances from an ART Lab. Yeah, so I think the introduction for all the panelists has been done. So first panelist.
Oh, you want to go back? Okay.
First, no?
Yeah.
Yeah, so Dr. Rajvi H. Mehta. She's a senior embryologist carrying 30 years of experience. Next panelist is Ibrahim Al-Khatib, and let me do it. Next. Then we have Bhagyashree from Ahmedabad, Ashwini from Mumbai, Aheli from Chennai, and again Sanika from Mumbai. So in this panel, we'll be discussing and assessing the black box, which contains the various factors that affect the morphokinetics of a human embryo. So these include the sterility, cleanliness of the IVF lab, the air quality maintained in the IVF lab, temperature control, laboratory maintenance by the embryologist, and the techniques and their outcomes.
Right. So let's go to our first case scenario. So you come in one morning, and you have 4 patients in culture currently. The first one is a patient who's just for check. Second and third one are day 3 embryos, and the last one is a blastocyst. So this is what you saw when you took out each of these dishes in the morning check. So there was no similar incidents noted, like all along everything's been fine. And so what do you think is the root cause? What do you think is the action that you have to take immediately, and what precaution can you take to avoid this in the future? Can we start with Ibrahim?
Ibrahim is the last one.
Okay, Ibrahim is the last one. Can we start with Sanika?
Hello? So the immediate action would be to check the remaining droplets for any contamination, and if there are clean droplets, so shift the embryos to the new droplets, wash them thoroughly, and if we have an extra set of fresh dish, so shift it to the new fresh dish.
Okay, anyone else has any other opinions that we can do?
So all these images you see on the same day? It's
Yes.
Not, yeah, okay. So because the image D is already into blast.
Yes.
So the patient infection is ruled out for the D, right? So it can be a gamete handling issue or also the media bottle issue.
Okay.
You also have to check how the media preparation is done and how you are maintaining the quality during the processing, gamete processing.
Surely it appears to be a handling issue. You can't blame the patient here because it's in day 1, day 3, day 5, so that's ruled out. And it's happened in all of them, so it's possibly depending if you're using a single step medium, then very likely something's happened in that during the handling and preparation of the dishes. So it goes back to the embryologist and the handling.
Aheli, what do you think you can do to avoid this? We already know what's happened, so how do you avoid this in the future?
So first, the most important point is aseptic handling, so media preparation using proper gloves and masks, and also to check the media bottle before doing any preparation to check for any cloudiness or any residue in the bottle, and also to make sure that the storage of the media is done properly so that it prevents any chances of contamination. And also the main thing is to check the culture conditions itself, the incubator itself, if there's any contamination within the incubator chambers, or if in case you're using a humidified incubator, then keep clean the incubator, change the humidification flasks and all of that.
So yes, I agree with what Aheli said, that it is clearly the source is from the laboratory. So all the factors we need to rule out that can contribute, starting from embryologist, the air quality of the lab, the laminar airflow, the culture conditions, the consumables, and the media bottle, and a proper training of the embryologist. Again, one of the main part, that how to prepare the media, how to identify that. First of all, this is contamination. That is one important thing, because sometimes these checks are done by a junior and sometimes they fail to report that this is contamination. So identifying and documenting these things, and probably, we have a blastocyst also. So even after washing, when we are using this blastocyst, I feel it is important to document along with your freezing document, and it is important to inform the clinicians also that we have identified such case. And when we transfer such embryos, for example that blastocyst, if we are going to use that blastocyst, then I feel it is again a precautionary measure to keep this in mind.
Ibrahim?
So I think this is the easiest way when it happens to all the patients.
Mhm.
Because these are all the patients, different days, if I understood
Yes.
correct, right? So this will make it easier to eliminate things. So for example, you can check other exi dishes, wash dishes, the things that you don't use. You use HIPPIs, for example, of buffered medium, right? If you don't see contamination, then you can eliminate the oil, for example, right? And I mean, what you will find in common between a day 1, I understood, day 2, day 3, and
Day 5.
blastocyst, right? So it must be 1 or 2 points that you can identify, then you need to eliminate this contamination. But what is interesting for me, because it was half answers, so clearly we need to change, right? We need to change the drops.
Yes.
We need to change the dishes.
Yes.
And I doubt that any of us in the lab, we prepare for 4 patients extra media, right? So in that case, what we will do, we will keep it for how long in and how we will approach it. So this is, I think, for me would be interesting.
So we generally keep extra media always in the incubator, but first, before preparing the new dish, we need to check whether that incubated media is contaminated or not. If yes, so basically, in general, how we approach is always have to have a backup media in our lab. So I think that strategy helps a lot. For example, the same sequential bottle, the entire bottle isn't contaminated, and for emergency purposes, if we keep one step, so we can use maybe that bottle. But then,
oh sorry,
the point is we have to incubate it first.
Yeah, I mean, if it's very urgent, you can gas it, because, for example, in our lab, what we do is we replicate these scenarios. So we assume that this happened with me. So if it happened with me, I need urgently media. This type of media at this temperature, how long do I need to gas it in order to get the pH that we want? Okay, it will cost you some money and time the first time. But then in case of such a case, then you know, for temperature, I need 45 minutes in the incubator. I gas it, I need 1 hour, 1 minute, 20 seconds, for example. But what is important from what she answered, that's why sometimes we invest in things, whether it was in the protocol or in the equipment, that sometimes people, they don't find it logic. That's why we waste a little bit more media, we consume more media than the number of patients, because, you know, yes, it doesn't happen every day, but once it happens, I'm sure all of you will be happier that we are able to,
already
right?
prepared.
Getting an incubator, extra incubator, yes, it's an extra cost. I will not utilize it every day, but when it happens, I'm sure all of us will. So, thank you.
Keeping extra medium is something which is just very logical and rational. It's not too much cost. I mean, in the cycle of IVF, 30, 40 microliters is not going to make any difference. So
Salvaging a patient cycle is more important for us at this time over
and
looking at
also
the
with
cost.
that level of contamination in the blastocyst, yeah, one would be very scared to even transfer that.
Yeah.
You're transferring microbes in there, so you'll have to really wash it and maybe cryo and then see what happens after that. Because a fresh transfer, you're surely getting to get those. I'm going to put in there.
To just ending note, I would also send the media contaminated to the swab, to the testing and the report for the documentation purpose.
Yeah.
Any more addition to the points?
Yep.
Yeah. So moving on to case scenario 2. So we have a lab which is reaching the competence level according to the Vienna consensus in terms of all the KPI. But suddenly the blastocyst development in the last 2 weeks of 1 month drops below the competence value. So we have to discuss the action, the root cause and the precaution. So how will you retrospectively analyze the situation and see and explain to the clinicians when asked?
So as you can see in the first 2 weeks, we have a fertilization rate of around 84-94% and a good blastulation of 65%, 69%. But when we're looking at the third and the fourth week, the blastulation has gone down to 27% and 35%.
Yes. But we also have to notice that we had in the week 1, we had 5 patients and 3 were advanced maternal age. So we have to also put into consideration the age of the patient, and we can discuss all the variables that are involved in making of an embryo or a blastocyst. So we will start with Ibrahim. Okay. Ashwini.
Let's start with Dr. Rajvi this time.
If you talk of advanced maternal age, there's not much difference. It was 5 patients, it's 4 patients week 3. The other one is 8 and 8. So I think the female factor possibly doesn't seem to be the cause. So it seems to be possibly a lab factor. Now I would really like to know about the media. I mean, how long has it been? Has there been osmolarity changes? If you've got a larger volume, you've opened and closed it, so maybe by the end of the month, osmolarity is changed, and that's possibly causing a prevention of blastulation. That's what appears to me more than, I mean, it's something to do with the culture conditions, possibly.
I would also check whether it's the same batch or a different batch of media. If it's a same batch of media, then I would ask for the, if there is a temperature variation while the handling and transportation. I would also check whether the operators, I will compare whether who has done the procedures, and I'll compare the KPIs also accordingly.
Aheli?
So the first thing I will look into is any major changes that has happened in the lab between the 2 weeks, the gap of the first 2 weeks and the last 2 weeks. Is there anything like that, any maintenance work that has been done in the lab, or if any, the daily QC checks that we do, is there any discrepancy between the first 2 weeks and the last 2 weeks? And then I agree with Ashwini ma'am, like to check the batch of the media and the operator who has done the procedure, right from the dish preparation to the ICSI or IVF and the later stages.
Yes, Bhagyashree, what are your views on the same?
Yes, yes, I do agree with what all of them said, that obviously the media and everything, we need to check all the QC factors. Also, I would see how many male factor patients are there in last 2 weeks, because that was not mentioned, because in case we have more TISA cases or the cases with poor
severe OTA,
severe
yeah.
OAT or something like that. That also has to be taken to the consideration, and also for the last week where just one AMA, but then we have to consider the PCO cases also, because sometimes with less cases where we have retrieved more eggs, good fertilization, but then the numbers will outlayer the entire data. So I think we should take into consideration these things as well.
Yes, Ibrahim?
Yeah, nothing actually to add. Maybe just also to check if there is further stimulation in new drugs. Yeah, most of the time, even the maturity rate will indicate if it's patient related or the lab related.
Okay. Right, let's go to the next case scenario. So, we're going to do tubing for a patient we've just done biopsy, and when you start making the drops to wash the sample and for the tube that you're using to send to the genetic lab, this is what you see under the microscope. So what is going to be your first response to this? What do you feel is the reason this happened, and how do you think we can prevent this from happening for the next time? Ashwini?
Yeah, so this is our experience we came across once, but generally we check before biopsy what buffers we are getting to avoid such situations. So it should never happen in the live biopsy. So it is contamination can caused with the poor handling by the genetic lab, geneticist, or while transportation when the temperature is not maintained. So we should always have extra buffers in our lab in case the one of the batch is contaminated, and we should report it immediately.
Dr. Rajvi?
She's covered it. I mean, it's something which we have to be prepared for and not
Right.
accept that everything we get is perfect.
Right.
Yeah, so as a precautionary measure, we would have a meeting with the genetic lab. We would check for the cold chain maintenance, the data logs, and the tubes and the transportation conditions. So next, case scenario 4, that you have just joined as an embryologist at a newly constructed lab at a roadside location on a highway on the ground floor of a 3-floor building with ongoing construction nearby. In the first few ovum pickups, all patients are showing high degeneration, poor quality embryos on day 3, poor quality blastocysts resulting in pregnancy rate of 40%, and from that 50% miscarriage rate. So please, what are the actions and the root cause and the precautions that you would take if you come across such a situation?
Aheli?
Okay, so first thing I would want to know if the lab, after the completion of the construction, if the lab has been validated using mock cultures, and if the outcomes of those mock cultures were adequate and acceptable. The second thing is that there is an ongoing construction nearby, so I would definitely worry about the air quality of the lab. So, and again, VOC systems, the efficacy of the HVAC systems, and also if the proper culture conditions are maintained, so that could explain these poor outcomes.
Sanika, what do you think?
I think proper installation of AHU unit should be looked after, and ICSI table with anti-vibration table setup should be there to avoid any complications in that matter.
Right, so we also look at the KPIs that we had in the lab, like whatever we've discussed previously, that also has to be looked at. We have to make sure that in the next time when you open a lab, you make sure that the site selection is better, if you think that is the reason why this happened. And proper off-gassing and burning in was done for all the instruments. You just don't get everything in and start the next day. There's a protocol that needs to be followed before we start the first stimulation in the lab. And I think everything else our panelists have covered. Next slide, please. Okay, so now you come in one morning, and when you go to thaw your embryos, this is how your liquid nitrogen tank is looking. and there is some ice formation which is there on the lid, and you can see a tiny crack in the wall. So now all the other tanks are okay. Now what are you going to do in this situation? How do you salvage it, and how do you make sure this doesn't happen again in the future? Bhagashri, let's start with you.
Hello. Yes. So this scenario looks like obviously, as you mentioned, the crack because it's a failure of tank. So it's a kind of the scenario which should be reported at high level of incident because it is going to affect the majority of the patients which are being stored in the tank. So immediately, the immediate action would be to shift the embryos to other tank. That is the first action I think any embryologist would do. Second thing would be as a precautionary action would be not to just inspecting the tanks at a particular interval for say like a weekly or 10 days. I would make a system to check the tanks or the liquid nitrogen levels and what are the differences of these liquid nitrogen levels on daily basis. So I think that's kind of a precautionary measure that we can have by just developing a basic system in our labs and to have a schedule of refilling the nitrogen.
So I would like to, So basically the root cause can be the, not monitoring it daily. Also while, handling it physically shifting, it has got damaged and nobody noticed it. That is why we need a monitoring system, which we have, which can also monitor the liquid nitrogen levels. If any deviations in the temperature, it senses it and gives alarm. Secondly, to avoid such situations, we always, when there are more than one cryotops of one patient, it is advisable to split into 2 tanks.
Right.
So in case one damages, we always have the backup something of the patient.
Something for the patient to make sure the cycle does not get cancelled for the patient. This is essential.
Obviously, we have to inform clinician and to the team make an incident report because like Bhageshi said, we have to also because more number of patients
might have been
affected.
Yeah.
So we have to check how much is the damage caused in this leak and
installation of monitoring system to detect nitrogen level if it drops or something like that.
And if you don't have someone, then maybe you can try to talk to someone from your staff. If you have a night watchman, he can just have a look around that everything's okay. Not that he would know much, but some peace of mind at night when you sleep, if nothing else.
Rather than lowering of the liquid nitrogen levels. So, it's more of physical damage or maybe the location of the tank in the room because it's going to be a well ventilated
maybe
room.
because the tank has been there for
a really long
it's
time.
An old tank
wear and
nobody,
tear.
Minutely observed that this crack was happening for a long time.
Next.
Yeah, so case scenario 6 that the lab KPI in terms of fertilization rate suddenly drops significantly to 50% and the degeneration rate increases in 1 week in 2 patients. So following this, the low fertilization is observed in all the patients in the same week. So patient 1 is 32 years of age, AMH 12.18, trigger progesterone value 0.89. So 22% degeneration, 48% fertilization was seen in this patient, and patient second has degeneration of 53% and 47% fert rate. She's 31 years of age, 3.47 AMH and 0.81 trigger FSH. Sorry, P4.
Right. Sanika, tell us, what do you think is the reason for this, and what can you do immediately?
The immediate action would be to check the gas levels of incubators, pH of the media, and batch of media or something like that.
Okay.
So since it happens to all the patient, like you said, I would check the P4 is already mentioned. So I will check the ICSI temperatures, ICSI stage temperatures. Then I'll see at what time all the procedures are done after the trigger time. Generally, when we have the A2 injections, like the A injections, when we see the degeneration, we wait for 1 hour. So we will check these details if it's mentioned on the patient sheet, like if this has been delayed, like we wait and then do ICSI. This is detail. Also the operators who did, whether there's a change of hand helped in such situations.
But would you not look at the patient profile, like the AMH in this patient is 12.18. So she was a case of PC, like highly PCO patient. So this case happened, and up to say 9 out of 17 oocytes degenerated on spot. And you also have to consider, see in the first image, you can see the second polar body. So it's not an immediate degeneration.
Yeah,
in
so
our
I would also look for the morphological abnormalities for the oocytes.
So these two patients fell on the same week, like 2 days apart. And automatically when the degeneration goes high, the fertilization will decrease.
To rule out, the temperature variation, and so that is why the, the routine quality checks play an important role to make sure that to rule out, so the temperature is not an issue.
So Ibrahim, would you like to add something here?
Not really. I wanted just to say that we cannot exclude the patient, but you've just said it because, And also the second part is that you mentioned that after these two patients also it persists, the low fertilization, so it requires investigation.
Right. So we would also look at like the denudation protocol that is being used. At what time are you denuding it post the pickup? Was the stripper that we were using, did that batch of strippers have any defect because of which they're rupturing due to the size of the stripper bore?
Even while the denudation, which diameter you use?
Which diameter? So there are multiple factors that we look into: the ICSI technique, the stage temperature, the denudation technique, the batch of the highs, all of that, the PVP also.
You also look at the suction pump that you're using, the pressure of the suction pump that you're using, the pickup needle that you're using, the gauge of the pickup needle, is it deformed as well? And the injections as well. Is there any cold chain issue with the injection drugs as well?
Okay. So the next scenario is of a 39-year-old female with AMH 0.3 who underwent 2 pooling plus PGTA cycle. She has a history of a pregnancy which she medically terminated and 1 previous FET failure without PGTA. So review her case and the genetic report, and how would you
Right. So how do you counsel this patient, and what would you recommend to her how to proceed forward?
Yeah, so first cycle we had on the left side 1,5 BB grade embryo which came aneuploid trisomy 22, and second one was a BA embryo complex aneuploid mono 22 tri 19 and 21. This was her first cycle. So she had to underwent another cycle. In that we had 2 embryos, 5 BB and 5 BC. One came aneuploid and the other one came non-informative, which was a 5 BC embryo. So Ibrahim, how would you proceed?
We will rebiopsy the non-informative.
The non-informative.
Yeah, and what did you say the first one? One of them had multiple abnormalities,
yes, multiple.
Right? But one of them was 21, right?
22.
22.
No, 22 was whole chromosome.
This is 22, this embryo.
And here, yes, the other one is complex, including 21.
BA1.
Yeah, but that one we will rebiopsy
is a
the
clear
second case.
aneuploid monosomy.
The non-informative, we need to rebiopsy.
Right. So we would also look at the grade of the embryo and see if it has enough trophectoderm cells for a rebiopsy, because if it's a BC and we don't know how many cells will be left to do a rebiopsy and then do implantation as well. Plus the technique of biopsy, the way that the flicking was done, like Ibrahim already explained in his PPT, and the quality of the cells that we tubed. All of these are also important when we look at how biopsy can affect the outcomes. And next slide. So this is our last case scenario. So you have a team of 2 embryologists and 1 embryology technician. There is a sudden increase in cases from 30 pickups per month to 65 pickups per month. And the IVF lab team is working consecutively for 12 to 15 days without a break because the increased caseload. And we're putting in at least 10 to 12 hours daily to cope up with the lab work and paperwork that is involved and match the timelines. And the team is expected to deliver good outcomes which they were delivering earlier. And we have to match it, but we're feeling pressured and overwhelmed. not we as in all of us here.
I have to take this question.
Yes.
So you consider 65 OPUs per month a sudden increase? So it's an average of 2 per day, 3 if you exclude weekends. I think with the proper time management, how many you have? 2 embryologists and 1 andrologist. These 2 plus 1 more embryologist, one of them can go for annual leave. So it's all about, look, and this is what we see and what we learned with Dr. Fatemi, it's a teamwork.
Yeah.
If your physicians understands this, and they know that, you cannot do 3 procedures at the same time because you're only 2, and they put, for example, 1 hour in between the pickups, that's more than enough. You can do the denudation, you can do ICSI within this 1 hour. If they understand that in this period, maybe we cannot put 5 pickups with a TC case, okay. So it's all about the timing, and I promise you, if you do proper planning, by 3 o'clock, all of you will leave with the 3 OPUs a day, and a warming, and a freezing, it's okay. This is not what you expected from me, right?
No, Ashwini, would you like to add something here?
No, the big boss said everything.
I gave this answer because we're running out of time.
Okay. Right, so we just want more teamwork, we want more discussions, and we want an open discussion with the clinical team, like he said as well. And the lab team itself has to also communicate to avoid any miscommunication. And yeah, we have to have a healthy lab environment. Yeah. So yes, and we avoid weekends if possible.
One thing is, don't get stressed out, because the moment you say, oh my God, you finished, your mind has stopped working. So the thing is, like 2 per day is manageable.
2 per day.
So when you start
if you're
your
well
work, your work
organized,
is
you have
half
a good
done
flow
already.
chart of what you're planning to do and discuss it with your co-embryologist,
yeah.
and then it can be planned out well.
Yeah.
So any clinician wants to add something here? No, I don't
Right.
think. Yeah.
It's like. So what we see from this panel and the discussions we have and this entire section that we have on surroundings is there are a number of factors which an embryo needs to thrive. The embryologist, the culture conditions, the pH, osmolarity, the gas levels that we have, the person who does the media setup, and all of this is together one thing that we need is all of this together to make it work. Next slide, please. And we have to understand that there is only one thing that is truly important in an IVF lab, that is everything. So none of these things can be skipped if we want a patient to have a good cycle, and everything that we do from our side is the best that we do as embryologists.
Thank you.
Thank you, panelists. Thank you, audience, for listening to us this late in the evening.
So this concludes our incredible academic feast. Now I request Dr. Richa Jagatab to deliver vote of thanks.
I thank all of you for persisting with us. I won't take any more time. Just really heartfelt thanks for making this Congress such a success. I had thought it'll be half of what it is, but it's been an amazing Sunday spent in great deliberations and with a great company. Thank you so much, everybody. And group picture, please, over here.